Thank you all. Please be seated. As we officially begin today's scientific summit, every successful event starts with words of welcome that bring together the purpose and vision behind the gathering. It's now my pleasure to invite a person who has been an important part of the organization and someone who continuously contributes towards the growth and progress of our institution, our founder and chairman, Dr. E. Arunachalam, to deliver the welcome address and formally welcome all our distinguished faculty members, delegates, and guests present here today. I welcome you, sir.
Good morning, everybody. First of all, I welcome all of you, all the speakers, delegates, and moderators, chairpersons who have traveled all the way. Dr. Harish from Bangalore, Dr. Shanmugam from Chennai, Shanmugavel sir, Veni madam, and Shokma sir, and all those who travel from Madurai, Trichy to this conference. See, actually, it's not the matter of doing advanced techniques like laser angioplasty or this OCT in the hospital and treating the patients. It is, we have to disseminate the knowledge in 3-tier cities. With that only we started ACCeSS 1, which was very successful with almost 270 delegates a couple of years back. So this is mainly, we want the conference, which are state conferences, which are done only in big cities. We have to bring them to 3-tier cities. That is the only thing. So I will not stand between the speakers. So I welcome all of you and have a good session. Thank you.
Thank you, sir, for your warm words of welcome and certainly for a wonderful evening for today's event. And we truly appreciate your great words. As we begin our today's event session, we start with a topic that's highly relevant across multiple scenarios. Perioperative management of hyperglycemia. Managing blood glucose during the perioperative peak remains one of the most aspects of patient care, especially improving certain outcomes and complications. To guide this important scientific session, we are honored to have a highly respected clinician who are here as hyperglycemics. So I request Dr. Sundar sir, the surgeon cardiologist, I have a category. And I kindly request the moderators, Dr. Sundar sir, and Dr. Vinarajima, and Dr. Vicky sir, to be the moderators. It's now my privilege to introduce a distinguished faculty for the session, Dr. E. Shanmugam. Dr. Shanmugam is a highly respected lead in the field of biology and intervention and has dedicated nearly 2 decades of his professional career to advanced diabetes care and metabolic disease management. He completed his MBBS from Tamil Nadu Engineering University in 1998. Further strengthening his expertise in diabetes care, he completed his diploma in diabetes in 2004, followed by MD in diabetes from prestigious College in 2008. He is currently practicing in Street College, Hospital, and serves as senior consultant neurologist at Chennai Diabetes Specialty Center, Chennai. In his academic career, he also served as professor and head of Dr. Ambedkar Institute of Diabetes from Deepak Medical College, where he played an important role in teaching at very future medical professions. I kindly welcome you, sir.
treated in hospital patients comes under any one of these three categories. One is known type 2 diabetes, or previously unknown or undetected diabetes, or stress hyperglycemia. This is most important. We can simply diagnose, differentiate in between these three by simple history and by doing HbA1c. So if HbA1c is normal, sugar is still elevated, you can say that patient is having stress hyperglycemia. If it is HbA1c is very high, history doesn't know.
Is quite high for stress hypertension patient than the non-type 2 diabetic patients admitted for inheritance. Why this is quite high for stress hypertension than with non-diabetes with uncontrolled diabetic patients? We all know that any stress event will elevate the pulmonary hormones. So even non-diabetic patients, if the stress is severe enough, it will impact the sepsis, MI, stroke. If it is severe enough to cause stress hyperglycemia, it means that the impact is so severe. That is why the stress hyperglycemia patients have more worse outcome than non-diabetic having uncontrolled hyperglycemia. So we should have carefully deal the patients. If a patient with stress hyperglycemia, the mortality rate is quite high compared to non-diabetic and controlled diabetes. So always set a job in managing the patients. There are so many factors in the there are so many factors will reduce the blood sugar. The factors will elevate the sugar will be stress hyperglycemia. Whatever the cause you are admitted for the patient, even for simple surgery, patient might have stress. And discontinuation of outpatient regimen will elevate the sugar and IV food is whatever I should see you. Even though the patient will elevate stressors, steroids, vasopressors, reduced physical activity, and fear of hypoglycemia. This is about our patients we don't go with high doses. That is the reasons for high blood sugar in the patients. And there is a chances for hypoglycemia as well. Because low nutrition, because patient admitted for the hospital cannot eat food, and meal interruptions, we go for frequent procedures, we go for CT scan, ultrasound, the patient put the patient on NPO, and insulin statin, frequent insulin initiation happening sometimes, and other mental stress, particularly depression, anxiety, all these things will alter the blood sugar levels. The main goal of diabetes management in the inpatient setup will be smoothing the roller coaster. It is always a roller coaster. So up and down will be expected. So how smooth you are maintaining the glycemia, this is the main aim of maintaining a glycemic status in inpatient setup. We all know that hyperglycemia will so many damages by inflammation, endothelial dysfunction, and all the interleukin 6, all the creatine of all these things will be elevated. At the same time, hypoglycemia also dangerous. Hypoglycemia will induce, due to prolongation, it can induce arrhythmia, sudden death. So both the way hypo and hyper are dangerous to our inpatient setup. So what is the recommendations we do have? How much we need to maintain blood sugar levels? This is about international recommendations. American Diabetic Association and American Association of Clinical Endocrinology do recommend that maintain a blood sugar of levels of 140 to 180. In between 140 to 180 is well maintained. If any blood sugar more than 180, you have to initiate treatment. At the same time, you should not go levels less than 110. So not recommended to maintain blood sugar of less than 110. Acceptable for very stable patients, you can able to maintain 110 to 140 in the ICU setting. So as an average, the recommended blood sugar in the ICU setting will be 140 to 180. We doesn't want less than 100 in ICU settings. And in non-ICU as well, the fasting blood sugar will be less than 140. At the same time, 100 to 140 will be ideal, either pre-meal or in the fasting state, or the post-meal state, or in the random blood sugar, it should be less than 180. This is what the recommendation for non-ICU setting. So ICU 140 to 180. In non-ICU, you can able to maintain 100 to 180. It means that in non-ICU, most of the patients are unstable, so you can go slightly lower than the ICU setting. So what about Indian guidelines? We do have Indian guidelines. Indian guidelines also suggest the same about ICU 140 to 180.
non-ICU around 100 to 180. This is what the recommendations for ICU blood sugar levels in ICU and non-ICU. So what about point of care? We cannot able to do blood sugar random venous blood sugar every time. We cannot adjust the dose. This is internationally accepted. It is recommended to do blood sugar levels with glucometers. So point of care glucometers are internationally accepted. In ICU, you can do once in an hour, once in half an hour, or once in 2 hours, depending upon the patient's status. If the patient is on infusion, you have to monitor the blood sugar once in an hour. If this patient is stable, you can monitor the patient's blood sugar around 4 to 6 hours. In a non-ICU patients, stable patients, every pre-meal you just do the sugar accordingly. You can go with the medications. What about CGM? CGM is everywhere we are using CGM now in non-hospitalized patients. Can we use CGM in hospitalized patients? There are so many studies are available. Whenever we are using CGM, there's one point we have to address this MARD. What is MARD? MARD is mean absolute relative difference. It means that the difference between the glucometer and the CGM value. If the difference is huge, more than 15%, we cannot use this. This is the concern about CGM in hospitals. There are only 9 studies in hospital patients. Among the 9 inpatient studies, many studies suggest that MARD mean absolute relative difference in hypoglycemia range is more than 50. That is why CGM is not at all recommended in inpatient setup. International bodies are not recommending, but during COVID period we do use because we cannot able to approach the patients with the glucometer. During COVID it has been approved and accepted. Nowadays it is not approved to use CGM in hospital patients. But the concern about CGM will be the hypoglycemia. Many times CGM will detect wrong hypoglycemia. We tend to over treat the patient. So always fingertip confirmation is mandatory before treating hypoglycemia if a patient is on CGM. Not only in an hospital, also in outpatient setup also, don't go with CGM based hypoglycemia always. So insulin is always gold standard. We all know that insulin is anti-inflammatory, insulin will improve healing, insulin is anti-infective, it also have a rapid action. It's a precise titration can be done here. This is well-known safety. It is 100 years we are using insulin safety. Efficacy has been well documented and well proven. And this is what the normal physiology of insulin secretion happening. For every meal, there is a prandial insulin secretion, and 24 hours we do have a basal insulin secretion. We want to mimic the same of basal and prandial insulin secretion in inpatient setup also, so that we can have a normal physiological insulin secretion response, so that the blood sugar response will be plateau, almost flat sugar over a period of time. And types of insulin regimens available will be basal bolus or continuous IV insulin or basal plus. Let's see one by one. And this is what the basal bolus therapy. Every 3 times we go with, every meal we go with short acting insulin or conventional regular insulin also can be used. So before breakfast one insulin, regular or aspart or lispro, short acting insulin. Before lunch also we are going for short acting insulin. Before dinner also one short acting insulin. And bedtime long acting insulin, Glargine, Jetimer or intermediate acting insulin NPX also be given here in inpatient setup. One simple formula for treating type 1 or type 2 diabetic will be with the insulin will be, we should know about pharmacokinetics and pharmacokinetics of insulin. If you know about pharmacodynamics of insulin, you can treat any diabetic patients with the help of insulin. As there is one simple slide, we know that what are the insulin types are available. We know basal insulin, prandial insulins are available, and the normal pharmacokinetics of basal insulin, regular insulin will be, the onset will be half an hour, peak will be 2 to 3 hours, duration will be 4 to 6 hours. In other means, if you given a regular insulin in the morning breakfast, what time you have to do the sugar? Morning breakfast, you have given the short acting insulin. So many PGs are here. PGs should answer this. Morning blood sugar, morning 8 o'clock, you have done the fasting blood sugar. You are given the regular insulin. What time you check the sugar, whether to know, to assess that the blood sugar, the insulin, whatever you have given is worked or not. What time? Before lunch. So this duration, up to the duration, you have to wait. Don't do the sugar after 1 hour, 2 hours, and increase the dose of insulin. Doesn't mean that insulin will not work. Insulin will work up to 4 duration of action. In the other words, this is a fasting patient. If a fasting is 140, You are given 5 units of regular insulin, and before lunch, blood sugar is 140. What it mean by? You are given 5 units, patient had 3 ETs, you are given 5 units, fasting is 140, pre-lunch is also 140. What it mean by? Whatever insulin you are given is sufficient enough for the breakfast size. So next day, they same breakfast, you can give the same insulin. No need to adjust the dose. If it is fasting is 140, the blood sugar is 100, what do you mean by? It is overactive. So we need to reduce the dose of insulin. Not to the either you can reduce the dose in the next dose or in the next day morning. At the same time you can reduce the dose. And if it is fasting is 140, full noon is 180, what do you mean by? We have to increase the dose in the next time. This whatever insulin we are given is not sufficient enough. So any insulin you should keep in mind that pharmacokinetics, peak, duration, and onset. So if you understand that, you can see this insulin worked or not, whether to increase the dose of insulin or reduce the dose of insulin, you can simply assess that. This is about analog, short-acting analogs, the same. Duration will be 3 to 4 hours. This is intermediate acting insulin we commonly use in our government hospitals. NPH insulin onset will be 1 to 2 hours, peak will be 4 to 6 hours, duration will be 8 to 12 hours. The same NPH insulin, if you given it the NPH insulin in the morning, what time you do the sugar? What time you do the sugar for NPH? It works for 8 to 12 hours. So you should check the sugar in the evening. So evening blood sugar is 140. Same time, whatever you are given 8 units of NPH in the morning, fasting is 140, evening is also 140. It means that they taken care of the lunch peak. The peak will be 3 to 4 hours. During the lunch only it takes peak. So the lunch peak it has been taken care of the insulin NPH. So no need to change the NPH in the next day. Same way if sugars comes down, we have to reduce. If sugars are going up, we have to increase those. So just understand the duration, peak, onset. You can be able to adjust the dose of insulin, whether to increase or whether to decrease the dose of insulin. So all only one thing about Glargine and Lantus, long-acting insulin, which work for 48 to 72 hours, the dose adjustment can be done once in after 3 days, not every day. So practice says teachers only after 3 days. So don't increase the dose every day by doing just fasting blood sugar. So after 3 days only we have to adjust the dose of long-acting, particularly taking the or you can go if you are going with the long tree and the you have to adjust the dose once in 3 days. So it is very simple to use insulin. Just understand how it works. Short-acting insulin how it works, intermediate acting how it works, or ultra-short-acting insulin how it works, retinol how it works, Glargine how it works, ultra-long-acting retinol how it works. So if you understand the pharmacokinetics, you can be able to understand how the insulin works. So basal insulin, the 24 hours basal insulin will address the fasting plasma glucose. It will address the hepatic glucose output. So the fasting will be
Whenever you want to have a good fasting, you should put the patient on either on NPH or on Glargine or Detimar or Degludec. But don't increase the dose of regular insulin to bring down your fasting. So whenever you want to have a fasting plasma glucose, always rely on NPH or with Glargine. This is bolus dose. Whenever the post meal is going up, you have to go with prandial doses. So insulin orders in hospital, whenever any nurses or your house surgeons asking for your sugar orders, this much sugar, what insulin I have to give. So there are 5 questions you have to ask before giving insulin orders to any patients. First question is, who is the patient? Which is outpatient regimen? How well the control sugar is needed? What is the current glucose levels? When the patient to eat? Why the patient is admitted for? So based upon the 5 questions only, you have to adjust the dose of insulin or you have to give the insulin orders. So who is the patient? If it is patient is type 1 or type 2, type 1 absolute insulin deficiency. You have to give some amount of insulin. If you are not giving insulin, patient will develop decay. You always keep in mind that. So in type 2, patient have some reserve insulin reserve, whether you are giving or not, patient can able to manage it, they won't go for decay. So if your patient is type 1, don't stop insulin, at least half of the dose of insulin you should give. Which is outpatient regimen, whether patient is on oral regimen or insulin regimen or combination. If sugars are well controlled, we can keep continuing the same dose of insulin. If patient is on oral drugs, what drugs patient is on? Whether the patient is on sulfurias, if the requirement of insulin will be quite high. If a patient is on metformin alone, the requirement will be very low. So depending upon the previous drug, you can decide about insulin. And how well you want to control the sugar, whether you want to bring down the blood sugar of less than 6.5, 7 or 8, whether dealing with geriatric patient or pediatric patient or with adult, whatever the HbA1c target we want, what is the blood sugar target, 140 or 180 or less than 110, what is the baseline HbA1c? If a HbA1c is baseline is 6.5, already whatever insulin or tablet he is taking is adequate enough, slight modification is needed. If your HbA1c is quite high, you have to aggressively treat the patient. What is the current status, blood sugar levels? Whether if it is more than 300, whether you need insulin infusion or not, whether the patient is more than 250, always check ketone. Whenever you come across blood sugar more than 250 or 300, check ketone once. Unless you ask for ketones, we never diagnose DKA. And whether the patient is NPO or full diet. If it is NPO, type 1, definitely you have to give insulin. If a patient is NPO, type 2, no need of insulin. What is the patient admitted for? If a patient is admitted for sepsis, we need to have aggressive control. If a patient is admitted for atrial fibrillation, or if a patient admitted for some stroke, if you tightly control the patient, hypoglycemic symptoms cannot be detected. So if hypoglycemia can be aggravate the arrhythmias. So what condition patient has been admitted for. So all these conditions, all these questions has to be addressed whenever we are giving for insulin orders for our type 2 diabetic patients. This is very easy to manage in patients with sliding scale insulin. Sliding scale insulin, you have seen that whenever blood sugar 150, don't give insulin. 150 to 200, 4 units, 200 to 250, 8 units, 250 to 300, 8 units. This is quite easy. But the problem here with this insulin is, whenever blood sugar is less than 100, you don't give insulin. Whenever blood sugar reaches 250, you give insulin. Here you will give insulin. Then blood sugar will come down, you don't give. Then after lunch, blood sugar go up, you will give insulin after lunch. Before evening, sugar will come down, you don't give insulin. Before dinner, you don't give insulin. After dinner, blood sugar go up, you will give insulin. This is what the sliding scale. So fasting will be normal. As per the sliding scale, no insulin. If it is fasting, it's normal. So you do postprandial, blood sugar will be 250 or 350, you give insulin, then blood sugar will come down. This is the problem with the sliding scale will be, there will be hyperglycemia and hypoglycemia. So instead of bringing down the blood sugar, we are inducing hyper and hypo with sliding scale insulin. So this one point, if you understand that, this is the best way of managing the inpatient management. Don't go for sliding scale therapy for any type 1 or type 2 diabetic patients admitted for inpatient setup. So don't go for the greatest cause of high glycemic variability, ups and downs will be sliding scale insulin. The ADA also do recommend that sliding scale insulin is a sole regimen should be strongly discouraged in hospitalized patients. Never go for sliding scale insulin therapy. So sliding scale insulin therapy should not act a proactive way. So you have to think that whether the patient is eating or not, whether the blood sugar will go or not, accordingly you have to go with the insulin. After the blood sugar going up, you are giving insulin, no purpose of giving insulin. So IV insulin protocol, there are so many protocols available. The well-known famous protocol will be AL-IV insulin protocol. I don't want to explain that. It is available in internet. You can see that it is a fixed protocol, no need to adjust the dose. And this is quite challenging, that transition from IV insulin to subcutaneous insulin. So once patient is stable, able to eat properly, you can slightly change over to subcutaneous insulin. How to change over to subcutaneous insulin? Just calculate total daily dose and divided into 50% for basal insulin, another 50% for prandial insulin, the same prandial insulin divided into 1/3, 1/3, 1/3, simple way. So total daily dose, how much required? If it is total daily dose is required will be 60 units, 30 will be basal, another 30 will be prandial, another 30 of prandial, morning 10, afternoon 10, night 10. So this is what the calculating daily dose, and there is a correction factor is also available. Whenever, as per our expectation, blood sugars are not coming down, we can go with the correction factor. The formula for correction factor will be 1800 divided by total daily dose. How much value you will get it? If it is 40 units of daily dose, 1800 divided by 40, 45 grams of blood sugar will come down with 1 unit of sugar, 1 unit of insulin. So this is simple calculation. Whenever you need it, you can go with this correcting factor. So special situation, whenever patient is on nil per mouth. So in case of type 1 diabetes, should not stop insulin. If case of type 2 diabetes, the insulin requirement is quite low, we can manage without insulin or just monitor the patients. Whenever sugars are going up, you can go with long-acting basal insulin whenever patient is on nil per mouth. And parenteral nutrition, whenever a patient is on continuous tube feed, you can go with basal insulin or bolus tube, another 2 minutes. Bolus insulin, you can go with short-acting insulin. And total parenteral nutrition, patient is on total parenteral, you can give insulin with the total parenteral nutrition itself, or routine basal bolus therapy also be applicable here with whenever patient is on total parenteral nutrition. Steroid-induced hyperglycemia, thing is that glucose peaks 4 to 8 hours after steroid. Whenever you are giving steroid, particularly if you are giving steroid in the morning, the blood sugar peak will happen post-lunch or pre-lunch. So always with the steroid, better to control with NPH insulin. If you are giving only on morning steroid, always keep in mind that steroid will suppress HPA axis, hypothalamic pituitary axis, adrenal axis. The chances of early morning hypoglycemia is quite high whenever patient is on steroid more than a week. So always keep that, always preferable to use NPH in the morning, less dose in the night so that you can avoid hypoglycemia. And role of oral hypoglycemic agents, generally not recommended, but we do use oral hypoglycemic agents in the current scenario. Particularly, we are comfortable with DPP-4 inhibitors. That too, there are so much studies are available. Sitagliptin studies are available. Linagliptin DEAN trial is available. The reduced insulin requirement will be reduced by 30 to 40%. So during COVID, we have comfortably used DPP-4 inhibitors. We know that linagliptin can be given for CKD patient or cardiac failure patients or whatever, chronic liver disease patients. So without seeing a patient, if at all you want to give one drug, you can comfortably give linagliptin. So if a patient is stable or if a patient is very mild hyperglycemia, you can go with linagliptin. Even without insulin, I am practicing that. Patients are comfortable with linagliptin. So whenever patient is mild to moderate hyperglycemia, stable patients, you can always go with DPP-4 inhibitors. So when to not use OHS, metformin obviously we don't use. SGLT inhibitors we have to stop 3 to 4 days because of weak glycemic ketoacidosis. The GLP-1 receptor agonist also you have to stop 1 week before. And sulfurias, sometimes we can go with shock-acting sulfurias, particularly glycoside can be used in inpatient setup. So discharge plan has to be started whenever patient is admitted for, on the first day itself we have to plan for discharge. The simple way of planning discharge will be if your HbA1c is 7, continue the same regimen, 8, add one more drug. If it is 9 or 10, you have to intensify the therapy before discharge. So based upon HbA1c, you can plan for the discharge advice. So that this is 2 tools are available. We are in the artificial intelligence era. There are 2 approved tools by US FDA, LikeTech and EndoTool, which help us to manage inpatient setup. So if you just feed it, just blood sugar, you can feed it. It tells us how much insulin you need to give. It is simply amazing tool. It is available in US. Hopefully we'll also get it in India soon. And key takeaways from my talk will be insulin is the cornerstone for inpatient glycemic management. Target is 140 to 180 for all our type 2 diabetic patients. And DPP-4 inhibitors have a role, particularly sitagliptin and linagliptin can be used in safe and mild to moderate patients, hyperglycemic patients, and adjust for special situations, NPO status, steroids, total parenteral nutrition. During surgery, perioperatively, we have to intervene according to the individualized patients. Discharge planning start on the first day. Don't plan for a discharge just on the discharge day. Once a patient admitted, plan for discharge. What drug I have to give for this patient during discharge? Thank you for your patient listening.
Thank you very much, Doctor, for that extremely insightful and highly informative presentation. The clarity with which you explained this important topic and the practical clinic experience you shared has certainly added valuable learning for all of us present here today. We sincerely appreciate your contribution to today's scientific summit. Every scientific presentation becomes even more meaningful when enriched by clinical observation. At this moment, may I request our respected chairperson, Dr. S. Sundaram, to kindly share your few valuable observations.
Thank you, sir, for your excellent presentation. Being a surgeon, and we face this diabetes problem very frequently. What we have been following was the sliding scale which you have condemned. But practically, it's very difficult to get the physician opinion every 4th hour or 6th hour as the blood sugars which we used to do. So in such cases, what is the via media? If you can come out with some guidelines where the staff nurses can, along with the duty PG, can implement something to keep the glycemic control.
Yes, sir.
So what we have been following is the sliding scale up to 200, no insulin. Thereafter, for every 50, we give 5 units plain insulin. So that was what was being followed at least for the initial 3-4 days. Thereafter, we send the patient to the physician for opinion, and they give a standard regimen.
So, thanks to COVID, because of COVID only, the government of India and our NMC has approved telemedicine. So, with the telemedicine, now need of physicians to visit every day to your clinic. Your hospital, just one day is enough for physician to understand what is the glycemic status, how much insulin is required. So, we can get the orders from through telemedicine itself. Either duty doctor or that staff nurse can call their physicians. And the 4 things has to be informed to the any physicians whenever we are getting insulin orders. What for patient admitted, what is the current HbA1c, what is the creatinine levels. This is most important. If creatinine levels are quite high, the chances of hypoglycemia is quite high. So if what is the creatinine level, what is the intake, what for admitted. Just 4 questions, any physician can able to give orders emergency wise. And once the patient, they are free, they can come and see the patient. Just one day observation is sufficient enough physician. Then you can give a fixed orders. This is amount needed. Whenever sugars are going up, you can go with this correction dose. This is simple way to manage. But you have, every hospital have a standalone physician for them. So you can get the orders from the physicians. That is the easy way, sir. Telemedicine is approved now. So no need to visit every hospital every now and then, every 4 hours. Just need to see the patient and give your orders. Not at all needed, sir, nowadays.
During TPN transmission, whether separate insulin is necessary or add, which is better, add in the TPN itself?
So usually I do add insulin in the TPN itself, sir. Most of the TPNs, we have a standard formula that 1 unit of insulin will neutralize 3 grams of glucose. That is why 5D we are adding 8 units. So 8 into 3, 24 grams will come. In DNS, 25 grams of glucose. 5% DNS means 100 ml, 5 grams. So 500 ml, 25 grams of insulin is available. 8 units is sufficient enough for neutralize the DNS. Same TPN, just see that package, how much glucose is available. Most of the time, the glucose level in the TPN will be 150 or 130, depending upon the brand we use. So I preferable to use TPN insulin with the TPN itself. Many a time what will problem is patient is in TPN, staff nurse will stop TPN for some other purpose. They will go for some CT or MRI, they stop. If you given insulin subcutaneously, they will develop hypoglycemia. And they will restart once again. In the midnight, they will restart. That is the problem. So always I prefer to go with insulin along with the TPN. So whenever TPN color is going, sugar, insulin also going along with the sugar will be well maintained.
Thank you so much, sir. And I request the moderators to deliver a few words.
Sir, one last question, sir. So, we are operating a patient and the patient is a diabetic who is coming for surgery. Whether all the patients need to be changed to insulin and proceed for surgery, or does OHS itself is enough for that surgery and you can start that OHS after post-operative period? So,
yes, obviously, it doesn't mean that all the patients should be changed to insulin. Depending upon the procedure, if you are going for simple procedure, minor procedure without general anesthesia, immediately you can start with oral diet. We never stop insulin for cataract surgery. We never initiate insulin for cataract surgery. Simple sub-ACCeSS excision, lipoma excision doesn't need that. But keep in mind that whatever drug patient had before should not cause hypoglycemia during the NPO period. So if a patient on sulfurias, if you put on patient on NPO since morning to evening, because of procedure, patient may develop hypoglycemia. Why we prefer insulin is, insulin we can able to see how much insulin we are giving, how much sugar will be respond, how much time it will work. If you give short-acting insulin, I know that it works only for 4 hours. If patient will not develop hypoglycemia after 4 hours, that surety I can able to give that. That is why we prefer insulin for even for simple cases. But you can go with OHAs. You can stop OHA one day before. On the day of surgery, based on the blood sugar, you can go with short-acting insulin. Once oral diet has been started, change over to OHA. If it is HbA1c, is perfectly normal.
For major cases, shall we continue that insulin for 1 month until the healing completely occurs, and then we'll shift it to OHS?
Yes, this is what happening, but major cases we switch over to insulin straight away. And sometimes if a patient is obese, markedly insulin resistance, we need to add on sulfurias or some drugs like DPP4 inhibitors along with the insulin post-operatively. Ultimately, blood sugar has to be come down. Patient should be on some amount of insulin to have anti-inflammatory, better healing effect and anti-infective effect. At the same time, if your insulin is not sufficient enough to bring down the sugar, by simple adding linagliptin or sitagliptin, you can able to reduce the total dose of insulin by 30 to 40%. So instead of increasing the dose furthermore, add simple linagliptin or teneligliptin. If a patient is stable, patient is able to eat properly, you can add OHA along with the insulin. And this is a way to bring down the sugar, better glycemic control, and at the same time planning for discharge or switching over to OHA also quite helpful.
Thank you, sir.
Thank you so much, sir. And it was really a very great session to hear from you. So thank you, sir. We now continue to our next session. So we continue to the next session of our scientific summit. So we start with another extremely important topic, that is management of septic shock. So the management of septic shock remains one of the biggest challenges in the critical care medicine, where timely decisions and evidence-based medicine directly impact the patient's survival. For this important academic discussion, we are honored to have our experienced clinicians for guiding today's session. And I now welcome our chairperson, Dr. Ilango, sir. Thank you so much, sir. And I request Dr. Arunachalam, sir, V. Arunachalam, sir, and Dr. J. Saravanan, sir, to be the moderators for the session. I warmly welcome you all. And thank you, doctors, for joining the session and supporting today's scientific summit. And now, I'm bound to introduce the speaker of the session, our distinguished speaker, Dr. Harish Malapura Maheshwarappa. Dr. Harish is widely recognized in the field of critical care medicine and has built an outstanding professional career dedicated to the intensive care management and advanced treatment of critically ill patients. He completed MBBS, MD, DNB, and IDCCM, followed by the highly specialized DM in critical care medicine. Further strengthening his academic credentials, he has completed EDIC, the European Diploma in Intensive Care Medicine, Fellowship in Infectious Disease, MBA in Hospital Administration, and FIARC Fellowship. He currently serves as the Director, Institute of Critical Care Medicine at Kaveri Hospitals, Bengaluru. Over the years, he has developed extensive expertise in critical care medicine, severe infection management, septic shock management, ICU care, and management of the multi-organ failure. We are honored to have such an accomplished expert with us today. Thank you for joining us, sir. With a great pleasure, I invite you to kindly begin your presentation. Thank you.
Good morning, all. So this managing sepsis and septic shock, in the last 2-3 decades, lots of changes happened. So from diagnostic criteria, there are lots of therapeutic options available. There are lots of prognostication indicators available for septic shock management. But if you see, even currently also the mortality because of septic shock in a very good tertiary quaternary care center is also around 40-50%. Again, the mortality increases with the increase in severity and all. So how early we are able to diagnose? So like how in brain, how in heart attack we have the time linked prognostication, morbidity and mortality. Even in sepsis, septic shock also. So there was a data almost 2 decades back published. So each hour delay in giving an appropriate antibiotic for a septic shock patient, so increases the mortality by about 8 to 10%. So the idea here, why we have lots of changes in terms of the diagnostic like criteria for sepsis, because we want to screen them, we want to early diagnose so that we can initiate the early therapy so that we can reduce the overall morbidity and mortality. So we'll take you through one of the common case like which we face in any of the tertiary care center or maybe secondary care center. So these kind of patients are very common. So then we'll try to discuss how we can manage this patient, what evidence evolved in terms of lots of therapeutic options and all. So he's a 50-year male patient shifted to ICU with tachypnea. So his respiratory rate is 60 per minute, tachycardia. So decrease in urine output. His intake was around 3 liter. His output is hardly 350 ml. So on examination, he was conscious, cooperative, well oriented. So his heart rate is 145, sinus tachycardia. So blood pressure 130/87. So he was having a fever of 101 degrees Fahrenheit. So chest bilateral clear, so saturating around 98% with a minimal oxygen, that is around 3 liter of oxygen. So one significant past history was an uncontrolled diabetes since almost 10 years. So he was a chronic ethanolic almost since 30 years. So these are common cases we face in any of the ICU. So middle-aged gentleman, so presented with tachycardia, tachypnea, normal blood pressure, fever, decrease in urine output with the background of uncontrolled diabetes and comorbidity of chronic ethanolic. Okay. So what is your diagnosis? So is he having a sepsis? So is he having a severe sepsis, septic shock, multi-organ dysfunction, or is having something called systemic inflammatory response syndrome, what is known as the SIRS kind of this one. So what previous confusion was, so we are having something called SIRS criteria like temperature, heart rate, respiratory rate, so like WBC count. So with a particular cutoff, so if anything satisfied 2 criteria, we tag them as having a SIRS. So SIRS with some proven source or a suspected source, maybe like lung as a source, skin soft tissue as a source, we call it as a sepsis. So sepsis with 1 or more organ dysfunction, we tagged it as a like severe sepsis. So severe sepsis with a persistent hypotension with a like systolic pressure less than 90, even after giving a sufficient fluid and is requiring a norepinephrine, we tagged him as having a septic shock. So we know that, so this is the same spectrum with a different severity and that of the different morbidity and mortality. But the problem was, so there are some clinical conditions. So there is an overlap. So we know that, so trauma, pancreatitis, burns, hemorrhage. So there is a inflammatory surge. They can also have some sort of the fever, even in a elective post-surgical patient, myocardial infarction, pulmonary embolism, head injury. So all these patients can have fever, high WBC count, tachycardia, tachypnea and all. So are we dealing with a sepsis? There is lots of overlapping. So that's why we got some like redefined criteria almost a decade back. So what we call it as sepsis 3 definition. So Q sepsis and all. So what they have done, okay, what like if patient is having some sort of like tachypnea, altered mental condition, so under low blood pressure, so any of these 2, we label them as having a sepsis. Okay. So if patient is admitted already, assume patient is on the floor, he came for some sort of road traffic accident. So how to diagnose the sepsis? So they have given something called SOFA score. So if the SOFA score increase from the baseline by more than 2, in an admitted patient, you diagnose the patient is having a sepsis kind of this one. So but the problem was, see I told in sepsis, we need a early diagnosis. We need a very good screening tool. So screening tool should be highly sensitive, so that we are not able to like miss any of the patient. But the problem here, they included only respiratory rate, altered sensorium and systolic blood pressure. So assume patient is having a loose motion, neutropenic, okay, he might not mount the like some sort of any tachypnea to begin with, but he is having a fever. So are we able to rule out he is not having a sepsis? So So still these only 3 criteria, we are having a lots of limitation. We are going to have a problem with missing many of the patient if you use the QSOFA and sepsis 3 diagnosis and all. So later we got something called early warning sign, okay, modified early warning score and all. So which currently what we practice, okay, in and around respiratory rate, fever, so blood pressure, WBC count, okay, so cold temperature, so mottling, all those things together, we got something called early warning signs or maybe modified early warning signs, so which is having a very good sensitivity so that the chance of missing, so chance of delayed diagnosis is going to be reduced if you use some sort of early warning sign. This is the current acceptance, okay. So coming back to our patient, so middle-aged male, so with the background of uncontrolled diabetes, ethanol, tachycardia, tachypnea, normal blood pressure, decrease in urine output, we got some sort of investigation report. His HB is 9.7, WBC is 27,000, so platelet 1.2 lakh, creatinine we got 4.7, urea is 112, there is a mild transaminitis, so ECG echo is normal, his urine shows 40 to 50 pus cells with a proteinuria 2+. So what is happening to our patient? So middle-aged male, so this is the investigation report we got. So I told, so if a patient is having an organ dysfunction, is straight away fit into severe sepsis according to the previous diagnostic criteria. So he's already having a creatinine of 4.7. Okay, platelet is compromised. Platelet is also one of the organ system. So our vascular system basically. So compromised creatinine with a high urea, so obviously is having an organ dysfunction with a high WBC count with background of uncontrolled diabetes. So if you see, according to like previous diagnostic criteria is fitting straight away into severe sepsis. So never early warning signs he fit into sepsis, okay. What next? So what is bothering in our patient? So patient is badly tachycardia. So even though blood pressure is maintained, so his respiratory rate is 60 per minute, okay. So obviously in a patient who is having a sepsis, when respiratory effort increases, the respiratory muscle oxygen consumption is going to be exponentially high. So we need to reduce the work of breathing, so that we have to take care on a priority in our like middle-aged gentleman. So what is the cause of tachypnea here? It is a supply-demand mismatch. So because of the inflammatory surge, so there is a demand increase in the body, so that to match that one, so there is a more and more like respiratory work is happening. What we done? We initiated the non-invasive ventilation. So remember, whenever we start a patient on NIV, we should have some clarity. So when to put a full stop for NIV, when we need to take a call on intubating a particular patient and all. So there are some criteria. So you ask the patient subjectively, are you feeling better now? If you express, I am now better, now I am feeling good, so something is helping, so NIV you might take a call on continuing. So then you take care of some objective criteria, see his respiratory rate, axillary muscle usage, whether is altered sensorium, sweating is there, so that is the objective criteria. So then one biochemical criteria, what you need to do is, like in the next 30 minutes, do an ABG. What we done in our middle-aged gentleman, we done the ABG, it shows a pH of 7.07, PCO2 is 28, bicarb is 10, lactate is 14, PO2 is 114 with a 3 liter of oxygen on NIV mask. So what's happening here? Are you comfortable to continue the patient on NIV when patient is having a severe metabolic acidosis? Here, so there are two components for metabolic acidosis. One is a diabetic, maybe you might be having some sort of ketones. So sepsis is there. So lactate of 14 is the cause for high anion gap metabolic acidosis with the background of kidney injury. So all these things together will kick off is anion gap. It is an high anion gap metabolic acidosis. So it's deteriorating. So it's tachypnic. So obviously we are not able to continue the NIV. We need to put a full stop, take care of his airway with the endotracheal intubation and mechanical ventilation. So this is what happened in the last 2-3 decades, okay. We have something called bundles. So basically these bundles made our job easy. See, the components of the bundle all are equal and all are important like that. It is an all or none phenomenon. It's not a checklist, okay, like 20 checklist. Even in the checklist, if you miss 2-3 component, outcome may not change. but bundle component, you need to follow everything to have a reduction in the morbidity and mortality. We started with the 24-hour bundle, 12-hour bundle, 6-hour, 3-hour, now we have a 1-hour bundle, which means measure lactate as a priority, which gives a clue for your way of resuscitation. So obtain the blood culture before giving the broad spectrum antibiotic, administer the antibiotic, administer IV fluid at least 30 ml per kg if you are the primary receiver of the patient, apply the vasopressor, preferably norepinephrine if your fluid alone is not helping to improve the mean arterial pressure of more than 65 and all. So that is what we call it as 1-hour bundle, which we follow currently in the management of the sepsis. Okay. So coming back to our patient, so on NIV, he become more and more tachypneic, restless, he started pulling the NIV mask. So we intubated the patient and started him on the mechanical ventilation. So what next? So we have taken care some sort of the management of our particular patient. So next is like giving an antibiotic. So remember, like you need to take preferably the culture before giving the antibiotic. But if it is taking logistically too much time in collecting the culture, don't wait. Give a antibiotic if patient is having a septic shock and all. So basically, so what culture you need to take? One, source specific. If you are suspecting a community acquired pneumonia, skin soft tissue infection, meningitis, that is a one source specific culture, and blood culture is the common for all patients who are having a sepsis and septic shock and all. So remember, the volume of the blood which you send for culture analysis gives the yield of your bacterial identification. So don't compromise, lesser the volume, so less chance you are going to get the culture positivity. If we see the overall positivity rate for blood culture itself is around 30%. When you send less, so then the yield is going to be a problematic, so then you are not able to escalate or de-escalate, so depending upon the culture sensitivity. So at least 2 sets, if you are suspecting infective endocarditis, 3 sets, at least around 20 ml you need to send the blood culture as the blood volume. So broad spectrum antibiotic, how to choose? It depends upon what organism you are suspecting, gram negative, gram positive, so anaerobic organism, what organ system is involved, okay, what antibiotic patient already received in the community, what is his immune status, what is his organ dysfunction, whether he is having some sort of liver dysfunction or like renal dysfunction, accordingly you have to choose the antibiotic and all. So first dose of antibiotic, it is always full dosage, don't compromise the dosage. So with sepsis, seconds counts, this is what I told, each hour delay increases the mortality by about 8 to 10%, okay. So remember, so antibiotic, now the probability of your sepsis, septic shock is more, give the antibiotic within 1 hour. But if you are having a mixed pathology, you are not sure about septic shock, you can wait before jumping on giving antibiotics, because we want to avoid the over usage and the drug resistance of the antibiotic and all. So again, source specific antibiotic in our particular patient. So one, urinary quinolone leoflox we added. So piperacin tazobactam has been started because we suspected a community acquired urosepsis. Primary organism we want to cover is the E. coli. So remember, so this is very, very important, pharmacokinetics, pharmacodynamics of antibiotic. Suppose most of the common antibiotic which we use are beta-lactam group of antibiotic, like carbapenems. So your Magnex 4, piperacin tazobactam, they are all water soluble. You need to infuse them over a period of 3 hours. So otherwise, even if you give meropenem over 30 minutes push and all, it's not going to work, because it acts by something called time dependent killing. So that's why you need to understand PKPD of antibiotics, which antibiotic you are giving, okay. So remember, there was a concept of therapeutic drug monitoring, so to optimize the antibiotic dosage, but still we don't have access in all the setup in Indian scenario. We need to wait for TDM to be assessed and all. So what next? If patient is persistently having hypotension after giving 20 to 30 ml of fluid also, so then you need to define, so what is your mean arterial pressure target? Remember, so 65 MAP is sufficient if a patient is not having a CKD, okay. So 65 MAP is more than enough. Don't jump on so infusing too much of fluid and all. So your overall management roam around like this, okay. So initially you stabilize, salvage, organ support, then the last phase we call it as a de-escalation. Very, very important. So de-escalation is not only for stopping the antibiotic. Remember, so when you give lots of fluid bolus during the resuscitation, accumulated fluid balance after 2-3 days increases the morbidity and mortality. So in that scenario, you should take care with some sort of diuresis when the patient is adequately satisfied with the perfusion markers and all. So again, some evidence, crystalloid or colloid. So no doubt, so crystalloid is the choice for fluid resuscitation. So lots of clinical trial we have. So the landmark trial, ACCeSS trial, if you use colloid, so hydroxyethyl starch, more chance of renal injury, more chance of requirement of renal replacement therapy, more chance of death rate. So that's why colloid is out in terms of the managing sepsis. It is the crystalloid. So among the crystalloid, which one to use? Balanced crystalloid. Either a ringer lactate, ringer acetate is the option when it comes to choosing the crystalloid. So not your normal saline and all, because normal saline, chloride is the culprit. So chloride increases the normal anion gap like acidosis. So chloride decreases the renal perfusion and more chance of the requirement of renal replacement therapy. As I told, so MAP requirement of around 65 is sufficient. So don't try to use dopamine and all. So norepinephrine is the first choice for your septic shock management. So dopamine increases tachycardia, tachyarrhythmia, even in a patient who is having a cardiac dysfunction background. So dopamine increases the mortality when you use in a septic shock patient and all. So again, what about the vasopressin? Always in septic patient, there is something called relative vasopressin insufficiency will be there. As a second option, when NORAD is in a moderate dosage, you can add vasopressin as a fixed dosage kind of this one. So is there any choice for angiotensin 2 which is not available, but maybe in the future we can look for this molecule in terms of using as a salvage therapy when your norepinephrine or vasopressin is not helping. So what MAP to target? This is what I told. This is a famous sepsis PAM trial. So targeting high MAP beyond 70, 80 and all unnecessarily increases the tachycardia, tachyarrhythmia. So 65 MAP is sufficient. Okay. So is there any role for central venous oxygen saturation? No role. So we had lots of clinical trials. So in terms of early goal directed therapy, so they used a cutoff of central venous oxygen saturation. See, if you go back to 2 decades back, so they were thinking septic shock patient need a hemoglobin of around 10. Give the blood and all. Give them the dobutamine to improve the contractility and all. So that concept is not there. What we follow is accelerated goal directed therapy. This is what we need to do, not the early goal directed therapy, because so this process arise promise trial. If you use blood to keep the HbF more than 10 or hematocrit to keep more than 35, unnecessarily your transfusion risk will increases, add to the cost, okay, without any major benefit. So that's why it is out to follow any sort of early goal directed therapy. So lactate, SCO2, PCO2 gap, so these are something which we started using in the last decade as a global markers of the perfusion to guide our resuscitation. So that is what's happening in terms of the resuscitation goal and all. So lots of things happened in microcirculatory method also. We used something called orthogonal polarization spectrum to understand whether blood circulation is happening at the capillary level or not. So this technology is also evolving, but we need more and more data. So coming back to our patient, so basically we done a CT for our middle-aged male who is having a urosepsis. So this is what we got, contrast CT. So right sided is having a emphysematous pyelonephritis. So what next is still deteriorating. So immediately we have taken him for the intervention radiology. Pictile catheter inserted, around 1 liter of pus has been drained. So his NORAD requirement went up to 0.5 mics per kg per minute. So he's been brought back to ICU, continued on the management. So what next? Is there any role of steroid? Is deteriorating? So again, definitely yes. So there is a relative adrenal insufficiency in patient with septic shock. We can use oral 200 milligram of steroid, hydrocortisone in a 24 hour. So preferably as an infusion, but the lack of infusion pump, you can go by 50 milligram Q 6 hourly. So again, there are lots of trial. So clinical data is available in terms of using steroid for a septic shock patient and all. So this is something which we used before COVID, something called Murrick's protocol, like a magic bullet. Give vitamin C, high dosage, steroid, thiamine for all septic shock patient and all. So then we learned lots of criticism, lots of evidence is available. Even the recent evidence shows high dose vitamin C can increase the morbidity and mortality. So only you can use steroid
in an indicated patient, or thiamine in a patient with a background of malnutrition, or if he is having a ethanol background. So otherwise not to give thiamine and vitamin C for all the patient and all. Is there any role for methylene blue? We know that so methylene blue is having some potency to improve your vasomotor tone, but the problem is we don't have a evidence in a larger study to suggest so methylene blue is going to be helpful in septic shock patient and all. So as we already discussed glycemic control 140 to 180, lots of clinical trial, NICE, YSAP. So Vanderburg 1 and 2 trial so clearly suggest we don't want a tight glycemic control in septic shock patient and all. So lung protective ventilation with the like preferably ideal body weight, go for 6 ml per kg with adequate PEEP. So that also helps in reducing the morbidity and mortality. So coming back to our patient in the next 72 hours. So after pictile, whatever we sent, it shows E. coli. So we escalated, which was sensitive to miro, imipenem and amikacin. So his WBC count is 77,000. So his creat is 3.5. Still urea is 112. So his procalcitonin we done, it is out of range. Okay, so we started him on meropenem and colistin. So his initial antibiotic has been like stopped, but still his NORAD requirement is increasing, his PF ratio is worsened, his glycemic control is poor, is not tolerating the feed, is agitated, high rails tube aspirate, is still on ventilator. So what next? So there are lots of like data is available with a multiplex PCR, because see, remember we are living in the era something called carbapenem resistant enterobacteriaceae and all. What we do, the conventional culture will not give what genetic pattern of resistance patient is having. We are having a huge burden in India, something called metallo-beta-lactamases. For that, we need a molecular diagnostics and all. There are lots of technology available. So for molecular diagnostic to understand. So remember, we done a pictile for our patient, but the problem is still deteriorating. So you need to search, is there any option to optimally control the source, what we call it as a 4Ds, okay? So definitive control is needed. What we done, in spite of his worsening clinical status, he's been pushed for the surgery, right-sided nephrectomy has been done. So in the next 24 hours, is off support, his urine output improved, his acidosis settled. In the another next 2-3 days, we were able to wean from the ventilator and send the patient to home. So without like any sequelae of his septic shock management and all. So lots of available advanced therapeutics for sepsis like blood purification and all. So, but we still have a lag of data. This is what we need to do in overall septic shock patient, like what we call it as a sepsis 6. So remember, lots of things gone out. So in terms of goal-directed therapy, dopamine, okay. So lots of things came in, lots of things are still in the criticism. That is how we can manage septic shock in the current era. Thank you all. So any questions?
So thank you so much for the session, sir. And we'll have the discussion later. So now I request the speakers of the previous session and this session, and the chairpersons, the moderators of the previous 2 sessions to the stage for felicitation.
Sir, discussions will close up. Sir, any questions can be just put. It's a very interesting. After that, we'll have that. So, chairpersons, moderators, any questions?
So, thank you for your very well presented case presentation. You are managing both the things, the case study as well as the theory background behind this septic shock. But if you are starting in this scenario, if you are starting noradrenaline for this patient for hypertension, what about the role of renal dopamine? Because once in the olden days, we used to start the patient on renal dose of dopamine because the patient is for a long time in a profound hypotension. To improve the renal perfusion, we used to give a renal dose of dopamine. So do you have any experience in this context, whether the renal dopamine dose in order to increase the renal perfusion will be helpful in the presence of noradrenaline?
See, basically, dopamine, maybe in the last 20 years, 15 years at least, it is out in the sepsis management.
So lots of data available. So when I started, maybe before my DMC, I'm the first MCA recognized DM critical care medicine in India. So I done almost 14 years back. So before that I done some fellowship and all. Since then, maybe in the 15 years, we never used dopamine. So the problem is the division of your dopamine on D receptors, dopamine on beta 2 receptor for cardiac contractility. Last dosage, like 8 to 10 mics, we classified it as a alpha receptor activity for constricting the blood vessel and all. So that itself is a myth. So lots of data is available. The segregation in a particular patient based on a particular dosage as a renal, cardiac and alpha receptor to improve the BP, that concept is not there. Because, so they have done lots of, within the patient itself, the clarity and in terms of the demarcation is not exist. So that is one thing. So again, like we got a one major landmark trial. So in terms of comparing dopamine with that of the norepinephrine, that is called SOAP2 trial. SOAP2 trial. So those patients whom added with the dopamine, so more chance of tachycardia, tachyarrhythmia in whatever the dosage, whether it is a renal dosage, cardiac dosage or vasopressor dosage, that is alpha receptor dosage and all. So more chance of mortality, increase of the death, even in a patients who are having a cardiac comorbidity and all. So dopamine, lots of meta-analysis later after this SOAP2 trial showed it is totally out in terms of the sepsis management and all. So only thing is, there is a small narrow indication for dopamine in management of sepsis. Assume you have a scenario, septic shock with a persistent bradycardia. Maybe heart rate is like 46, 50 and all. Then you can have an option for dopamine, that too as a trial in terms of whether it will help in improving both BP and that of the heart rate. Otherwise, by and large, it is out because lots of, there are some sort of animal studies, molecular studies. So dopamine, other than this tachycardia, tachyarrhythmia, it also having an impact on the prolactin. It also modulated the immune system in a bad way. So all these things came in the last decades, dopamine is out. Maybe dobutamine in a selected patient we can use. Selected patient, there is something called sepsis-induced cardiomyopathy. So sepsis-induced cardiomyopathy is a global hypokinesia of the heart. Okay. So there are three things you need to see. If patient is adequately filled with the fluid, means he should not be volume depleted. You have a echo finding which shows global hypokinesia, contractility is compromised. Still there is an ongoing hypoperfusion, means his peripheries are cold, his lactate is increasing, so his urine output is low, is having a mottling, is having an altered sensorium. So adequately filled, cardiac dysfunction is there, ongoing hypoperfusion is there, then we can use dobutamine as a trial drug of trial. Because after starting the dobutamine, if his heart rate increases by 20 from the baseline, because dobutamine will act on both beta 1 and beta 2 receptor. So beta 1 improve the contractility, beta 2 is a vasodilatation, reflex tachycardia will happen. So if heart rate increases by more than 20 from the baseline, or if your mean arterial pressure drop by more than 20% from the baseline, dobutamine also you can't continue. So NARAD fairly fit into all scenario in patients with septic shock.
Thank you, sir.
Thank you.
Thank you so much, sir. I now request the speakers and the moderators and the chairperson of session 1 to the stage. I request Dr. Shanmugam, sir. I request Dr. Sundaram, sir. I request Dr. Somasundaram, sir. Meena Ranjani, ma'am, and Dr. Vignesh, sir, to the stage. And now, as a token of gratitude, like I request Dr. Arunachalam, sir, to give the memento to the speakers. Dr. Shanmugam, sir. I now request Dr. Madhavan, sir, and Dr. Ramasubramanian, sir, to the stage to felicitate the moderators and the chairperson. Thank you so much, sir. Thank you so much, sir. And I request the speaker, Dr. Harish, sir, to the stage for felicitation. And I request the chairperson, Dr. Ilango, sir, Dr. Arunachalam, sir, and Dr. Saravanan, sir, to the stage. I request Dr. Mohan, sir, to the stage. So as a token of gratitude, Dr. Arunachalam, sir, is giving a small token of love to Dr. Speaker Harish, sir. I request Dr. Mohan, sir, to felicitate the chairperson, the moderator. Thank you so much, sir. So as we continue to the session, so I request Dr. Sivakumar, sir, as a speaker, and I request Dr. Subramanian, sir, and Dr. Rama Subramanian, sir, to chair the next session. And I also request Dr. Vijay Dhanaraj, sir, and Dr. Badri Srinivasan, sir, to be the moderators for the session. So at this moment, the next session is on fluid overload, AKI, and heart failure, navigating the cardiorenal axis. At this moment, I may warmly welcome a respected speaker, Dr. Sivakumar, sir. He completed his MBBS in 1996, MD General Medicine in Madurai Medical College, and DM in Nephrology in Sri Ramachandra Medical College. He has a very strong clinical expertise in the advanced renal medicine and management of complex kidney-related cases. I welcome you, sir. Over to you, sir. Thank you.
Good morning, all. At the outset, I thank Dr. Arunachalam, sir, and organizing team for giving me the wonderful opportunity to meet my friends as well as the august audience of this Tirunelveli Thoothukudi area. Next one. The topic today is a cardiorenal syndrome. It's not a new entity, actually. So we know that one vital organ definitely affects the next vital organ's functions, we know. So why we are giving so much importance to this cardiorenal syndrome at present is because nowadays the people are living longer, and two major diseases like hypertension and diabetes is almost India is a pandemic. Really, we are facing a pandemic. We are heading the world. It's a diabetic capital, hypertension capital of the world. So the end organ damages due to this particular two diseases, as well as the other diseases, which affects two important organs. Next slide, please. It's not operating properly. It's running on its own. So come to the first slide, please. So now the topic today is a fluid overload, acute kidney injury, heart failure. What is the the relation network between the cardio and renal axis. Next one. So Dr. Richard Bright, who is the father of the nephrology, in 1800, he come out with the observation, 1836. He has done few patients died due to renal disease. In the postmortem examination, he has observed that both the kidneys are small, but heart is enlarged. This is the first observation made at early years. So 2 centuries before, the physician who has observed that there is a relation between heart and kidney. That is small kidneys, but large heart. So he is the Richard Bright, father of nephrology. Next one. So I can put it like this. The heart is like a husband, kidneys is like a wife. Okay, if a happy marriage is going on, no issues. If suppose there is a problem with the husband and subsequently the wife is started suffering, that is called cardiorenal syndrome type 1. If it is chronic, it's a type 2. The cardiorenal syndrome, it's type 3 and type 4, where the wife, primarily the problem is with the wife, that is in the kidneys. Secondly, getting affected, the kidneys, the heart is getting affected, that is a CRS3 and CRS4. CRS5 is both husband and wife is having a problem, like a sepsis, like a diabetes, it's like that. So to easily remember that CRS1, that's the topic I'm going to discuss, that is acute heart failure scenario, how it tilts the balance of the kidney function, and how we are going to manage. What are the newer understanding in this area? That is the acute heart failure that produces the kidney dysfunction. That's the CRS1, newer understanding, and what is the newer pathogenetic mechanisms, and what are the newer ways to counter it. Next one. CRS history in the early 2000, the term cardiorenal syndrome emerged. 2008, first consensus definition arises, and then 2012, the European Society guidelines that gives some classification type 1 to 5. And present scenario, the more importance given to this newer pathogenetic mechanisms and newer drugs. Next one. This is the 5 types I have told you. CRS type 1, it's acute heart failure that produces kidney dysfunction. CRS type 2, it's a chronic heart failure that produces kidney dysfunction. The cardiorenal syndrome type 3, where the primary problem is in the kidney, that is acute kidney failure that produces heart failure. And type 4 is a chronic kidney disease that produces heart issues. And type 5, both organ primarily is getting affected. Next one. The cardiorenal syndrome, 1% of the adults, 40 to 50% of the heart failure patients, they are fitting with this category. Next one. So coming to this cardiorenal syndrome, it represents a vulnerable subset of patients with high mortality and morbidity. That's the most important thing. Next one. The previous hypothesis, there are a lot of pathogenetic mechanisms. The previous hypothesis is it's a low cardiac output theory. Okay? So that's why the dopamine, dobutamine, and then other inotrophs and other things comes in. But the latest understanding here is it's a congestion. That is the primary pathogenetic mechanism behind the acute heart failure that produces renal dysfunction. So it's a congestion that increases the venous pressure, it's a key driver, and subsequent there is the complex neurohormonal as well as the neuroendocrine hemodynamic factors follows that cascade. Next one. So this congestion at the level of glomerulus, that produces venous congestion that increases the interstitial pressure and increases the lymphatic washout of proteins and decreases the interstitial oncotic pressure and increase the sodium chloride reabsorption. By this various mechanism, the net filtration pressure, it decreases, subsequently the glomerular filtration, the single nephron GFR drops. So this is the pathogenetic mechanism. At crucial point of time, up to certain days, it is reversible. That's the most important thing. It is reversible as a physician. So we are having a patient at ICU, having acute heart failure, we can completely give a remedy to this particular pathology. Next one. So venous congestion over low flow, The increased central venous pressure directly impairs the glomerular filtration rate by reducing the transglomerular pressure gradient. It's an independent predictor of mortality. That is the latest understanding of this particular entity. Next one. The CVP as well as the AAP above 12 millimeter are now recognized as the primary drivers. Next one. So coming to the therapy, next one. So there are two pillars of CRS management. One is decongestion, another one is the GDMT. That is a guideline directed medical therapy. What are they? We will see one by one. Next. The decongestion is, if there is a situation like that, the loop diuretics. Next line is the loop diuretic. The starting dose is, it's a rule of thumb, that is whatever the patient already having, for example, patient on 20 milligram of Lasix or 10 milligram torsemide, then you have to double the dose. That is the rule of thumb. The starting dose will be like that. So 20 to 40 milligram of furosemide or equivalent intravesically we have to give. Starting dose 1 to 2 times, and you have to monitor. Next one. So the drugs relieving venous congestion is loop diuretic, like furosemide or torsemide or other drugs like SGLT2 inhibitors or vasodilators can be tried. The SGLT2 inhibitors, we will see it later. Vasodilators also some situations, if the hemodynamic stability is there, we can consider. Next one. So here, after giving a starting dose and starting dose of the thing, then we have to evaluate whether the diuretic is working or not. How we have to, clinically at bedside, we have to see after 6 hours, you have to measure the urine output. If the 6 hours urine output is more than 100 to 150 ml per hour, then the diuretic is working. Other way is urine spot sodium. If it is more than 50 to 70 milliequivalents, then your drugs is working. Then we have to continue the same dosage. Next one. Suppose if there is no response, the evaluation that shows there is a reduced urine output, that is 1.5 ml per kg per hour. That is the expected response from a diuretic. If it is not there, then you have to double the dosage of diuretic. Okay, you have to double the dosage of diuretic, or you have to go for a add-on diuretics. So you have to go for a sequential nephron blockade. The next step you have to go for it. Next one. Next one. Next one. So coming to the comparison between the torsemide and furosemide. So torsemide, we know it's a highly potent loop diuretic what at present we are having. So 1 milligram is equivalent to 2 milligram of furosemide. That is the usual dosage we know. But in acute heart failure settings, most of the time, the intravenous modality mode is concerned, the IV furosemide is most of the time we are using than torsemide. That's the thing. But you are going to discharge the patient, that point of time you can consider torsemide as a tablet. But in acute setting, most of the time we are considering furosemide. The torsemide, the hypokalemia risk is slightly lower, and the dosage already I told, furosemide 40 milligram is equal to torsemide 20 milligram. For IV, it's roughly furosemide 20 milligrams, torsemide 10 milligram IV. Next one. This is the comparison between the both drugs, torsemide versus furosemide. There is the torsemide did not reduce the all-cause mortality compared with the furosemide. So it's a neck-to-neck comparison. It's not showing any the difference between these two drugs. Next one. So almost the primary outcome of all-cause mortality is same. So it's not advantageous to have a torsemide. Next one. So applying dose trial, it starts with the usual dosage, that is IV furosemide 20 to 40 milligram. Assess the response by the urine output, symptoms, weight loss, electrolytes, and titrate. Non-responders increase by 2 into 2.5 times, and responders continue or just maintain the euvolemia. Consider infusion if there is a resistance or hypotension risk is there. Next one. So let's come to the furosemide bolus or infusion. Which one is best? So bolus, many times in my own clinical experience, bolus many times it's very useful in these clinical settings. It's a rapid effect, short duration, even 80 milligram of IV push over a period of 6 to 12 hours, we can use it. And risk hypotension or electrolysis may be there. And infusion, it has a sustained diuresis, less rebound, sodium retention, and 5 to 20 milligram per hour after loading dose may improve the diuresis in resistant cases. So those trial that shows that no clear win tailored to patient response. So in clinical practice, in acute heart failure settings, when the patient is having a shock, cardiogenic shock, so where we can consider many times in Apollo ICU, I have succeeded with the IV furosemide infusion. Just loading 60 milligram or 80 milligram and put it as a 4 to 6 milligram per hour. And then we trying to make the patients come out with the need of dialysis or ultrafiltration. Many a times we have succeeded in that. Next one. Diuretic resistance. This is the one known entity which is very common in this clinical scenario. So you have to diagnose within 6 hours, we have to assess the diuretic resistance. The one newer update in this area is serum chloride. In this situation, if you have a low serum chloride, hypochloremia is emerged as a critical marker of diuretic resistance. It's the latest understanding, one more clinical point. Next. So next one. So strategies to counter diuretic resistance. What are the strategies? So there are a lot of strategies are there, right? But the most important useful thing is a sequential nephron blockade. So drugs are very much available in this therapeutic armamentarium as a treating physician. When to use, where to use, how to use. That's the trick of trade we have to know. Next one. Sequential nephronal blockade. Come next. So these are the things. This is a nephron map. Step 1 is we are using a loop diuretic. The step 2, we can use thiazide diuretics. So we act as the different level. The mechanism is different. It blocks the sodium chloride transporter like a metolazone. Thiazide-like diuretic can be used. It potentiates the diuretic effect because the loop diuretic, which acts as the proximal convoluted tubule, that is, it blocks the sodium, potassium, 2-chloride transporters. There is the increased delivery of sodium to the distal tubules. Okay, so when you are using another drug at the later part of the tubules, distal part of the tubules, the efficacy of the diuresis, we can get it more and more. That's this ideology. The step 3 is a potassium sparing diuretic. So like a spironolactone, eplerenone, amyloidoid, we can use it because it acts at the level of the collecting tubules. Next. So double therapy as a sequential nephronal blockade, double therapy or triple therapy can be tried. So double therapy is a loop plus thiazide or thiazide-like diuretic. Triple therapy is loop plus thiazide or plus a potassium sparing diuretic. Next. Next slide, please. So metolazone dosage 2.5 to 5 milligram given 30 to 60 minutes before loop diuretic. Why before? It allows metolazone to act to the distal tubules when loop diuretic increases potassium, sodium delivery. So another one trick of trade that metolazone should be given just prior to, half an hour prior to the furosemide. Frequency, usually once daily, and monitor the electrolytes and the volume status. Next one. So the MRA, that is the mineralocorticoid receptor antagonist. So there are 3 generation of drugs comes in. First spironolactone, next eplerenone. The third drug right now we are having is a finerenone. Next one. Next one. So another one is the braking phenomena. It's a body's adaptive response to chronic diuretic use. Again, you can use the most important methodology to counter this is you have to restrict the sodium restriction. That's the most important thing. And combination of diuretics, consider ultrafiltration resistance. Next one. Braking phenomena occurs in the 80% of the patients with the chronic loop diuretics. The dietary and fluid advice is the most important trick here. Next one. So as far as the serum biomarkers are considered, the serum creatinine is the late marker of AKA, acute kidney injury. So you have to consider other drugs like the cystatin C and NGAL. Next one. The serum creatinine in acute decompensated heart failure, the initial rise in creatinine due to the loop diuretic, aggressive loop diuretic, as well as the sequential nephronal blockade is anticipated. When you are using a AC inhibitor, 30% reduction in the eGFR is anticipated. When you are using SGLT2 inhibitors, 30% reduction in the eGFR is anticipated. Like that, in this situation, using the loop diuretic or combination of diuretic, the permissible hypercreatinemia is acceptable. Even there is a drop in the eGFR, rise in the serum creatinine from 1.5 to 1.8 is acceptable. That means your drug is working there. So please continue the loop diuretics, but the most important thing is you target the decongestion. Decongestion you should target either by means of the loop diuretic or combination of diuretics or even to the extent of ultrafiltration with the help of a nephrologist. Just 1 or 2 sittings of ultrafiltration in these situations will give a completely patient can tide away the crisis. Next one. So don't stop the diuretic abruptly. Don't rely solely on the creatinine to diagnose. Don't use nephrotoxic drugs. Please avoid other nephrotoxics. Don't aggressively raise the BP. Don't delay decongestion. It's the most important thing. Next. Next, please. Tolvaptan, is it useful? Yes, if the patient is having hyponatremia or hypervolemia, it is useful. Otherwise, it is not useful. It is accuratic. Yes, it is accuratic, but it will not diuretic. It is not a diuretic. What's the difference between the two? It will eliminate only water. It will not eliminate sodium. So it's not useful in CRS. Next one. So ultrafiltration in a decompensated heart failure with a cardiorenal is the most important tool today. When you are having a patient with acute heart failure with a renal dysfunction, fit in with the CRS, you have tried everything, then 1 or 2 sittings of the ultrafiltration definitely makes the difference. It will heal the patient, it will give a very good outcome. Subsequently, you can switch over to the oral drugs and other things. Jason, thanks for the patient listening. Thank you so much.
Thank you so much, sir. So we'll have a discussion after the next session. And now I request Dr. Aruna sir to the stage for the next session. So while listening to the next brainstorming session, we'll also have a tea inside the hall. Thank you.
Good morning. So we are already half an hour late, so I'll finish after. Slides, please. So acute coronary syndrome, because whether this acute coronary syndrome, you are a physician, cardiologist, that's a different. We must know something about a basic treatment of acute coronary syndrome, everybody, because as rightly said, after this diabetes, hypertension and more elderly people, longevity, we are getting a lot of acute coronary syndrome within our neighbors, family and all. So we should know what is at least just a bird's view on that. So I'll be just going through advances in acute coronary syndrome. So you know that acute coronary syndrome is nothing but there is an atherosclerotic plaque inside the artery, and the plaque ruptures, the platelets and all the coagulation mechanism is activated, and if there is 90% blockade, troponin normal, ECG normal, echo normal. This is the biggest challenge for treating doctor, because he will be taking photo, sending to other doctor asking echo normal, ECG normal, troponin normal. Why you want to take a treatment, why you want to do angiogram, or you want a medical management. So we have to be very clear with the patient's symptoms. Treat the patient and not the troponins, ECG, echoes. He has symptoms, risk factors, diabetic, family history, father undergone heart attack or sudden cardiac death at 45 years, obesity, hypertension, hyperlipidemia, so metabolic syndrome. Yeah, the risk factors, if the risk factors are more, symptoms are atypical, yes. If risk factor is less, symptoms are typical, yes. Only thing is, so you have to, in the context of the risk factors, symptoms are there. You have to even, the subtle symptoms like GRD, like some irritation, you have to treat. So more the risk factors, be careful, because The obesity epidemic is going like anything, so we have to catch them earlier. Family history, I want to stress. Father undergone heart attack, had an attack and CABG or angioplasty done between 40 to 60 years. The history is there. You suspect more even if the child's son or daughter is at 25 years with chest pain. So let us go through that. First, 1977, Andres Grinsick started angioplasty, plain balloon angioplasty. Then in 1988, intravascular ultrasound. You put a catheter inside the artery, send sound waves, look at the artery, how it behaves, how it looks like that. Tunica, intima, media, and adventitia. Then comes optical coherence tomography. This is a light-based imaging catheter. You put a catheter inside coronary artery, it will give the pictures, and then this is incorporated into the management. So the biggest challenge in acute coronary syndrome management is, as said, most of the patients between 65 to 80 years having high thrombus with calcium. Even young patients, we are getting a lot of 40-45-year-old male, heavy smoker with family history, poorly controlled diabetic with calcium, with acute MI. So that is the challenge. You have to see that in such patients, this calcium is picked up by angiogram in 30%, and what you see, the black and white is intravascular ultrasound, and what you see this is what this zone, what you are seeing here is this area is the calcium. So the problem, you cannot assess only 30% cases, you can assess with what do you call that, angiogram. So the imaging is needed, so you can see that clearly how the calcium looks like here, but very difficult to pick up with IVUS. There will be increased white followed by a black shadow because of attenuation. And this is what you can see clearly what you have learned from pathology. You can see intima, media, adventitia, internal elastic lamina, external elastic lamina. Why it is important is this external elastic lamina to external elastic lamina will give what balloon you have to choose, what stent diameter you have to choose. And this is another scenario. You see, this is OCT, this is intima. What you see, the black is full lipids. So if such a lipid is there, don't do any balloon, anything. Put direct stent. If you balloon, these lipids will go and clog the microcirculation, atheroemboli. But here you see, this is a calcium where you will need a balloon or special apparatus. You can see in that what do you call that, IVUS also. So for that we have special balloons which have blades. But the problem is you cannot use with thrombus. If it is pure calcium you can use. So these blades will cut in the 0, that's 60 and 120 degree. It will cut the calcium and will expand it. You can see here this big chunk of calcium. So after putting the cutting balloon, you can see the balloon has produced a dissection. So once this is produced, the stent will expand. If there is no adequate stent expansion, the patient will come again with stent restenosis. And this is a scoring balloon where you have wires over the balloon. Either it is like this or longitudinally. So when you expand, that nitinol wires will cut the calcium and expand it. But the main is you have to do imaging. If more thrombus is there, then there will be a problem. And you have for this latest laser angioplasty, you have intravascular lithotripsy, rotablator, and orbital atherectomy. I'll discuss case by case. So this is a 75-year-old male, a diabetic hypertension, CKD patient, eGFR is 36 ml, and he had a stent deployed in 2016. You can see that hypokinesia in these lower segments, inferior and infra-posterior segment. And you can see this is a ECG. So anybody can postgraduates findings. What is exactly? What is? So that is what I want to specific. 2, 3 AVF, there is ST elevation. You had ST depression V1, V2. V5, V6 are perfectly normal. So it is acute infraposterior wall infarction. So that much specific you must be able to tell that, because only inferior, nothing, patient will be safe. Infraposterior, medium. Infraposterolateral, the patient prognosis is very bad. So you can see that angiogram done, this is stent. It is blocked, the stent, he had acute inferior wall, and so laser is nothing but it is, you can see in this one, initially they were using infrared laser. That is a hot laser, heat laser, produces lot of dissection and perforation. The latest laser is cool laser, ultraviolet laser, 309 millimeter. So the catheter tip will emit the concentric fibers will be there. It will emit laser waves. It is a contact laser. Only from the tip of catheter, 100 nanometer, that is, what do you call that, hair thickness will be emitted. So it will vaporize the tissue, and this is the mechanism. So it is a pulsed laser, not continuous laser. Previously they were using continuous laser, lot of complications. Cool laser, if you see this one you can understand that. See what they are using in ophthalmology, LASIK is 193, and what we are using in cardiology is 308. So it's a cool laser. Previously they were using 2090, so we got lot of complications, and that was continuous laser. So these are all the mechanisms. So what happens is, when the laser comes, waves comes, it will be absorbed by the atherosclerotic tissues, so that molecular bonds will be broken, and it will produce a sonic wave. That ultrasonic wave will vibrate and will make further calcium fibrous tissue to break. Finally, a cavitation is formed. So you can see this is laser at rest, and that is the laser pulse. So initially the tissues absorb the laser waves, so they go for vaporization. Then they form like this ultrasonic waves, which will vibrate inside the artery and will make the calcium and fibrous tissue to yield. And finally, this forms a cavitation bubble, which will just collapse and will wash off all the atherocalcium debris less than RBC. So the microvascular clog is not there with the laser. If you take roto, orbital, all the things, the least microvascular clogging is with laser. So this is the mechanism. So why it is, how it is, these two gases, xenon and chloride, they form as xenon chloride. This xenon chloride get excited, that is called excimer. So this is called ELCA, excimer laser coronary angioplasty. Why excimer is, this is excited dimer. When this dimer splits, you get the photon. When lot of photons form, they are reflected by behind the laser machine, there will be mirrors, serial mirrors, which will make photon beam. That's the laser beam. So you can see in a saline, the laser waves go directly, but you see there in contrast, the laser gets more absorbed and get into more things. And this is what saline and thing. So the balloon is not crossing. You can see that I am pushing the balloon, the catheter is coming out. So it is not allowing. Then I took a laser catheter and just making the tissues to get modified. And finally, we are able to cross with that. You can see these are all the laser cuts. You can see in the OCT, these are all the laser cuts. And you can see the previous stent also clearly. So this if you are able to appreciate this ring, this is the previous stent, and inside the stent the laser will vaporize the tissue. So now current recommendation, European guidelines and American guidelines is, if somebody had put a stent, come with instant restenosis, again another stent, first time. But now the consensus are coming for drug-coated balloon, but not yet. So you can see here all these laser effects, what the tissues has been vaporized, and so then this is what previously, this is after stenting. You can see clearly this is very important. You have to, any thrombolysis or angioplasty, we have to take post, at least it has to settle down, or there should not be more increase. And the patient was put on ticagrelor. So one thing I want to just stress to all the people is, ticagrelor is twice a day. Many patients for the cost factor make once a day. It's not right. If done, at least switch over to clopidogrel if the patient is not affordable. So minimum 1 year, at least 1 to 3 months, because stenting cost lags, so you can make them. If not, you convert into prasugrel, which is less costly, or into clopidogrel. Don't put 90 milligram OD. The patient is taking, please ensure, and ecosprin. When you are putting ticagrelor, ecosprin never 150 milligram. It should not exceed 100 milligram. We don't have 100 milligram much companies, so 75 is enough. Don't put 150 milligram, because with clopidogrel we put 150. If you put 150, the ticagrelor effect is attenuated. And then statins is CKD insulin. So this is another case scenario. 79-year-old man, chest pain, came with tropi, anterior wall MI. You can see that hypokinesia from 9 o'clock to 3 o'clock. And you see that the ST elevations are there. You can see from V1 to V4, and there is a reciprocal ST depressions in the inferior leads. So this is the thing. He was thrombolized in a periphery and shifted. So he had a proximal thrombus. This is the scenario I was telling, that if you put a balloon here, plus minus 50%, you are okay, 50% the artery will get closed, because if there is more thrombus. So 79 years, we are worried whether it is a calcium or thrombus. So I did this laser run, and you can see that this clearly it has modified. You can see these are all the modifications, and thrombus, it has vaporized that. And then this is the advantage of OCT. So you can see here, I point the calcium. This is the more calcific region. This orange color is artificial intelligence based, this OCT. It will tell you if the orange is this much, then 255 degree calcium is there. If you put a balloon, it may expand or may not expand. If you put a stent, same thing, 50-50 chance. So 360 degree is there, you should be very careful. So what I am doing is, I am mapping that in this artery, so that area is here. But the thrombocalcium area is here. So I am not putting any balloons. I am using a special scoring balloon and expanding this and just putting a stent. So I am putting not in the thrombus area, in that calcium area. And this is what after stenting. So you can see that a 0.72 area has come to 6.67. So that is what post and thing. And this is another balloon non-crossable, a patient unstable angina, a mother of a doctor, physician, but not willing. I gave option first CABG, you are not willing, so got a non-willing concern. This is the calcium area where even a balloon was not able to cross that. Because you can see full 360 degree calcium. So we take rota. Rota is very simple. You can understand that it is a drilling machine, that's all. So it's a purely the movement, everything will be a drilling, but only thing is we will be doing inside the live person. So people in our fraternity used to say it's a cardiac plumbing, but the problem is, so I am trying here, I am not able to cross the balloon, so taking the rota and doing the, so Burr effect, so it gets, you can see these rota cuts clearly. These are all the rota cuts. So when the rota cuts are there, then you take a balloon, the job is finished. See, it is well expanded. you can see that 87%. 80% is okay, but aim for 90% to 100% expansion. And the lumen has come from 1.77 millimeters to 6 point. You cannot get just with balloon this much gain. And so the patient was put on the same things. And this is another COPD patients. And he had, this is what the artery, see, it's a very bad, severe calcific artery. He has COPD patients, discussed heart team, he was said high risk CABG. So took orbital. Orbital atherectomy is nothing but, you might have seen this. So that days we used to put that's the same thing, it does that. But only problem is the artery should be at least 2.5 millimeter and above. So this, we are doing imaging. You see that very simple. See this L mode, this length, calcium, the length of calcium, circumferential calcium. You put any stent or balloon, it will not expand and the patient will come 6 months back. So better this patient should be subjected to CABG. The problem is COPD and high risk, and he denies that. So then we took the orbital atherectomy. You can see the sanding effect of the orbital atherectomy. So you can see these are all the areas where it has produced sanding and covered the calcium. After that you put a stent, the expansion will be better. So this is another patient, intravascular lithotripsy. This is nothing but same like what you call that using in the renal nephrologist. The balloon will emit the waves, shock waves, and that will produce the expansion. But nowadays after laser we are not using, because laser produces sound waves better than this, and this is very costlier. Since we have laser equipment, we not much using IVL nowadays. So this is pre and post. So the finally, just two slides, I'll close this. This is called coronary microvascular dysfunction. I'll give a scenario. Many patients used to come that their ECG normal, echo normal, treadmill positive, angiogram normal. Then you fix that it is a non-cardiac. It's not like that. See, what you see by angio is this one. What is the real is that. So the whole microvessels are not seen in coronary angiograms. So what you see is 5%. You don't see that 95% microvessels. So these microvessels, all normal angiograms are not normal coronaries. So there is a microvessel, either dilatation impaired or there is a vasoconstriction. And so that is called, it is in future, this is going to explain everything. Heart failure, pressure ejection fraction, cardiomyopathy, MI with normal coronary arteries, iatrogenic obstructive, all these things. So it's a systemic disease, again coming with obesity. So either impaired vasodilation or increased vasoconstriction. With this you just have, this is major vessel, epicardial vessel, where fractional flow reservoir will measure. These microvessels will be measured by IMR, index of microcirculatory resistance. So what you do FFR is, the wire will measure aortic pressure and then will cross and measure distal to lesion. If there is a pressure drop, then only you have to stent. And these IMR normal values are more than CFR values. So we'll go. This is, so some woman is coming, chest spine, 50 years, normal angiogram. You have CT angio or invasive angio done. And if there is normal, it is normal. In abroad they do PET. But in India we have only treadmill. If treadmill is positive, subjective, invasive angio, if normal, you go for microvascular dysfunction, where a wire will be put and a saline will be injected, hyperemia will be induced. By this thermodilution method, we get the CFR IMR values, and depending on that, we fix whether the patient has microvessel. This issue is there depending on these things. If CMR is decreased, IMR is increased, then we call it a structural CMD. If CMR is decreased but IMR is normal, we call functional CMD. So the vasospastic component, you inject acetylcholine, the arteries will shrink. Then we call it as vasospastic angina. Why this? Because, see, the very easy, for all treatment is same. Nutrition, exercise, weight management, smoking cessation, treat the comorbidities. But here comes, if it's a microvascular angina, and you are very clear it is not vasospastic, beta blocker is the choice. If you feel it is vasospastic, then verapamil or diltium is the choice. See, other drugs are very costly. Okay. So, thank you. So, the management, it is not the only treating the obstructive coronaries. Lot of 50% of people have non-obstructive coronary microvascular angina also. Thank you.
Thank you, Dr. Arunachalam, the master of the ceremony. So for your wonderful presentation about various latest management about acute coronary syndrome, including laser therapy and lithotripsy. So medicine is not mathematics. So it will be changing every day. That's why the CMEs like these are necessary. So when we are doing CRRI in 1985, so only heparin is the therapy. Other drugs are aspirin, dipyridamole, and gemfibrozil, not statins, are not available. And Indral. Indral is the only beta blocker at that time. Now it has changed to latest level. So thank you. Any question from the audience?
Congratulations, Dr. Arunachalam. My question is, I'm an EC member of Lipid Association of India. Lipid Association of India guideline recommendations for the management of acute coronary syndrome. One is rosuvastatin 40 milligram plus ezetimibe 10 milligram plus bempedoic acid, this cocktail, one. Second thing is assess the patient's risk by subjecting the patient with ApoB as well as the LDL level as well as LP little a. And there are definite indications for us to initiate the patient on PCSK9 inhibitors or inclisiran in some of the patients. What's your view?
Sir, what you said is true, sir, because when patient comes to me, when I did angioplasty, I used to put patients on rosuvastatin 20 to 40 milligram or atorva 40 to 80, ezetimibe, bempedoic acid. After at least as much the patient tolerates, we used to put, most of the patient accepts up to 3 to 6 months. After that, I used to bring down the things. This is very cost effective. My point is LDL should be less than 55 milligram per deciliter. This is what my secondary target of triglyceride should be, less than 200 milligrams. So, if not able to achieve that, then definitely, as you said, inclisiran is the drug. But my experience is, most of our patients, if they are properly taking and able to tolerate 40 milligram rosuvastatin, ezetimibe, and bempedoic acid, there is no uric acid rise with bempedoic acid able to manage. In my, it is just 1 to less than 10%. I can say that if the patient needs inclisiran, but less than 1% takes inclisiran. That's a big challenge for us. The cost is very high, but it's a wonderful drug, subcutaneous dosing, and no side effects at all except for inject and side things. And really, you should be aggressive. Don't be happy that LDL is 100, 110. After 5 years, the patient comes with second episodes. So keep LDL less than 70, at least less than 55. Look at triglycerides, bring it below 150, and you can use all these 3 drugs. They are now come in combination and very cheaper. Bempedoic acid with ezetimibe, rosuvastatin. If the patient is not able to tolerate, don't stop that. 40 milligram, bring it 20, or add ezetimibe. Keep something, whatever. And I have seen many patients not able to tolerate 40 milligram. 20 milligram rosuvastatin with ezetimibe brings LDL less than 70. So somehow keep the drug in combination and keep the LDL and secondary triglycerides. And as Sir said, ApoA, ApoB, and also all these things.
Thank you so much, sir. It was a brainstorming session on the new advancements of coronary management. So I request the previous speaker to the stage for the questions, and the ground is now open for discussion. So any questions from the audience and the chairpersons? Okay. So now, yes, sir.
Sir, good morning, sir. Previously, you had mentioned that pseudo worsening of renal function in your talk. During pseudo worsening of renal function during decongestion therapy in cardiorenal syndrome type 1, you told that we need not de-escalate diuretics based on pseudo worsening of renal function. Till what percentage of rise in creatinine shall we wait? Or
up to 30%.
30%.
30% we can accept. That is, I have told you that's permissible hypercreatininemia in this cardiorenal syndrome 1 is acceptable, warranted. We have to be happy about that your drug is working. If the 30% rise in the serum creatinine, for example, the baseline creatinine is around 1.5, then the creatinine is around up to 2, you can permit. At the same time, your urine output is good. That is, urine output means it's 1 ml per kg per hour. If it is more than that, you have to be happy about that. Per day, weight loss is more than 500 grams. That means your diuresis is happening, your drugs are working. You have to be happy about that.
Can you add a few points on the role of sacubitril valsartan and our new drugs like SGL2 receptor blockers in the
Can
management?
you open the slides, please?
In the
Last
management of heart failure when the patient is having acute renal injury also. Can we do that, or how carefully we have to handle this drugs?
So due to time constraints, I couldn't able to show the second part of management of this. First one, the decongestion. The another one is, I have told you, that is a GTMT, that is a goal-directed medical therapy. That means there are 4 drugs, there are 4 pillars of therapy. That is, simply you remain that ABCD. It's called ABCD. A means AC inhibitor or ARB. B, beta blocker. The C, it's, in spite of C, you put it as S. That is SGL2 inhibitors. The D is a diuretic, neurodiuretic. That is MRA. MRA means eplerenone or finerenone. So A, B, C, D. That is the most important thing. You are seeing a patient with acute heart failure with a renal dysfunction. Irrespective of the renal dysfunction, you use these 4 drugs, A, B, C, D. A for AC inhibitor or ARB, B for beta blocker, C for SGL2 inhibitors, last slide, SGL2 inhibitors, or D for this MRA. MRA means finerenone. So all these 4 drugs, you have to use it as early as possible. All the drugs can be, you use it same time. It's not one after another. You can use it fastly, rapidly, yearly you have to introduce, because it completely changes the outcome. If you use it all the 4 drugs, the outcome is 70 to 80% of the time you can save the patient. And also you can, within 5 days, within 6 days, previous one, within 7 days you can discharge the patient with these drugs. Previous one, previous one. Yeah, this is the one. This is the 4 pillars of heart failure. That is called ARB, ARNI. That is a beta blocker. And C is for SGL2 inhibitors, D for MRA. This is the most important thing. As Subramaniam has enumerated, that is 30% reduction with the RAS blockade is anticipated, expected one. 30% reduction with the SGL2 inhibitors is also anticipated. But once you are having a 30% reduction in the GFR, don't panic. You continue the drug. If it is more than 30%, you reduce the drug or stop the drug. Otherwise, it is an indirect evidence that your drugs are working there. These group of patients are going to benefit more in coming decades. You are going to safeguard the heart, kidneys, brain also. So it's an indirect way of knowing things. You can boldly use this drug, but you have to monitor electrolytes as well as eGFR in next week, and a couple of weeks.
Sir, if scenario is a 65 diabetic has LV dysfunction and creatinine is 1.6. So the big challenge for us is we are afraid to put AC, ARB, worsening. All the drugs which what you said is right. If there is some rise, they are working. But what sequence you advise to add that? there's A, B, C, D, no? So anyhow, we'll put MRAs because along with diuretics. And beta blockers, okay, we can start with lower dose. And ARNI, we start with low dose. Do you start in hospital SGLT also, sir?
Yes, if the eGFR is more than 30 ml, indirectly we can say this creatinine is less than 3.5, then boldly we can use SGLT2 inhibitors also. It's a most important thing, you have to use it. You have to start with the low dose and slowly you step up, slowly titrate. And once the patient is tolerating and the creatinine is not going up more than 30%, then definitely these subgroup of patients are going to benefit. These people are going to live for another additional 10 years or 20 years with organ protection. That's the most important thing. So don't panic. Try to use SGLT2 inhibitors and MRA as much as possible. MRA, that is the Finrenone, the drug cost is 100 rupees per day. That is Finrenone. But latest we are going to have the ACCeSS. It's a new drug, the same class, third generation MRA. They manufactured, discovered in Japan. The drug cost is going to be 50% cost lesser than the Finrenone, same effect. It's going to knock our doors. So we can use those drugs because Finrenone is little costly. So all the 4 drugs are available right now. Previously we don't have, 20 years back we don't have this much amount of drugs. So as a physicians we have so much drugs at our hand, therapeutic armamentarium. So we as a physician, with these tools, we have to know where to use, when to use, how to titrate.
To better answer your question, sir, there are situations where this problem arises, which sequence of drugs we have to introduce one after the other. As he said, it is better to put them, most of the patients in all the 4 drugs if it is possible. But the scenario sometimes will be challenging, like you have a patient who is very lean and dehydrated, developing heart failure because of MI. In that scenario, you should know only these things. Sacubitril valsartan is going to act on the efferent arteriole, whereas your SGLT receptor blockers are afferent arteriole or constrictor. Okay, so if the patient is dehydrated and you go and open the efferent arteriole, immediately the GFR will be drastically dropping down. There is a chance for developing severe form of acute injury because of this, adding this drug also there. So dehydrated patient, when there is heart failure, you have to be cautious in using sacubitril valsartan. Whereas you have a patient who is volume overloaded and developing heart failure. In that scenario, if you add SGLT receptor blockers, you are constricting the afferent arteriole and making the amount of blood entering the kidney less. So instead of using that, you can use this drug, sacubitril valsartan. So volume overload patients, sacubitril valsartan. Dehydrated patients, you can use SGLT receptor blockers. The other 2 drugs, beta blockers and mineralocorticoid receptor antagonists, you can safely use in all the patients. And you can immediately start. If there is no contraindication for beta blockers, you can start. So these 2 drugs, immediately you start. The other 2 drugs you manage, volume overloaded or dehydrated.
So in this cardiorenal settings, one more additional benefit while using SGLT2 inhibitors is, when you are using beta blocker and RAS blockade, the chances of hyperkalemia is a little high. When you are combining with SGLT2 inhibitors, the chances of hyperkalemia is lesser. So there is another one additional indications where another benefit with the SGLT2 inhibitors, the incidence of hyperkalemia is lesser when you are using SGLT2 in this combination.
Any other questions from the audience side? Okay, so thank you. So now I request the moderators and the speakers of both the session to come to the stage for felicitation. So I request Dr. Subramanian sir, Dr. Vijay Dhanraj sir, Dr. Badri Srinivasan sir, and I also request Dr. Vijay Shanand sir, Dr. Loganathan sir, and Dr. Mohan sir. I also request Dr. Ram Subramanian sir to the stage. So I request Dr. Arunachalam sir to hand over the felicitation memento to Dr. Sivakumar sir. I also request Dr. Sundaram sir and Dr. Shanmugavel sir to the stage to felicitate the speakers. Yes. So I request Dr. Vijay Sanand sir to give the memento to Dr. Subramanian sir. I request Dr. Vijay Sanand sir to give the memento to Dr. Ramasubramanian sir. I request Dr. Mohan sir to give the memento to Dr. Badri Srinivasan sir. I request Dr. Loganathan sir to give the memento to Dr. Vijay Dhanraj sir. So next I request Dr. Shanmugavelu sir and Dr. Sundaram sir to felicitate the next speaker, Dr. Arunachalam sir. Thank you, sir. Thank you so much. So as we continue, like we're going to the next session of the day, it's HFpEF, Heart Failure and Preserved Ejection Fraction, the next frontier in the heart failure management. And the speaker is Dr. Alan Binney, sir. So I request the chairperson, Dr. Ratnakumar, sir, my chief. And I also request Dr. Muhammad Faisal Bashir, sir, Dr. Vijay Sanand, sir, and Dr. Loganathan, sir, to moderate the session. And I also request Dr. Mohan, sir, to chair the session. I welcome our speaker, Dr. Alan Binney, sir, who is a consultant cardiologist in Aruna Cardiac Care, Thoothukudi. Over to you, sir.
Yeah. Good morning, everyone. Good morning, everyone. I thank Aruna Cardiac Care organization to give me this opportunity to stand in front of you. I'm happy to see my teachers, Ratnakumar sir, Ravichandran sir, Veni madam here. I'm so happy to see them after a very long period. Yeah. So the topic we are going to be concentrating for the next 15 minutes will be heart failure with preserved ejection fraction. So let's start with the case. A 65-year-old female having exertional dyspnea for the past 6 months. Patient has having diabetes, hypertensive, dyslipidemia. Her BMI is 34, blood pressure is 140/80. Clinical examination nil significant. Her HbA1c is 9. She is already on AC inhibitors and calcium channel blockers. ECG is sinus rhythm with LV hypertrophy, echo, concentric LVH, ejection fraction 65%, urine micral will be is elevated 200 milligrams. Patient is having dyspnea. So we'll focus on this phenotype. So we'll be covering on epidemiology, disease burden, the latest definitions, pathophysiology, what are the newer insights, biomarkers helping us in diagnosis, imaging, drugs, the latest drugs, and comorbidity management and the future directions. So coming to the latest definitions, the 2021 EAC guideline definition states the heart failure is a complex clinical syndrome featuring typical symptoms and physical signs caused by underlying structural or functional cardiac abnormalities. So the signs and symptoms along with structural and functional abnormalities. The structural meaning LV diastolic dysfunction caused due to hypertrophy, or the functional impairment due to elevated filling pressures. So the hemodynamic assessment and biomarker assessment plays an important role in the heart failure diagnosis. Patient is having a preserved left ventricular ejection fraction more than 50, but still patient is having symptoms of heart failure. So the biomarkers presently we are focusing on natriuretic peptides, and hemodynamic assessment may be using echocardiography or using right heart cath. The 2026 definition, which was released last week, actually has removed one particular group of ejection fraction, that is the mid-range ejection fraction, which was previously listed in the 2021 definition. So we are presently having only three groups: the reduced ejection fraction, preserved ejection fraction, and improved ejection fraction. Improved ejection fraction patients, or the patients who were previously having an LV dysfunction with EF of less than 30%, but presently they have improved with guideline directed therapy with an EF of more than 50%, they come under the improved ejection fraction. Presently we are having only three classifications. So epidemiology and burden of the heart failure, because of the rise in the obesity epidemic, the heart failure with preserved ejection fraction patients are actually increasing. Of all the heart failure patients, nearly more than 50% of the patient presently are having a preserved ejection fraction, come under HFpEF. And what is the clinical and the long-term significance of HFpEF is that the 5-year mortality is similar to heart failure with reduced ejection fraction. Patient having an EF of less than 30, the 5-year mortality is going to be 50%. Patient having an EF of more than 60, the 5-year mortality is going to be 50% if the patient comes under HFpEF and is not being treated appropriately with GDMT. Usually the mean age of diagnosis is more than 65 years, and the prevalence is actually increasing, particularly in women with obesity, hypertension, diabetes, atrial fibrillation. Actually in developed countries, the admissions for heart failure is increasing, and the patients mostly comes under the heart failure with preserved ejection fraction than in the developing countries, where we have more admissions with heart failure with reduced ejection fraction. The rising titer of HFpEF is mostly because of the obesity epidemic. So the diagnostic algorithms, we have two scores. One is the most likely with the clinical score, patient is heavy, hypertensive, atrial fibrillation, pulmonary hypertension, elder, or elevated filling pressures. That is going to be HFpEF score. And the PEF score, which is launched in the EAC 2019, which is mostly towards investigation based, where the functional assessment of diastolic function, morphological assessment of the left atrium and the left ventricle, and the biomarkers, which are the NT-proBNP, and the functional stress test, which is most important in heart failure with preserved ejection fraction, because mostly at rest when we examine with an echocardiography, the parameters may be normal, but when we make the patient for stress, either using dobutamine or cycle ergometry, the diastology is going to be changing. So a patient is having a score of 0 to 1, the heart failure probability is very less. And the patient who has a score more than 6, the heart failure probability is going to be very high. So coming to the pathophysiology, Heart failure is going to be heterogeneous syndrome. Previously, the focus was only on diastolic dysfunction, elevated LV muscle mass causing LV stiffness. That was the only thing focused previously. But the newer paradigm is going to be different. The present focus is mostly on obesity and inflammation, the epicardial fat and the systemic pro-inflammatory state, the adipokines and the interleukins going to play an important role in the titin hypophosphorylation. Titin is the macromolecule present in the cardiac myocyte, which acts like a spring. So when it is hypophosphorylated because of the inflammation, the spring is going to be constricted and is going to be stiff. When the titin is phosphorylated properly, the spring is going to be free and easy to relax and contract. So that is the main pathology, the inflammation, systemic pro-inflammatory state that is going to drive the titin contraction and relaxation. That is the basic pathology in the heart failure with preserved ejection fraction. The next is the pericardial restraint and the ventricular interdependence. In patients with obesity, that's going to be a significant thoracic impedance and ventricular interdependence because of the pulmonary hypertension and the right heart failure per se because of the obesity itself. The pericardium is going to be a compact space, a fixed space, where if there is an increase in the right ventricle volume, right atrial volume, or left atrial dilatation because of the stiff left ventricle, the space is so constrained and the whole pressure is going to be impeded on the left ventricle. And the increased epicardial adipose tissue is also going to play a factor in the pericardial restraint, causing significant ventricular interdependence between the left ventricle and the right ventricle because of the closed space. Then comes the vascular dysfunction, that is the endothelial dysfunction, which not only affects the coronary microvasculature, but also affects the venous capacitance because of the endothelitis of the veins, systemic veins. The venous capacitance is reduced, so the venous return is going to be increased to the heart, and that is going to impair the LV filling pressures. And finally is the metabolic syndrome, because the insulin resistance is going to play an important factor. Normally, the myocardial energy mechanism drives mostly from 60 to 70% from fatty acids. The ATP is derived from fatty acid metabolism. But when there is a requirement of more energy for the myocardium to work, maybe during exercise or during exertion, the additional energy required for the myocardium to work is derived usually from GLUT4 receptors using glucose metabolism. But when the patient has insulin resistance, there is downregulation of the GLUT4 receptors. Hence, the effective utilization of the glucose metabolism in the cardiac myocytes is going to be deficient. So heart is going to rely more on the lipid metabolism, fatty acid oxidation, creating more reactive oxygen species, less efficient generation of ATPase. So the final outcome is going to be a myocardial energy deficiency, reactive oxygen species, lipotoxicity, all going to impair the LV relaxation. These are the latest pathophysiological mechanism. Out of the previous one, that is the diastolic dysfunction, we have come far mostly into obesity, inflammation, pericardial restraint, vascular dysfunction, and finally insulin resistance. All is going to play its role in the myocyte. So the most common phenotype is the obesity-driven HFpEF phenotype. The epicardial adipose tissue thickness, if it is more thick, more than 5 millimeters, it is going to infiltrate the myocardium, causing local inflammation and fibrosis. The leptin resistance, adipokine dysregulation, causing low-grade systemic inflammation, titin hypophosphorylation, which is going to increase the myocardial stiffness. So when the BMI is more than 35, the heart failure is preserved ejection fraction, the risk is going to be more than 50% for the 5-year mortality if the patient is not being treated properly. So what are the emerging biomarkers in heart failure with preserved ejection fraction? We have already have a good thing on the table, that's the NT-proBNP, which is with the established usefulness in heart failure. But still, in 10 to 15% of the patients, the NT-proBNP is going to be normal because of the obesity, volume dilution, and more plasma volume. The NT-proBNP may be falsely normal. So we need more markers to diagnose. The emerging marker is the ST2, that is the soluble suppression of tumorigenicity 2 factor. We need the cardiotrophins and the growth differentiation factor, which are all novel factors coming up, still being studied. So what are the echocardiographic advances in the heart failure with preserved ejection fraction? Mostly this is going to be functional. The established guidelines focus mostly on the E/A ratio, which we may not see in our routine echocardiography reports. So for general practitioners and physicians, when we assess the echocardiography report, we should not be just looking at only the ejection fraction. We should be looking more. All the data are mostly given in all the echocardiography reports. We give left atrial size. We give E/E ratio, which is always there in the tissue analysis report. And if the speckle tracking is also done, GLS, global longitudinal strain, is also mentioned in the echocardiography report. But it is not so common. But the E/A ratio and the LA volume and the LA dimensions, tricuspid regurgitation velocity, are all mentioned in the echocardiography report. So if the EF is normal, EF is more than 60%, it doesn't mean the patient's dyspnea is non-cardiac. It can still be a cardiac dyspnea. We have to assess, we have to focus on the other parameters of LV filling pressures, including E/A ratio, global longitudinal strain, tricuspid regurgitation velocity. And still, if the echocardiography parameters, including the functional parameters, if they stay normal within the limits, we can request for a stress echo. Stress echo can be done in two ways, with either a dobutamine stress or a physical stress using a cycle ergometry. Because many of the times patient develops symptoms only during stress. So what is the point in examining the patient at rest and the resting echo is going to be normal, including the functional parameters? It doesn't mean that everything is over. We have to make the patient on stress echo. So stress echo is a very basic test to be done, and it is a gold standard when the resting criteria may not be sufficient. So coming to the drugs for management, the newer drugs, previously we have all the drugs for management of heart failure with reduced ejection fraction, as Sir said, the ABCD, the 4 pillars of heart failure management. But the data for heart failure with preserved ejection fraction are just coming up for the past 2 to 3 years. Previously we were not having a lot of drugs for HFpEF, but presently the data are showing a good results. The first one is going to be the SGLT2 inhibitors, which is going to act in the titin and reduce the myocardial stiffness, and it is going to show a class effect. So patients with an ejection fraction from 41 to 60%, they are going to show an absolute benefit with empagliflozin. Their heart failure hospitalization is going to be reduced drastically. And the next one is going to be dapagliflozin, which is also useful in heart failure with preserved ejection fraction. Though the primary endpoint of cardiovascular mortality is not met, there's still heart failure hospitalization is reduced in the DELIVER trial. So the class effect in the SGLT2 inhibitor comes favorable in heart failure with preserved ejection fraction. So what is going to be the mechanism? It is going to act as a hemodynamic factor by reducing the plasma volume and the preload. It is going to act in the metabolic level. It is going to reduce the oxygen demand and improve mitochondrial function. It is going to be antifibrotic. It reduces collagen deposition. And it's going to be renal protective, because most of the patient may have comorbid renal dysfunction in a patient with diabetes, hypertension, and dyslipidemia. The next one is going to be the GLP-1 agonist, that is the tirzepatide and the semaglutide. We have recent trials showing data for significant weight loss. But the heart failure hospitalization in heart failure with preserved ejection fraction is also very, very significant and showing a favorable direction of treatment in patients with obesity phenotype of heart failure with preserved ejection fraction. We have 2 trials. Both the molecules show semaglutide and Mounjaro tirzepatide. Both show significant benefit in heart failure with preserved ejection fraction by reducing their heart failure hospitalization. The third one is going to be the MRAs. Spironolactone is now out of the basket. the TopCat trial did not show any benefit, but the newer ones, that is the non-steroidal molecule, that is the finerenone, has showed significant benefit in the worsening heart failure and CV death in the Fine Arts trial, which was published in 2024. And presently, finerenone is also approved by the FDA for treatment with heart failure with preserved ejection fraction. But the thing is, there is hyperkalemia risk is still there in this finerenone molecule also. So coming to the comorbid management, hypertension in patient with heart failure with preserved ejection fraction. Blood pressures of 140/90 in a patient with heart failure with preserved ejection fraction is not fair. The physician should overcome their inertia in treating. BP of 140/90 is fine. No, not a problem. No. According to the SPRINT subgroup analysis, intensive hypertension control of BP lowering below 130/80 is going to show a significant benefit in the long-term morbidity and mortality in heart failure patients. So hypertension is usually managed with ACE/ARB, calcium channel blockers and loop diuretics. Beta blockers as of now has no role in the heart failure of preserved ejection fraction if the patient is in sinus rhythm. Unless there is an atrial fibrillation with fast response, beta blockers may not be helpful in managing HFpEF. The next one is the sacubitril valsartan. It was previously a golden molecule for heart failure with reduced ejection fraction, but presently after the Paragon trial, there is data showing benefit for heart failure with preserved ejection fraction, mostly between the ejection fraction between 45 to 55. If the EF is very high, like more than 65%, ARNI group of drugs may not show benefit. If the patient is already on AC or ARB inhibitors and the patient is still having some symptoms of heart failure, it's better to switch over to ARNI and try if the ejection fraction is between like 45 to 55 group of patients. Atrial fibrillation and heart failure with preserved ejection fraction. When the patient develops AF because of diabetes, hypertension, dyslipidemia, obesity, all those things can trigger an AF. There is a lot of loss of atrial kick. LV pressure, filling pressure is going to increase and acute decompensation is going to happen. So atrial fibrillation in a patient with heart failure with preserved ejection fraction, there is good data to show that early rhythm control strategy with either pharmacology or with ablation is going to show a good benefit rather than just maintaining the patient on controlled response with beta blockers and other drugs. It is better to switch over to rhythm control strategy with pharmacological drugs or with ablation. Then finally is the exercise training and cardiac rehabilitation. Most of the patients are going to be sedentary lifestyle in a patient with heart failure with preserved ejection fraction. High intensity interval training is going to reduce the morbidity with the greatest VO2 uptake improvement. With the combined strength and aerobic training is the ideal thing for a heart failure with preserved ejection fraction. Routinely we advise a brisk walking for 30 minutes at least 5 days per week with not more than 2 days of gap. That is going to be a good thing for exercise training in heart failure with preserved ejection fraction. Comorbidity management, the thing we might miss is the sleep apnea, which is present in up to 70% of the heart failure with preserved ejection fraction. So patients should be subjected to sleep study, and CPAP usage is going to improve the quality of life. Iron deficiency should be treated with ferric carboxy maltose. And pulmonary hypertension as of now is not going to be treated with pulmonary vasodilators. The studies are underway. Newer molecules are being studied. Presently, sildenafil or other molecules are not going to be useful in pulmonary hypertension related to heart failure with preserved ejection fraction. Next is the palliative care and the quality of life management. Depression screening is going to be mandatory for all heart failure with preserved ejection fraction, because untreated depression is going to worsen the outcomes twofold. So emerging drugs in the pipeline are listed here. Phenomapping is very important because phenogroup 1 is going to show good results with lifestyle modification. May not need aggressive pharmacotherapy. They are going to be young, few comorbidities. They show good prognosis with lifestyle modification. The phenogroup 2, we have all these group of drugs with patients who are metabolic syndrome and obesity. Phenogroup 3, the outcomes are going to be bad because they are going to be older, multiple comorbidities, severe renal dysfunction, and the worst outcome because of RV dysfunction associated with pulmonary hypertension. Device therapies, I'm going to skip. Yeah, so the patient which we saw in the first slide, what can we do better for this patient? She is already on AC inhibitors, so we can plan an NT-proBNP assessment, a diastology assessment, both at rest and stress, if possible, and the patient can change to an ARNI, addition of an SGLT2 inhibitors, either empagliflozin or dapagliflozin, addition of an mineralocortical receptor antagonist like finerenone, and obesity management with tirzepatide, and exercise rehabilitation and cardiac rehab for the patient with exercise therapy and intensive physical activity. So these are the things which we saw in the past 20 minutes. What's new in heart failure with preserved ejection fraction? We still have the pillar drugs, SGLT2 inhibitors, finerenone, and in additionally semaglutide for the management. Phenomapping is important because the phenogroup 2 is going to respond to all these drugs, and diagnostics, which includes functional assessment with stress echo and longitudinal strain. And exercise therapy is definitely improved, and there is a class 2A recommendation according to ESC for patients with heart failure with preserved ejection fraction. Thank you.
Thank you so much, sir. So I request the moderators to ask few questions to the speaker.
So congratulations to Alan Benny.
Thank you, sir.
To have a speaker, my student.
Thank you, sir.
Emerging cardiologist in Thuthukudi, and your speech was very excellent and scientific.
Thank you, sir.
Congratulations.
Thank you, sir. So heart failure with preserved EF, it's emerging year by year. When I am studying my MD, there were very lesser drugs. Now the therapy has expanded. So the drugs used for heart failure, your triple therapy, SGLTI with GLP-1 RI, with the finerenone, the same thing is also used for CKD. So why the both things are very much related? The therapy for the FF and the therapy for the CKD is the same. And we also see, you said about the phenotyping of the FF. The type 2 phenotype only we are commonly seeing in obese patient, in a chronic hypertension, with the dilated LA, with CKD. So do you think we have to address only the heart, or both the heart and the kidney, cardiorenal? And why the drug therapy for both the FF and the CKD is the same?
Sir, coming to your first question, the heart failure is actually not a single entity. It is going to be a syndrome. Something else has started the heart failure. So mostly heart failure is accompanied by a subtle renal dysfunction, liver dysfunction, metabolic syndrome package is also there. And most of the time, the heart failure mimickers is also underlying liver failure, renal failure, coronary artery disease. 10 to 15% of the patients in heart failure with preserved ejection fraction, 10 to 15% of the patients with coronary artery disease, they may not have classical angina. They present only with dyspnea, nothing more. So that dyspnea can be missed in the routine testing, but still, the patient is going to be benefit with coronary angiogram and angioplasty rather than putting the patient on HFpEF management. So heart failure mimickers are always there because heart failure is not just a single disease, it is going to be a syndrome, and we have to approach accordingly with all the specialists, including renal management, liver management, and cardiac management, because these molecules, all we see right now is going to act on all the three aspects and the organs, and the improvement is going to be a drastic one with the newer molecules. Yeah.
Thank you so much, sir.
Thank you, sir.
Thank you.
It's a nice presentation, sir.
Thank you, sir.
I have a question. The preserved ejection fraction is less than 30%. The patient is having CKD, iron deficiency anemia. How to treat the iron deficiency anemia in that case?
Sir,
with HFpEF, the patient ejection fraction is below 30 in rural setup. He is having already CKD, iron deficiency anemia, with the anemia below 8%. How to treat that?
Sir, heart failure management, the comorbidities, especially anemia, if the ferritin is less than 100 or if it is less than 300 with a TSAT of more than 30%, it has to be addressed. And the iron deficiency in heart failure aspect is usually treated with ferricarboxy maltose injection. According to the weight of the patient, we give it like 500 milligrams, 7 days later 500 milligrams, or if the patient is thinner, 750 milligrams in a single dose is enough. But if it is going to be a renal anemia, purely renal anemia, then we have to consult the nephrologist regarding management with the renal anemia treatment molecules, the newer molecules, that is the dapagen and other things, sir. Otherwise, if it is not purely a renal anemia, then the patient can be managed with injection, Ferinject. We have like 500 milligrams, 1 gram injection. It can be safely given with very few allergic reaction. It can be given in a single shot, OPD basis, half an hour to 1 hour, then observation, and then patient can go home. We get good results in 1 month time. Yeah.
Now maltose injection 1 gram and all available.
Yeah, yes,
Is
sir.
it safe to give it 1 gram for those kind of patients?
Yeah, definitely, sir. Definitely. The patient is not, if the patient is on an OPD basis, definitely we can do it. Yes, we can give it in 1 hour with a 500 milligram or 1 gram dosages according to the weight of the patient.
Thank you, sir.
Thank you so much, sir. So we are continuing for the next session of the day. It's obesity as a chronic disease, a new era of diabetes management. So I request the speaker, Dr. Shanmugavelu, sir. And
Dr. Aruna, sir, to be the moderator first.
I also request Dr. Aruna sir to start the session.
It is not working, I think. Can I start my presentation? Respected chairperson, senior doctors, my doctor presence, I feel extremely happy, honored, and most privileged to have been invited to make a presentation on obesity as a chronic disease, a new era of diabetes management with a particular focus on evidence-based findings. I thank Dr. Aruna for his kind invitations. My disclosures, what I'm going to do for another 20 minutes, the contents of my talk plan includes the introduction, role of gut hormones in regulating energy and glucose homeostasis, definition, etiological, evaluation of obesity, surgical management, of course, conclusions. So obesity is a multifactorial disease with the various phenotypes, clinical presentations, and treatment responses. Despite increased recognition as a chronic disease, it remains greatly underdiagnosed and undertreated. Only a small minority of patients, they receive clinically proven lifestyle, pharmacological, and or surgical intervention. It confers a substantial burden on psychological and psychosocial functioning with a profound consequences on global health economic burden. Very important, obesity stigma. It is characterized by prejudiced, stereotyped, and discriminatory views. So we have the gut hormones released from the stomach, the duodenum, jejunum, ileum. So these hormones, we call it incretins, GIP and GLP. GIP is released from the proximal small bowel and the GLP from the distal bowel. They are the incretin hormones that regulate glucose homeostasis. It is secreted postprandially by K cells as well as by L cells. They have short half-life. Of course, there are differences in terms of their levels. In patients with obesity, type 2 diabetes, the circulating GIP levels are normal, but the responsiveness of the beta cell to GIP is very much reduced. On the other hand, the GLP, once it is released, it undergoes degradation by the DPP4 enzymes. But the responsiveness of the beta cells to GLP remains intact in patients with the type 2 diabetes. So these hormones are released into the portal circulation. They are traveled by the afferent neurons in the vagus to the area postrema as well as the nucleus tractus solitarius. From there they convey to the hypothalamus. Hypothalamus regulates both energy intake as well as energy metabolism, right? So we have the center for appetite and center for satiety. Center for satiety, POMC code, pro-opium melanocortin cocaine amphetamine related transcript, and the center for appetite, we have the agouti related peptide as well as the other peptides. And when it gets stimulated, that is, they suppress oroxagenic, reduce hunger, reduce appetite, reduce food intake, and induces a feeling of satiety. So we have the leptin released by the white adipose tissue. They are carried to the brain. They bind with the receptors which are located in the agouti-related peptide neuron as well as in the POMC neuron. So it inhibits the agouti-related peptide neuron. By inhibiting, it reduces appetite as well as hunger sensation. By activating the POMC, it induces satiety, thereby reduces the hunger, food intake, reduces body weight through energy expenditure also. So melanocortin 4. So POMC, once it is released, it undergoes transformational changes and they become converted into the alpha melanocyte stimulating hormone. Alpha melanocyte stimulating hormone, they compete with other, namely the agouti-related peptide. So they bind with the MC4, that is melanocortin 4 receptor. Thereby it induces satiety and suppresses appetite. So, very important thing, brain receives enough stimuli. So, from the gastrointestinal tract, we have the satiety hormones, we have the hunger hormones, namely the ghrelin. We have three types of eating. One is for the hunger, that is maintained by the, that is homeostatic eating, that is maintained by the hypothalamus. We have the hedonic, the central is mesolimbic system, which is dopamine related. And we have yet another prefrontal cortex, that is executive function. So in response to peripheral signals, CNS primarily hypothalamus plays a key role. So obesity is a multifactorial disease with various phenotypes. There is always an interaction between environmental factors with reference to diet, physical activity, sleep, increased stress, as well as medication, and genetic factors. So it's a growing health problem. What is striking here, that is several million children and adolescents with overweight, that is in the year 2024. It is an emerging challenge and also problem. These are all the underlying causes of obesity, lifestyle-related, mental. Next is medication. Hormonal, hypothalamus. We get the monogenic syndromic. Of course, Dr. Al Prakash is here, so he must have come across the, that is syndromic types of obesity. So the genetic maps, these are the genes involved. There are monogenic or polygenic. Monogenic with reference to leptin receptor, with reference to MC4 receptor, with reference to PSK1 receptor, right? So next is we have the cannabinoid receptors. This plays an important role, CB1 receptor. They are believed to play a role in controlling food consumptions. These receptors are overactive among the obese patients. I am sure senior physicians, they must be knowing a particular product, Rimonabant, that is marketed by Ranbaxy long beards. In fact, it was discontinued all of a sudden. So body weight is primarily determined by energy balance. So caloric in, energy intake, caloric out, that is energy expenditure. That depends on the resting metabolic rate, the diet-induced thermogenesis, the non-exercise activity thermogenesis, as well as the activity, physical activity. So understanding the energy balance, it is a complexity in weight loss. So energy balance is determined by the brain through various sources of input from the GI tract, from the liver, from the adipose tissue. So brain controls three types of eating, namely the homeostatic eating, next is with reference to hedonic eating, as well as next is hormone, that is next is functional eating, what we call it executive eating. So the maintenance of weight is challenging due to metabolic adaptations. When we try to achieve weight loss, physiologically adaptive mechanisms, so the satiety hormones will come down, the hunger producing hormones will go up, ghrelin. That is often associated with other metabolic problems and other metabolic changes. So definition and etiological evolution. So obesity is not a result of lifestyle choices. It should be considered as a disease, just like diabetes, just like hypertension, just like dyslipidemia. We should consider obesity as a disease because it is not a simple comorbidity or risk factor for other disease. It is also major cause of complications. That is very important. So according to the Endocrine Society, obesity is a chronic relapsing disease driven by excess adiposity that harms health. These are the causes and drivers, including the intrauterine programming, insufficient sleep, and drugs, medications, and chemicals. And the etiological evaluation, condition associated with slow metabolic rate, condition associated with increased caloric intake, secondary to socio-cultural environment or emotional eating, reduced physical activity, again, socio-cultural environment or the emotional factors. Whenever you come across, always assess comorbidity, type 2 diabetes, that is metabolic, hypertension, dyslipidemia, polycystic ovarian syndrome, mechanical impact, osteoarthritis, obstructive sleep apnea, or psychological, namely anxiety, depression, as well as eating disorders. And there are certain definite conditions wherein we need to do the genetic study. Even we come across the obesity, age of onset less than 10 years, presence of morbid obesity, or family history of young onset obesity, or history of hyperphagia, mild or moderate developmental delay, clinical evidence of visual impairment or hearing defects, or macrocephaly. So adipocyte dysfunction is a key driver. So healthy individuals. In obese, adipocyte increase in size. Hypertrophy, hyperplasia, there is inflammation, inflammatory release cytokines, and this brings about various pathophysiological conditions associated with obesity. And cardiologists, they have highlighted nicely the epicardial pad of fat, the pericardial pad of fat, next is metabolic dysfunction associated steatotic liver disease, including importance is renal steatosis. That accounts for hypertension. And one of the reasons for CKD in patients who are obese is because of the renal steatosis. So obesity, these are all the indicators: body mass index, waist circumference, waist hip ratio, body fat percentage, more than 25% in men and more than 50%, 30% in women. And of course, with reference to children, we have the percentile, 5th to 85th, more than 95th percentile. And Indian cutoff, there are certain predictors, especially the wrist circumference. Next is neck circumference, that is very important. Next is measure the waist circumference, measure the height, and it should be less than 0.5. Anything more than 0.5, it indicates the obesity and it increases the risk for atherosclerotic cardiovascular disease. Next is we have the bioelectrical impedance analysis, body composition. So it all depends upon the water content. Water content of the muscle is greater than the water content of the fat. So we can measure the fat mass as well as the fat-free mass. And of course we get the imaging, CT, MRI, as well as the they are the precise and accurate measurement of the regional fat mass, and of course the DEXA, dual energy X-ray absorptiometry, and we normally measure the bone mineral density. We can measure the fat-free mass, we can measure the fat mass, which is more accurate and it is simple to perform and less expensive. And obesity associated numerous complications. We have the cardiometabolic, mechanical, mental, neurological, and of course associated with reduced life expectations as well as increased risk of several cancers. What are the health benefits? When you try to achieve 5% metabolic improvement, 5 to 10% improvement in musculoskeletal problems, dyslipidemia, 10 to 15% osteoarthritis, improvement in obstructive sleep apnea, improvement in AHI index, and reduced and hypoxic need, hypoxic burden, and as well as the cardiovascular disease. More than 15%. There is improvement with reference to heart failure with preserved ejection fraction, CV mortality, as well as type 2 remission. So weight loss alters the body's homeostatic system, favoring weight gain. So increase in the hormone like ghrelin, alteration with reference to eating behavior, reduce nervous system activity, reduce fatty acid oxidation, increase circulating levels of the cortisol, reduce energy expenditure, as well as reduce anorexic hormones. So following weight loss, reduce energy expenditure, adaptive mechanism that leads to increased hunger and decreased satiety and weight regain. So management, comprehensive lifestyle, healthy eating, physical activity, behavioral therapy. Next is the plate model. See the plate with vegetables, fruits of all colors. Next is whole grains, and next is healthy protein. Healthy protein. So when to start pharmacotherapy in obesity? First step, lifestyle modification. Wait for 3 to 6 months. If the BMI is 30 or more, or 27 or more with one or more comorbidities, initiate the patient on pharmacotherapy. Indian cutoff, that is 25 kg and 27 kg meter square, in addition to lifestyle modification. So obesity treatment according to BMI category. So international and with reference to Asian cutoff, 25 plus and 27 plus, with and without comorbidities. And these are there are several drugs which act on different organs in different pathways. The norepinephrine, epinephrine release, as well as modification of the neuropeptide Y, as well as agouti-related peptide, as well as modulating the functions of the hypothalamus. These are all the FDA-approved agents for long-term treatment. We have liraglutide, we have naltrexone, bupropion, orlistat, phentermine, topramide, and of course semaglutide. So in the era of sustainable weight loss with incretin-based therapies, that we are more interested. So GLP-1 receptor analog, exendin-based, and human GLP. Under human GLP, we have the small molecule and large molecule. In the small molecule group, we have the liraglutide and semaglutide. In the large molecule, we have the dulaglutide, albiglutide. Liraglutide, in the scale trial, 3 milligram, weight loss, significant, no problem at all. But every day, patient has to take this injection. Now it is withdrawn. Semaglutide, it shares 94% human analogy with reference to amino acid sequence of the natural GLP. It gets highly concentrated in the area posterior as well as nucleus tractus solitarius as well as hypothalamus. It reduces hunger sensation, appetite, reduces the food intake. Not only that, it reduces it reduces appetite as well as the cravings and improved control of eating. That is very important in the long run. So semaglutide 2.4 milligram phase 3 program. These trials have clearly shown, compared to placebo and active comparator, dose-dependent reduction in body weight, dose-dependent reduction in waist circumference. So the weight loss across step 1, 2, 3, 4 trials clearly shown the benefit, not only with reference to the weight reduction, but also significant improvement with reference to glucose metabolism, A1C reduction. Next is subjects with pre-diabetes, greater proportion of subjects achieving normoglycemia. So significant weight reduction, reduction in fasting, postprandial A1C, waist circumference, no risk of hypoglycemia. Currently available anti-hyperglycemic agents reduces A1C, increases body weight, increases the risk of hypoglycemia. So achieving weight reduction, low risk of hypoglycemia, that is not currently possible except these group of drugs. Not only that, CV risk factors, greater reduction of systolic and diastolic BP, improvement in lipid profile and reduction in C-reactive protein. So GLP-based compounds in pipeline. So we know the effect mediated by GLP, the effect mediated by GIP. GIP is responsible for insulin secretion, 44%. GLP accounts for 22%, and glucose accounts for 33%. So much more that improvement in insulin secretion is attributed to GIP. What is the effect of glucagon? It induces satiety, increases energy expenditure, and increases glucagon production. So combining both GIP and GLP, unimolecular dual agonism. Combining GLP with glucagon, unimolecular dual agonism. Combining GLP, GIP with glucagon, that is unimolecular triple agonism. So dual concept, unimolecular dual agonism, there is no interaction at all. Each component, they bind with the receptor separately. So activity mediated by GLP and GIP. GIP predominant action on the brain. In fact, GIP increases the levels of GLP. When administered with the GLP, it reduces the tendency for nausea because of various mechanisms of action. And GLP has no receptor on the adipocyte, whereas GIP has a receptor on the adipose side, so favorably reduce the visceral fat as well as subcutaneous fat. And GLP and GIP addresses some important biological, namely reduce appetite, caloric intake, reduce the intensity of cravings, preference. So it modulates the appetite control. So while dual agonism, in patient with the type 2 diabetes, hyperglycemia, that causes desensitization of GIP. So by reducing hyperglycemia with the GLP, it restores the GIP signaling. Tirzepatide combined GIP, GLP, weight loss results from surplus 135, and these results have clearly shown not only weight loss or weight reduction, but also improvement. So obesity-related comorbid. Whenever you come across ASCVD, semaglutide, heart failure with preserved ejection fraction, tirzepatide, semaglutide, and next is patient with the pre-diabetes with obesity, LIRA, orlistat, tirzepatide, patient with the type 2, all, and patient with the metabolic dysfunction associated steatotic liver disease, and patient with OSA, and patient with osteoarthritis. So we do come across non-responders, that is fail to achieve less than 5% over 3 to 6 months. We have non-responders, normal responders, and super responders greater than 15%. These are all the hormone-based therapies in clinical development. So diagnosis and management leads to improvement in weight. And we need to balance the downstream, upstream approach. Downstream, focusing our attention glucocentric, and upstream approach, focusing our attention on obesity along with comprehensive care. That will definitely improve the obesity related. So the ADA, American Diabetes Association, clearly given the guidelines, obesity management, and these are the common healthcare and patient expectation from an anti-diabetic medications. How does Ozempic, that is semaglutide, match these expectations? When choosing glucose-lowering therapies, consider regimen with a high to very high dual glucose and weight efficacy. And this is, of course, surgical management, bariatric surgery, and these are the indication for bariatric surgery in patient with the type 2, and this mechanism of body weight restriction, maldigestion, malabsorption. And very important thing is, we are rerouting, that is increased entry into the small bowel. That alters microbiome, alters neural signaling, alters incretin, and improves insulin sensitivity. So obesity is a serious and growing health problem. Focus on lifestyle changes, several anti-obesity medications. These drugs are not widely prescribed, and the reasons might be the result of adverse events, and weight loss management is more challenging, and we have the guidelines for assessment and management. So that's what Dr. Aruna wanted me to convey, management of diabetes. Type 2 diabetes and obesity are chronic multifactorial disease. Proactive treatment of type 2 or obesity may improve or prevent serious complications. So patients need proactive, personalized, comprehensive treatment. Please remember, one on the right and one on the left. This one runs on money, makes you fat. This one runs on fat and saves you money. Thank you very much for your kind listening.
Thank you so much for excellent and energetic session, sir. So a kind announcement to the delegates. So car number TN72CE8985 and car number TN76BQ5555. Like, we request the delegates with the car numbers to remove the car and change it to another parking. It's a kind request from the organizers. Car number TN72CE8985 and car now over to the moderators for the questions.
So, at the outset, I would like to thank Dr. Shanmugam for excellent talk on obesity. It was a comprehensive coverage, right from the pathophysiology, GLP, etc., and finished very clearly with a single message. So you have covered everything, but I would like to make a few comments. For the Indian phenotype, so I'm just trying to touch upon some clinical aspect. So, you know, the clinical obesity document, which says Indians have certain kind of phenotypes, as you are aware that abdominal obesity, sarcopenic obesity, because when you put them on the weighing scale, they look absolutely normal BMI, but their muscle mass may be less and the fat mass may be more. So they need to be handled in a particular way. And then the metabolically healthy obesity. So it may run in families without any comorbidities. So how do you handle them? There are certain clinical aspects which you need to, you know, so personalize the patient for the care. And second thing, when using the semaglutide,
and tirzepatide also for the past 1 year.
You know, so the concerns were raised of suicidal thought that was, you know, negated because it was restudied and there was no risk of increased suicidal tendency.
In fact, we are following all our patients on this therapy meticulously.
Yeah,
we are looking for.
But again, during the initial clinical workup, we need to be careful to rule out the hormonal endocrine problems like hypothyroidism, Cushing's, etc., etc. During the evaluation, we need to have, if there is any physical markers, to go and work it up. And second thing, when the patient has diabetes and and obesity, gross obesity, sometimes they tend to lose weight, you know, 5 to 10 kilograms even in a month time once you put down semaglutide. And then we need to be careful that the patient may suddenly develop hypoglycemia because the glycemic control is crashed very quickly. So we need to pick up the patient if the patient is losing weight very rapidly, and we have to downsize the oral therapy of diabetes. These are all my recent observation on our own clinical patients.
So initially, whenever we initiate, patient might be on metformin 1000 milligram PID.
Yeah.
Such patient, they develop vomiting, feeling more.
Yeah.
Some of them are hemoglobin, so they develop. So where the dosage modification is needed.
Yeah.
Once we titrate upward, we reduce the dose of sulfonylurea if the patient is already on. The patient, yes.
Especially if somebody is on insulin and so on. And again, the acute ischemic optic neuropathy is being talked about that, and some people do a preliminary screening before putting them on GLP or GLP dual agonist. The disc diameter and the cup disc, if the ratio is more than 3, you know, they may be the candidates potential for going in for acute ischemic optic neuropathy, which is one of the red flags for this before using.
Yes, we are very careful in prescribing antihypertensive agents along with the terzepatide or semaglutide, including sildenafil.
Yeah.
This drug has also been incorporated for NAION, so non-arthritic ischemic optic neuropathy. That is number 2. And very important thing is we look into the optic disc,
Yes.
especially crowded disc,
Yeah.
especially disc at risk, apart from the retinopathy. Yes, sir.
Yeah. So that's my point.
Sir, with respect to the weight loss and obesity, so initially diabetic patients, when they lose weight, it is only their muscle mass. Because of the disease status, they lose. Only when they have physical exertion, they have the fat stores that are reserved. So for us to achieve the therapy, only the fat stores should be reduced rather than the muscle mass. So the best assessor will be the hand grip test, or what we will say chair test, troop test. So when we combine both this in our clinical practice, it is very easier. So we give a machine, we ask them to squeeze it on.
Yes, a hand grip.
Yes.
Hand grip strength we need to measure. And the simple thing is make the patient to sit
and
stand or sit, stand and walk.
So that 2 things will be ideal. So weight loss due to muscle mass loss or due to the fat. And third thing, we measure the diameter. But only thing that is being cautious is some patients, they have SIBO or they have bloating disorder. So when you measure the abdomen girth, at times it may be falsely giving a fallacy of either increase or decrease. So that things we have. And third thing regarding the surgery, I think now the recent concept is duodenal mucosal shaving. So that is one entity that is re-emerging. So where we take the endoscopy and we just re-alter the duodenal mucosa. So and we have found out the result that patients have better insulin responders and they have high sensitivity to the oral drugs that have been given. So now the paradigm is that the duodenum is the central dogma for the diabetes control as well as the receptor sensation. So that is.
Yes, sir. Thank you. Thank you so much.
Sir, one small question, sir. So most of the patients who are obese, they tend, when they reduce the weight, they tend to go back to their old weight very soon. And this is because over a period of time, those adipocytes develop epigenetic memory. So how important is it to maintain a low weight after being obese? And how long is it, we should ask the patient to maintain at least a low BMI for that adipocytes to forget the old epigenetic memory that they have and become normal again?
And the thing is, I have already given the various mechanisms giving rise to weight regain following an attempt to lose body weight. That is one. Second thing is, when you initiate these patients on incretin-based therapy, we follow the patients meticulously. We increase their protein intake. And we give suitable diet, number one. Second thing is, we see the percentage of response. We straight away don't give semaglutide 2.4, 0.25, 0.5, 1 milligram, 1.7. We see the response. One of my patients with 5 milligram tirzepatide, his body weight was 124 kg in September last year. He met me a week before. Now his body weight is 89 with 5 milligram. That we call it super respondents. So we maintain only on 5 milligram. We see the muscle power, muscle strength. Second important thing is weight loss. We assess the degree of weight loss. We normally tell the goal to be achieved. Setting the goal. We monitor the patient. Excess weight loss, we never advise. We want 5%, 10%, 15%. That's all, sir.
So should we also consider long-term weight reduction as a goal?
Yes, sir. As of now, I normally tell you have to take this medicine as long as I prescribe. Never discontinue. Once we achieve the goal, then let us try to de-escalate, see whether you are maintaining with a reduced dose with a less of side effects.
Okay, sir. Thank you so much.
Thank you so much, sir.
Thank you very much. Thank you so much.
So a kind request from the organizers. So I request the speaker, the moderators, and the chairperson of the previous two sessions to wait for the felicitation and it will be done after the end of the next session. Okay. So we're moving to the next session. It's time lost is brain lost. So modern management of the acute ischemic stroke from door to reperfusion by Dr. Veni ma'am. I request Dr. Madhavan sir to chair the session. And I also request Dr. Nandini ma'am and Dr. Sivasubramanian sir to be the moderators for the session.
I salute the illuminator of this universe who has blessed me a chance to serve the humanity by saving life. Respected chairperson, my dear colleagues, good afternoon to all of you. I would like to thank the organizing committee, especially Dr. Aruna sir, for arranging this beautiful and wonderful academic feast. For the next 20 minutes, my flow will be on these subtitles. It's about acute stroke care, especially the concept of door to needle time and door to groin time, and followed by stroke rehab. Despite modern advancement, starting from imaging, treatment profile, reperfusion, recanalization, still the stroke stands on the second place. Only 10 to 15% of the patient utilize the reperfusion therapy. Only 5 to 10% utilize the endovascular therapy. So we need to understand time is brain. Why we are saying this? For every minute delay, we are losing 1.9 neurons, 9 million neurons. If we are able to save 15 minutes, we can save 30 million neurons in our brain. So this is our duty to spread the knowledge of the symptomatology of stroke. First, we need to understand this golden period. It can be divided into early and late. For IV thrombolysis, less than 3 hours is the early window, 3 to 4.5 hours is the late window. For mechanical thrombectomy, less than 6 hours is the early window, more than 6 hours within 24 hours is the late window. Why? Because affected brain tissue has two regions. One is the infarct core, another one is the penumbra. Okay. As we know, there is a process. When vessel occluded, the infarct core develops. How? Because our brain, 55 ml is the average blood flow to both the gray and white matter. When the blood flow drops down below 40, between 20 and 40, that is the oligemic phase. Below 20 ml, what happened? Our brain cells loses the electrical function. Then finally, reduced oxygen, glucose supply and energy failure, ATP depletion, ionic imbalance and cellular swelling, then release of excitation, then finally inflammation and neuronal death. That is the infarct area. What happened to that penumbra? That is in the oligemic region. The penumbra means dysfunctional brain tissue, but we can salvage that area by reperfusion. That is the concept we need to understand. How we can do this? First, whenever we are recognizing the stroke symptom, when the patient received within the golden period, next duty is we have to categorize the stroke type. First, large vessel stroke. That is ICA, MCA, M1. The circle of Willis get involved. That is the major, large vessel occlusion. Then territory, M2, M3, M4, P2, P3, like that. That is the small vessel stroke. One another thing is small vessel ischemia. Whenever we are taking MRI for something else, we used to say, see in the report, small vessel ischemia, small vessel disease, like that. That is the involvement of lenticular striate branch, especially in diabetes and hypertension. Then another thing, we have to see which causes the stroke. Either the atherosclerotic process or embolism. Embolism may be from the heart, cardioembolism, or artery to embolism. So, understanding this mechanism and risk factor is very much important to select the treatment option in that particular patient. Next concept is TIA. The TIA should be treated promptly to avoid or prevent the future stroke. The TIA symptom is a vague symptom. Patient used to say, I dropped the things, and blurring of vision and speech arrest or slurring of speech for 5 minutes, 10 minutes. But by definition, reversible neurological deficit less than 24 hours. But we neurologists never see the patient, the TIA lasting more than 5 or 10 minutes. So mostly less than 20 minutes. So how to approach this TAA? Why this is happening? Because of the embolism or because of the collateral. We need to understand the collateral circulation. See that circle of Willis. That ACOM and PCOM covers both the hemisphere. PCOM connect anterior and posterior circulation. Then ophthalmic artery and external carotid artery covers the intracranial to extracranial. So that is the leptomeningeal connection. Why these collaterals are very important? Because for M1 occlusion, the amount, that is the severity of the presentation may be variable. Even the circle of Willis is more than 60% variability will be there. That's why neurology is the beautiful field. For a single occlusion, we get so many symptoms. We have to remember all the symptoms. Neurology is just like the calculation. This symptom is there, that territory get involved. I will tell you what are the symptoms. Anterior circulation, if MCA get occluded, the face involvement and arm involvement will be more. Patient may present with aphasia, neglect and vision loss. We know the internal capsule, hemiplegia, hemiparesthesia, hemianopia. Then when ACA get occluded, leg weakness will be more. Because of the frontal lobe involvement, there is lot of confusion, behavioral disturbance will be there, anger outburst will be there. Then remember 5 Ds and 3 As for posterior circulation. Dizziness, diplopia, dysarthria, dysphasia, then dysphagia, disequilibrium. Then ataxia, altered sensorium, then altered consciousness. Because AR, ascending reticular activating system, is tightly packed in the brainstem. That's why in posterior circulation, patient present with altered sensorium. But in anterior circulation, they never present with altered sensorium unless both the hemisphere get involved. So every minute matters. So the symptomatology should be not only with the clinician, public should be addressed. For that, we created Be Fast. Balance, eyes, that is visual disturbance, facial weakness, arm drift, speech problems, that is the time to call ambulance, time is brain. So we need to spread this Be Fast to all our patients. Then only we can get the patient within the golden period. Okay, we assess the symptomatology. We concluded this is the stroke. What is the next? ER assessment. We have to assess the patient in detail. NIHS stroke scale should be done. The total score of 42. We categorize the stroke into mild, moderate, severe, less than 5, 5 to 25, more than 25. Which patient get benefited? How to assess that? Taking the imaging. The routine practice is taking CT, non-contrast CT, to differentiate whether it is the hemorrhagic stroke or ischemic stroke. If it is the ischemic stroke, within the golden period, whether to go for IV lysis or whether to go for endovascular therapy. That we need to form. Why? Because some of the patient get benefit from IV thrombolysis. But large vessel occlusion, if we give IV lysis, it won't help the patient. In that case, we opt mechanical thrombectomy. Then one another entity, wake up stroke. In that, how we are achieving the thrombolytic therapy? By taking perfusion sequence. So, rapid imaging, not only door to needle, door to imaging also taken care. Then, what next? That is door to needle. Okay, we assess the patient. NIHS is less than 10. The patient M2 occlusion or M3, we take the patient for IV lysis. The door to needle time recommended is less than 60 minutes. But if we able to do within 45 minutes, we are saving 30 million neurons within our patient brain. So for this, pre-hospital stroke notification should be evolved. This is the duty of the society and the government. As a clinician, we can minimize the door to needle time. We need to activate the stroke code. A separate stroke nurse will be there, then lab technician, imaging technician, then neurologist should be available, critical care physician should be available to minimize this door to needle time. Then what determines this thrombolysis success? First, who? Age of the patient, comorbidity. For example, patient with cardiac comorbidity, already on anticoagulant, whether to take for IV lysis or mechanical thrombectomy. So, the profile of the patient, right selection of the patient is very, very important. Then when we starting the therapy, that is very, very important. If I thrombolyze the patient within 2 hours, the outcome will be good. If it extends beyond 3 hours, outcome may be variable. So when we are starting the therapy, that is very, very important. Then which vessel get occluded? This is a large vessel or a small vessel, that also play a important role in the treatment outcome. Then how well the collaterals within the brain of that patient, that we can't change. That's why for every patient, the outcome is variable. So many patients develop reperfusion injury, some of the patients won't get reperfusion injury. That is, the patient profile is variable. Then what next? Not only reopening the arteries, we have to take care of rest of the thing. Is it for me or for audience? 5 minutes. Okay. So this is the perfusion sequence. First is for within 3 hours, see the M1 is occluded. The 11 hours after lysis, the vessel get opened. Already we are running short of time. So this is the indication for thrombolysis. Within golden window, no previous ICH, symptoms confined to stroke, BP should be less than 185, 110, platelet count less than 1 lakh, blood sugar above 60. This is the criteria. This is the aspect score. Its score is 10. If the score is more than 6, the success of thrombolysis will be high. So these are the agents used for thrombolysis. Recombinant tissue plasminogen activator, altiplase 0.9 milligram per kg, the maximum of 90 milligram. Tenecteplase 0.25 milligram, maximum of 25. IA lysis we won't recommend. This is adjuvant therapy when we are doing the recanalization. Then post lysis we have to monitor the BP, neurological profile for bleeding risk every 15 minutes for the first 2 hours, then every 30 minutes for the next 6 hours, then every hour for the next 24 hours. So we have to monitor the patient for bleeding risk, BP, because we have to keep the BP low, below 180, 110 to avoid reperfusion injuries and bleed. So this is the BP management. We are using labetalol, 10 to 20 milligram, you know better. Then concept of door to groin. First we need to recognize, is it a large vessel occlusion? We go with mechanical thrombectomy. So this is the demo. Just to see our circular phyllis is aligned in between our eyes. So in the bridge, when we insert the cannula in the femoral, external iliac, abdominal aorta, then thoracic aorta, common iliac, then ICA, then stent retrieval, initially guide wire followed by retrievers. So this is the video. So want of time, I am just skipping next videos. Just see how the clot retrieval is being done. So pass the guide wire beyond the clot. Sometimes we use a distal balloon to avoid emboli from that clot. This is the stent retriever. So the beautifully it hold the clot and remove. So the vessel is opened. So I am just skipping this video. This is the DSA. The another molecule is sovataltide. This is the endothelin B. We can use within 24 hours after lysis. Even patient is not thrombolized, we can use this molecule. Then carotid endarterectomy should be done for symptomatic TIA or symptomatic stroke. Recommended is between 70 and 99% stenosis, we go for carotid endarterectomy. And how well I explained the collateral circulation already. When the collateral is good, outcome is good. The improved recovery is warranted with robust cholesterol. Then we need to optimize the internal milieu, starting from our BP, glucose, temperature, oxygenation, then hydration, hyponatremia, hypoglycemia, everything should be taken care. Then we can start antiplatelet therapy after 24 hours after taking a CT or MRI screening. Then patient should be cared in the stroke unit. So with the advent of artificial intelligence, human eye has a limitation. That's why we are using the microscopic surgery, robotic surgery, like that. In stroke also, we are including the artificial intelligence to assess the prognosis of the patient. So then what next? Stroke care is over. We plan to discharge the patient. So discharging the patient with prescription. Assess the difficulties of the patient, whether it's a motor or the cognitive or the speech, swallowing, everything should be assessed. Proper rehabilitation goal should be given to the patient. This is my Prana Rehabilitation Center. So finally, preventive neurology. The last speaker also said about this. Everything, the prevention is always better than cure. We should, as a physician, you can take the diabetic patient, hypertension patient, teach them how to take their food. First bite in the morning should be fiber. The next bite should be protein. The third one will be the carbohydrate. So carbohydrate should be limited. Then if you ask me which is more important, I will tell you sleep is very, very important. 8 hours sleep. Don't think it's a 6 hours sleep is enough. It's 8 hours sleep for initial half of the sleep, that is up to 2 o'clock physical well-being. The 2 o'clock to another 4 hours is for mental resilience. The REM sleep is for mental resilience, non-REM sleep for physical recovery. So 8 hours sleep is mandatory. Every patient should be advised to take adequate sound sleep at night. Then stress management, because stroke is happen within seconds to minutes. So we have to address the stress level of the patient. Then exercise. Exercise is very important for get enough collaterals in the brain. So exercise is very, very important. Don't think 150 minutes of exercise in a week is sufficient. 1 hour exercise is very, very important. If you take care of your body for 1 hour, your body will take care of you remaining 23 hours. So exercise is very, very important. Then cognitive engagement is very, very important. Even for us also this is very important. Simple walking is not sufficient to keep the brain health. You have to involve the cognitive task. For example, if I say you tell letters or words with A. If you are able to tell 25 words in a minute, your brain is superb. Otherwise, you have to retrain your brain. Then avoidance of neurotoxins. Of course, we used to say don't smoke, everything. Alcohol, binge eating, beta and cocaine, cigarettes and distractions. Nowadays, the patient will be seeing the mobile just before sleep. How many of you having the habit of seeing the mobile before sleep? Honestly tell. So why I am telling for brain health, this is very, very important. If your retina sense the darkness, then only the melatonin get released. Retinohypothalamic pathway, then pineal gland, melatonin get released, then the sleep onset. The cortisol will be coming down. If you show the torch all the time on your eye, immediately you switch off the torch and go to sleep. How are you able to get the sound sleep? So sleep is very, very, very important. One last slide. So to conclude, we are not racing against the time alone. We are racing against the brain tissue. If you are able to save 1 minute, you can save 1.9 million neurons. So with advancement of imaging, mechanical thrombectomy, IV lysis, our stroke care has started improving. So this is our collective duty, responsibility to take care of the patient, not only for reopening, but also preserve the brain function and restore the independence and improve the quality of life through rehabilitation. For that, as a clinician, we need to create awareness among the public. So these are the books written by me. My first book on stroke, this is available in Sun Pharma stall. Please, if you want, you can get it. I am having my own YouTube channel, Dr. Veni Neuro, 3 crores followers. I am spreading the awareness among the public. That's why I started Prana Rehab Center for improve the quality of life. Thank you so much. I thank the organizing committee. Thank you. I am happy to answer your queries too.
Thank you, madam, for your excellent presentation. It was a very nuanced and fine intricacies of this current stroke management, along with the AI integration into stroke management also. Whether this lymphatics, which we read in anatomy, brain has no lymphatic supply, and now is lymphatics is making a major
fact, pardon me, sir, it's echoing.
Glymphatic
system. Okay, the glymphatic system is a system in our brain which works only during sleep. It removes the toxin from your brain. If you are not getting enough sleep, the toxins get accumulated. Nowadays, the youngsters present with fear, stress, so many factors because they don't allow the glymphatic system to work. That means they are not sleeping properly at night.
Thank you.
Good afternoon, ma'am. Ma'am, we had a complex scenario in our hospital. So we received a young male who is a known drug abuser. He had a left-sided numbness since the previous day. The next day, afternoon, he developed a complete right-sided weakness. So when we proceeded him with, he came to our hospital within 1 hour. So when we proceeded with MRI, there was a complete left ICA occlusion. And
left ICA
occlusion. He presented with right-sided weakness, but he had also right-sided numbness since the left-sided numbness since the previous day. In MRA, there was also a plaque in right ICA, which is occluding 40 to 50% of the artery. So whether he reached us within 1 to 1.5 hours. So whether we can go for bridging thrombolysis and then we can proceed with the mechanical thrombectomy if he is not improving, or directly we should refer him to mechanical thrombectomy, ma'am.
Anyway, it's a large vessel occlusion. What is the NIHS score?
NIHS score is less than 10, ma'am.
Less than 10?
Yes.
So collateral is taking care?
Yes, ma'am.
So we can take CT angio
to
decide on the clot burden and the nature of the clot. We go with mechanical thrombectomy. We can do the bridging also.
Yes, ma'am.
The previous comorbidity, either a patient is taking
He's
any
a drug
tablet,
abuser,
but any other drugs he is taking. I am talking about our drugs.
No, he's not on any, he's a young male.
Young male, okay,
Yes.
okay. Then we proceed with the bridging therapy.
Bridging therapy, yes. Thank you.
Madam, what is the thrombolysis in posterior circulation stroke? Your experience, madam?
Sir, posterior circulation stroke, the improvement is less because basilar occlusion, we can go for mechanical thrombectomy. But the P3, we can go with IV lysis. It depends on the which vessel get occluded.
Because I did nearly 2 to 3 patients thrombolysis in posterior circulation stroke. Most of the patient won't recover after lysis when compared with anterior circulation stroke. That's why you're asking this question.
Generally, posterior circulation stroke improvement is lesser than the anterior circulation because the tightly packed fibers within the brainstem.
Okay, thank you.
Ischemia.
Sir?
Neurons are also too much sensitive to ischemia.
Yeah.
That may be reason.
Then ascending lenticular system is also get affected. Then connections also get affected. So that's the issue.
Any more questions from the audience?
Of all the lifestyle modifications, which one you consider the best one?
Sir, I already mentioned sleep is the one single parameter we have to take care.
Suppose if the patient comes for insomnia, how will you advise? Whether you will refer to psychiatrist or you will manage yourself?
I will manage on my own.
Thank you.
First, we need to assess the sleep assessment. Sleep assessment scale is there. Sometimes patient will sleep better, but constantly he will be thinking I am not sleep well. It's a mind factor or really he is not sleeping well. We have to differentiate that. Then some of the patient will take a short nap or 2 hours sleep at the day. They complaining insomnia. So they have to avoid daytime sleep. They should be physically active. Then they have to avoid gadgets just before sleep, at least for 1 hour, to get proper sleep. I recommend pranayama and yoga along with some of the sedative drug, but make sure that he is physically active all the time. Because there is a system in our brain, adenosine. Melatonin, once you lie down and close your eyes, melatonin get released. But adenosine get accumulated throughout the day. That gives you the sleep urge. That makes you to think, I want to take nap. So adenosine burst will be high. For that we need to walk or physically active. All the time we are sitting within the AC and we are not having enough sun exposure. We are not taking care of our pineal gland. That is the reason we are not getting enough sleep. The one single most, because we are dealing in the neurometabolic era, no? So that's why we are talking about the GLP. We are in neurometabolic era. Day by day, all the mechanism, medicines, everything is changing. Evidence also changing. So we have to update ourselves. We have to take care of ourselves. Because doctor's lifespan, do you think it's the same as a general public or it's less? How many years less? 14 years less. We can't imagine, no. Our lifespan is less than 14 years than the general population. Why? We know everything, we are not practicing anything. So 1 hour exercise, 8 hours sleep. First bite will be fiber, second bite will be protein, carbohydrate. Give 3 hours gap between the sleep and dinner. So you will be young forevermore. Thank you.
Thank you so much, sir. It was a very nice session, and you have also reinforced the matter that the lifestyle modification is very important for the doctors to improve the lifespan. Okay.
We are not immune to anything.
So now it's time for the felicitation and express gratitude for the speakers and the moderators. So I request the speakers and the moderator and chairperson for the previous 2 sessions to get over the stage. So, yeah. I request Dr. Alan Binney sir, Dr. Ratna Kumar sir, Dr. Faisal sir, and I also request Dr. Mohan sir, Dr. Loganathan sir, Dr. Vijay Sanand sir, and I also request Dr. Aruna Chalam sir. I also request Dr. Thomas Kingsley sir, Dr. Sairam sir, Dr. Mohammed Yasser sir, And I also request Dr. Madhavan sir, Nandini ma'am, Sivasubramanian sir, and Veni sir. And I also request Dr. Aravind sir on the stage. I kindly request Dr. E. Arunachalam sir to hand over the momentum to Dr. Alan Bini sir. I request Dr. Ratnakumar sir to hand over the momentum to Dr. Loganathan sir. I request Dr. Madhavan sir to hand over the memento to Dr. Vijesh Anand sir. I request Dr. Arunachalam sir to hand over the momentum to Dr. Ratnakumar sir. I request Dr. Vijesh Anand sir I request Dr. Vijesh Anand sir to hand over the memento to Dr. Mohammad Faisal Bashir sir. I request Dr. Alan Binney sir to hand over the memento to Dr. Thomas Kingsley sir. I request Dr. Nandini ma'am to hand over the memento to Dr. Sai Ram sir. I request Dr. Ratnakumar sir to hand over the memento to Dr. Aravind sir. I request Dr. E. Arunachalam sir to hand over the memento to the speaker, Dr. Veni ma'am. I request Dr. Yasser sir to hand over the memento to Dr. Nandini ma'am. I request Dr. Madhavan sir to hand over the memento to Dr. Sivasubramanian sir. And I kindly request Dr. Ratnakumar sir and Dr. Arunachalam sir to hand over the memento to Dr. Madhavan sir. Thank you so much. So now it's time for a lunch. So we all can gather back around 2 o'clock after the lunch. 1:50 after lunch. 1. Very good lunch. So we are going forward to the next presentation, which is time is myocardium. So managing the cardiogenic shock effectively by Dr. Suresh Kumar sir, interventional cardiologist, Aruna Cardiac Care, Tirunelveli. I request Dr. Rajavel Murugan sir to chair the session, and I also request Dr. Meenakshi Sundaram sir and Dr. Vijay Anand sir to moderate the session.
Good afternoon and all present here. So it's a great privilege for me to present this topic in ACCeSS 2.0. The time is myocardium, managing cardiogenic shock effectively. So the global definition for cardiogenic shock, it's a physiological state in which the ineffective cardiac output resulting from primary cardiac dysfunction that leads to critical systemic tissue hypoperfusion and progressive cellular hypoxia. So the cardiogenic shock, it can be due to either ischemic or non-ischemic causes of cardiogenic shock. It includes both. So the main diagnostic criteria for this cardiogenic shock is hypotension, the systolic BP is less than 90 or mean arterial pressure less than 60, with tissue hypoperfusion, which can be identified with the lactate more than 2 millimole per liter with altered mentation. And the hemodynamics, which we monitor by Swan-Ganz catheterization, the cardiac index is less than 2.2 liter with pulmonary capillary wedge pressure of more than 15. So now the cardiogenic shock, the global burden is 40% in hospital mortality. So this is the critical situation we are facing now. The 40% ischemic event leading on to the mortality. Now it has to be reduced. That's our motto. So 5 to 10% of acute myocardial infarction represents the leading cause of death in hospital. So notably the non-ischemic heart failure events has risen sharply now. So the causes includes stress-induced cardiomyopathy and drug-induced cardiomyopathy related ethanol. So these are all non-ischemic heart failure cardiogenic shock causes. So this has to be addressed. So this is the evolution of cardiogenic shock score. In the pre-1999, the symptomatic medical therapies was there, but it was 80% mortality in the pre-2000 eras. So in the 1999, the shock trial, it's a landmark trial, revealed early intervention and early revascularization gave survival benefits. After that, 2012 IABP shock trial. So this IABP, initially it was thought that it will improve the mortality as well as morbidity, but now it has downgraded in the guidelines. So in 2019, the SCOI criteria for shock is introduced mainly to categorize the patients who are presenting with cardiogenic shock from A to E, so that the referral centers, peripheral centers who is referring the patients to the tertiary care center to clinically categorize the patients for which the tertiary care center will be ready appropriate for that. And 2024-25, it's a danger shock trial. It validates microaxial flow pumps in STEMI cardiogenic shock. The classic cardiogenic spiral, this is a vicious circulatory loop actually. The myocardial injury drastically drops the stroke volume and overall cardiac output. So it leads to systemic hypotension and it reduces further coronary perfusion pressure, creating severe ischemic burden. So non-infarct remote zone areas undergoing ischemia-driven depression, which accelerates the total vascular failure. This is the pathology. So here, due to the reduced cardiac output, the anaerobic shift will occur, in which the ischemia will forces the cells into anaerobic glycolysis. So this leads to increase in lactic acid in the blood. So this will disable the sodium, potassium and calcium pump, which causing the cellular swelling, necrosis and myocyte death. So this lactic acid accumulation, which will further increases this myocyte necrosis and death, leading on to the further failure. So this lactic acidosis is very much important to see in the blood parameter, because this acidosis, whatever the ionotropes we will give, if the lactic acid is high, the drug efficacy will be very low. So this acidosis has to be corrected. So regarding this myocardial stenting and hypertonic myocardium, these are all two entities which we have to know. This myocardial stenting it is a persisting dysfunction that remains despite successful epicardial blood flow restoration. So even though if we revascularize the vessel, the myocardium will have a stunned phase. So the tissue remains
retains the inotropic reserve and can recover with short-term support. So even though if you revascularize, it needs some short-term support like device therapies like ECMO.
So these are the device therapies which will take care of the stent myocardis. So if you are diabetic myocardium, adaptive chronic conservation of contractility and severely restricted vestibular flow. This due to the chronic reduction in the blood supply for chronic go for a phase of hypertension. So when we restore the blood supply, the myocardium will have its own recovery. So the purpose is solved. So the hypertension myocardium, the chronic state angina patients will be in this place actually. So if we
relationship will be shifted towards right. In this, the consequences which we are facing is one is pulmonary congestion. Because of the shifting of this CS loop towards right, we will see pulmonary congestion. That is, we will see in the acute pulmonary edema. Clinically, we will see it as acute pulmonary edema. And the other response is tachycardia. So tachycardia, this will reduces the diastolic perfusion time, which lead on to the starvation of coronaries. This is tachycardia, which will worsen the heart failure. So this is regarding systemic inflammation and SIRS. So extensive acute MI will release the cytokines, chemokines, which leads to systemic inflammatory response syndrome. So that we will see any MI patients with increased total count and they may have hyperthermia event also. This is because of SIRS activation. And regarding nitric oxide release, this is release of inducible nitric oxide synthase. This causes vascular relaxation and localized calcium metabolic stunning. This is another one entity called mixed phenotype. Here we can see systemic vasodilatation which compromises both systemic vascular resistance reflex and it is a mixed cardiogenic bar distributic shock. This is a hemodynamic phenotype. So there are two. One is classic cold and wet, other one is euvolemic cold and dry. So this classic cardiogenic shock cold and wet accounts for 2/3 of the patients who is presenting with cardiogenic shock. So here the cardiac index will be less than 2.2 liters per minute and the pulmonary capillary wedge pressure will be more than 15. So in euvolemic cold and dry shock is seen in 1/3 of the patients. Here the systemic perfusion is critically depressed but the filling pressures remain normal. So pulmonary capillary wedge pressure will be less than 15 with clear lungs. So in this patient classic cold and wet, they will have pulmonary edema, and this euvolemic cold and dry, they will have clear lung fields. And one thing we have to keep in mind, there is an entity called normotensive shock paradox. This accounts 5.2% in the shock cohort registry. Even though the blood pressure is normal, that is because of the vasoconstriction. This can be present with preserved systemic blood pressure. The systolic BP will be more than 90 mm of mercury. This cohort remains, the systolic BP will be remains more than 90 with peripheral vasoconstriction. If this is unnoticed, the progressive organ failure will end up. So there is another entity called right ventricular shock. So here there will be inferior RVMI, inferior wall MI, the RV will go for failure. So it cuts off the left-sided preloading, leading on to systemic forward output failure with clear lungs. In RV failure, the patient will have clear lungs, but the BP will be low. So here we should give fluid challenge to the patient. And one thing we have to keep in mind, if they give aggressive fluid challenge in RV failure cases, it will distend the RV, it will over distend the RV so that it shifts the septum towards left, which decreases the left ventricular output. So this is classified from A to E. This is based upon physical examination of the patient and lab biometrics and what all the drugs to be given during the each stages. So here this facilitates the clear language between the referral hospital and tertiary care center so that what all facilities has to be kept ready for if the tertiary care center we are receiving the cases. So what all thing we have to be kept in mind, whether the IABP is needed or not, whether the patient needs central line, whether we need an anesthetist advice for this patient to make a central line and to make this guides clinical algorithm for early transfer or emergency mechanical support team activation for like ECMO or Impella. So this is stage A. This is at risk. At risk patient, they will have warm, well perfused periphery, normal baseline lactate. This is the second one is stage B, that is beginning of shock. Here the systolic BP will be less than 90, MAP will be less than 60, and the patient will have relative tachycardia with normal tissue lactate less than 2. The third one is C stage, classic. Here there will be decompensated shock. So this needs intravenous vasoactive support or temporary mechanical circulatory support device. And here the lactate will be more than 2 with oliguria. And the fourth stage is stage D. This is deteriorating. Here the patient will have refractory shock even with inotropes and even with temporary mechanical circulatory support devices. So here we should think about whether we need to escalate the drugs or we have to add any other mechanical circulatory support we have to be given for this patient or not. So the final one is stage E. This is extremis. So here the patient is going for cardiac arrest, active cardiopulmonary collapse. So and patient may have refractory arrhythmias who needs a persistent cardiogenic DC version or ongoing CPR, whether the patient had any asystole, the ongoing CPR is needed or not. Here the pH will be less than 7.2 and the lactate will be more than 8. So these are all 5 stages of SCAI staging for cardiogenic shock. So the another one which is added to this cardiogenic shock from A to E is the A modifier paradigm. Here during any phase from A to E, if the patient is having a cardiac arrest event which requires CPR, then you should add A after the stages, whether CA or BA or EA, because this A will have extra mortality risk of added 30% with routine mortality risk if they have any event of cardiac arrest. This should be kept in mind. So this carries the worst prognosis. So the algorithm for diagnosing this is the suspect cardiogenic shock algorithm. This is a mnemonic you should be able to remember. One is symptoms and sign of poor perfusion. So what else we have to see? We have to see whether the patient is having decreased urine output less than 30 ml per hour or not. And the SP is the systemic hypotension, sustained systemic hypotension, which needs which is correlated with the lactate value more than 2. This is SP, the perfusion lab parameters. And EC, the patient whether they have any ECG or echo, regional wall motion abnormality in echocardiography, and the congestion threshold. What is the congestion threshold? Whether the pulmonary capillary wedge pressure is less than 15 or more than 15. And the T, suspect T is triage. So we should triage the patient, which category the patient is having and what needs to be done for this patient, whether we are going to refer or we are going to intervene. We should be able to keep in mind. So the biomarkers for this cardiogenic shock, what is to be done? We have to do NT-proBNP and cardiac troponin. This should be done as early as possible, and we have to make whether it is too high or we have to go for any other temporary mechanical circulatory support. So one thing is lactate clearance. So if initially the lactate is very high, we should give we should correct the lactic acidosis by bicarb correction, or you can give inotropes to increase the blood pressure, systolic BP, our MAP target. So if the resuscitation assess lactate clearance metrics every 1 to 4 hours, you should repeat the ABG. If there is failure to reduce the arterial lactate, then the mortality risk is high in this category. So other one is you should check the creatinine values and the patient decreased perfusion, which can be seen in raised AST as well as ALT. And one is the non-diabetic patient who is having a stress hyperglycemia, non-diabetic presenting with the hyperglycemia. This carries a poor prognosis in cardiogenic shock. So how we monitor the hemodynamics? So the Swan-Ganz hemodynamic profile. So we should see the Swan-Ganz catheterization should be done for all cardiogenic patients who is presenting with cardiogenic shock. So here you can see classic left-sided shock. The cardiac index will be less than 2.2, pulmonary capillary wedge pressure will be more than 15, and CVP will be variable, and the systemic vascular resistance will be more than 1500. In right-sided shock, the cardiac index is less than 2.2, pulmonary capillary wedge pressure is less than 15, and CVP will be more than 15, and the systemic vascular resistance will be more than 1500. And mixed distributive shock, both classic both left and right. So here the cardiac index will be less than 2.2, pulmonary capillary wedge pressure will be variable, and the CVP will be low or normal, and the systemic vascular resistance should be less than 800. So what is the main agenda for this is what we have to do for this patient. So for any patient presenting with the cardiogenic shock, with the early revascularization, the survival benefit is more in 47%. And if you go for medical stabilization followed by revascularization, the survival is lesser. It is only very much, it is when compared to early revascularization, it is 33%. So this landmark shock trial, which gave the information whether the PCA or CABG, if you go for revascularization, the 30-day outcome is, and the 6-month and the 30-day outcome were not significantly improved, but the 6-month and 1-month survival is very much better with early revascularization. And the recent guidelines, the revascularization scope, whether the patient presenting with antral wall MI, but the angiogram reveals triple vessel disease, whether we should address only the LAD or we should address all the multivessel, if the RCA has 90% stenosis and the LCS is having 70% stenosis, whether we should address all 3 vessels at the time of admission? No. So this culprit only strategy works better. So we should only address the LAD so that we should save the patient first of all. It's not mandatory to save all the 3 vessels at a time. So you should address the LAD alone and you should immediately you should finish the procedure. You should not take much time. You should, I am going to do all the LCX and RCA. So it's not mandatory. You should finish the culprit vessel and more than 60. So this is the first line of agent, dobutamine, but the patient should not have any arrhythmic event or the heart rate should not be higher, tachycardia. So milrinone, regarding milrinone, it is the preferred drug for cardiogenic shock patients who is receiving beta blockers, and the renal excretion requires dose adjustment regarding milrinone usage. So dopamine, it is downgraded now because we have now. One is IABP. So IABP, the IABP will inflate during the diastole and deflates during the systole. This is the mechanism to drop the LV after load. This provides low flow support, only 0.5 ml, 0.5 liters per minute. So, but nowadays IABP, it is downgraded after the SHOCK 2 trial. So the moving on to the other devices, microaxial pump. So it plunges the retrograde across the aortic valve to aspirate the LV blood into the. So the devices used are Impella CP. It provides up to 4.3 liters per minute, which unloads the ventricle. So moving on to the other device, centrifugal bypass. This is the tandem heart. This bypass the left side volume from left atria directly into the femoral artery. So this offers full high flow support up to 5 liters. This is like normal cardiac output. This is the tandem heart model. So this is a VA ECMO. So this is the circulatory bypass. So veno-arterial extracorporeal membrane oxygenation. This provides total cardiopulmonary support. This aspirates the venous blood and oxygenates it and pumps it back retrogradely into the arterial system. So this is perfect for rapid stabilization in active CPR. This is eCPR is extracorporeal CPR. So the afterload threat, so retrograde aortic flow from ECMO raises the LV afterload, increasing the LV pressure and pulmonary congestion. So the one threat with this VA ECMO is persistent pulmonary congestion will be there in patients who is on ECMO. So this should be kept in mind. This pulmonary congestion, this can be relieved by using other models like Impella. We should unload the ventricle so that the pulmonary congestion will be reduced. You can use either Impella or you can use IABP to unload the ventricle in addition to this ECMO. So how we should wean the temporary mechanical circulatory support algorithm is, so the myocardial recovery must be demonstrated and the underlying cause of cardiogenic shock must be should improve, this AST, ALT parameters should improve so that you can wean the supports for this patient. and it requires a multidisciplinary assessment utilizing echocardiographic parameters and invasive hemodynamics with Swang-Ganz catheterization. So how we should stepwise de-escalate? So reduce the support by 0.5 to 1 liter per minute every 2 to 4 hours while closely monitoring the clinical as well as hemodynamic targets. So when the failed attempt, if we is not seeing any improvement clinically as well as biochemical markers, renal function and ACALT, then we should not de-escalate the therapy. So regarding ICU or ventilator and safety targets, the PEEP has both benefits as well as hazard. The extensive PEEP will crushes the RV return, shifting the septum leftwards, and it reduces the left ventricular filling. If we increase the benefit of PEEP is it's a programmed high positive PEEP, so it drops the LV preload and SPR, and it augments the LV stroke volume. So vascular access protocol monitor the femoral insertion site. So any patient who is undergoing ECMO, please, you should look for the femoral access site, whether the patient is having any retroperitoneal bleeding, is there or not. So the take-home points from this talk is, so you should know about the SKY shock criteria from A to E, and you should when to refer. So when the patient should be referred immediately to the tertiary care center, and the revascularization should undergo. So this ischemic heart failure shock we will address, but regarding non-ischemic like Tokotsubu cardiomyopathy, there is stress-induced cardiomyopathy, and drug-induced there is ethanol. So these are all non-ischemic causes for cardiogenic shock. This should be addressed. So this needs, this should be kept in mind. So you should not think all patients are coronaries, not like that. This should be also kept in mind. And the one thing is normotensive paradox. The BP is fine, but the output is low. The patient, this is the patient's upset. The BP will be, systolic BP will be more than 90, but the urine output will be less than 30 ml per hour. So this is the normotensive paradox. So this needs to be addressed earlier, because we will think the BP is fine, but the patient will have multi-organ dysfunction syndrome finally. So revascularization standards, the culprit vessel should be addressed first, and we should not do all multi-vessel PC at the same sitting. Only the culprit has to be addressed, other vessels should be addressed selectively after a period of 4 to 6 weeks. And the norepinephrine is the first line vasoactive agent. You should be starting for this patient. Dopamine is not used more commonly now. Dobutamine you can use, but the patient, you should watch for arrhythmias whenever you start on dobutamine, and the mean arterial pressure should be more than 60. So this temporary mechanical circulatory support devices are it's emerging now. So we are having Impella, and there is a terminology called ECPella. We can combine both ECMO as well as Impella also. So with this temporary mechanical circulatory support, this acts like a bridge to therapy. So whoever patient waiting for a heart transplantation, you can keep him on this temporary mechanical circulatory support. And if you are going to do a complex PCI with a cardiogenic shock, you can have this gadgets like ECMO or Impella for complicated PCI. Thank you.
Thank you so much for enriching your knowledge in cardiogenic shock management effectively, sir. Thank you. So next, we'll go to the next session of today. The art of ABG interpretation, emergency and critical care. And I request a speaker. Yes, sir. So we'll have a discussion of this topic after the next 2 sessions. So I also call the chairperson, Dr. Sangamitra ma'am, to chair the session. And I also call the moderators, Dr. Sivaselam sir and Dr. Shankar sir, to moderate the session. I welcome you all. So I would like to introduce the speaker, Dr. C. Ayyappan. He completed his MD from his prestigious JIPMA Puducherry one of India's leading institutions for advanced medical education and clinical excellence. Further strengthening his specialization, he completed a DNP in anesthesiology, followed by the FNP in critical care medicine. He also holds a European Diploma in Intensive Care Medicine, and internationally respected and the qualification representing the excellence in global critical care medicine. He currently serves as a consultant ICU head at Apollo Specialty Hospitals, Madurai. I welcome you, sir. Sorry for the delay. There's a small technical glitch. Can we have a discussion of the previous meeting now? Oh, okay, sorry. So we'll have a discussion on the previous meeting, and we are facing a small technical glitch. Sorry for the inconvenience.
At the outset, let me thank Team Aruna, headed by Dr. Aruna, who is my close friend and classmate, for organizing this wonderful forum, which has brought all the physicians, practitioners, and cardiologists under one umbrella. So it's a great initiative. Congratulations, Dr. Aruna, and thank you for the opportunity to chair this session. So nowadays, due to this enormous burden of increasing diabetes and hypertension, so the incidence of cardiogenic shock is also increasing very high. So most of the times, most of the MI cases land up in ICU with the cardiogenic shock only. So I hope your session has thrown more light on how to diagnose this cardiogenic shock and how to categorize the cardiogenic shock and how to treat the cardiogenic shock. So my question, sir, so according to this classification, there's a cold and wet and cold and dry classification. So the cold and wet is very difficult to treat. So for the sake of postgraduates, so which drug you will go for the first to treat cold and wet condition? So in your experience. And my second question is, what is your experience regarding this recent drugs for treating this cardiogenic shock? So many recent drugs are available. Still we are hanging on this dobutamine and vasopressin and epinephrine. So recent drugs are coming out. This is levosimendan. So many drugs are there. So what is your experience with this recent drug?
Thank you, sir. So the recent drugs which we are using now is with addition to noradrenaline, we are using milrinone for those patients who is presenting with cardiogenic shock. So milrinone has a better, it's having an added benefit. In addition to noradrenaline, if we have milrinone support, the patient recovery is better. Of late, we are seeing now they're adding milrinone for these patients, but it needs a renal dose adjustment, sir, for these patients. The creatinine is high. If there is a dose adjustment, we should keep it in mind, sir. So the first question, sorry, sir, regarding cold and wet, sir. Yeah. So regarding the cold and wet phenotype, the patient will have cold peripheries, but the lung will be wet. So for these patients, they should be started on side-by-side diuretics with inotropes. So the diuretics we should monitor with rise in whether the patient is having rise in creatinine values, and we should monitor the urine output, whether the urine output is adequate or not. If the urine output is not adequate with loop diuretics, then we should add on with metolazone in addition to this loop diuretics so that the better output. But we should keep it in mind when we add metolazone, the electrolyte disturbance is very common and the arrhythmias is more common. So we should monitor the electrolytes, calcium, magnesium when we add metolazone in addition to loop diuretics.
So for the cases being treated with medical therapy, so when will you decide to stop the therapy and go for device therapy? Yeah, patients are on drug therapy. So when will you decide to stop drug therapy and go for this device therapy for cardiogenic shock?
So regarding patients on medications who else need a device therapy is one thing. The patient, Swan-Ganz catheterization, the patient is not properly responding. The hemodynamics is not improving. This is one parameter. And clinically, the patient is not getting improvement with these drugs. So this is one indicator. And the lab parameter wise, the creatinine, rise in creatinine and the congestion is increasing with rise in OTPT. Then the patient needs a temporary mechanical circulatory support devices. For these patients, they need escalation of therapy from drugs to devices.
Thank you, sir. I invite questions from the audience regarding this management of cardiogenic shock. So no more questions. We will wind up the session. Thank you, sir, for your
thank you.
excellent talk.
I request Dr. Ayappan sir to take over the session.
Good afternoon. It's a tough time to give a talk on post-lunch session. I'll try to keep you awake first, then before, and I'll try to present this in a nutshell. Presenting ABG interpretation in 20 minutes is going to be a tough task. So it's a half-day workshop in majority of the conferences, and to cover that in 20 minutes is going to be very tough. Before that, I would like to thank Dr. Aruna sir for giving me this opportunity, and to be a part of this conference with the dignitaries is really a privilege for me. Without wasting much time, I'll go to the topic per se, which is interpretation of ABG. So as an intensivist, if you ask me, the most common investigations which I do in a single day is probably ABG. And if I am allowed only one investigation on a patient comes to the ICU and I am allowed only one investigation on that patient, probably the investigation which I am going to choose is going to be ABG. Because it is one such unique investigation where you can get the complete internal idea about the internal milieu of the patient. It gives you an idea about the acid-base status. It gives you an idea about the oxygenation. It gives you an idea about the ventilation, and it gives you an idea about the perfusion related to the organs as well as the peripheries. So it is one such investigation which encompasses every organ system, by which you can know about the overall general condition of the patient. And it has its own advantages also. Apart from being a diagnostic tool, it can also be used as a tool for monitoring the response to treatment. There are a lot of times where we have diagnosed cases based on a simple ABG, and it is also a prognosticating marker where a patient in emergency can be determined whether he has to be nursed in a ward or in an intensive care setting. That is the importance of the ABG, and this is in a nutshell what are all the parameters which you can see. So 60 years ago, when the first ABG was invented, the only thing which they were able to get were PCO2s and bicarbonates. But the ABGs have come along far, and ahead that we will be able to know about almost the entire parameters which you take in a complete blood profile. You'll be able to see the hemoglobin, you'll be able to see the electrolytes, you'll be able to see all the oxygenation and ventilation parameters. So to go across everything in 20 minutes is going to be tough. So the only thing which I am going to stick to is about the acid-base balance, right? So among the parameters which you have seen here, only PaO2, PCO2 and pH are directly measured, and the rest of the things are derived variables. In other words, from PCO2, the bicarbonate is derived based on Henderson-Hasselbalch equation. And the last line is important, which we'll be discussing in the later slides where we discuss a case, because majority of the time saturation is derived based on the oxygen dissociation curve, unless your ABG machine is a co-oximeter compatible system. If you have a co-oximeter, it will directly measure the saturation, in which you will not look at only the functional saturation, you will also look at the fractional saturation of hemoglobin, right? So with that, we will go into the topic per se, which is acid-base balance. So when you look at acid-base balance, it is a tightly netted system where the pH is maintained between a strict range of 7.35 to 7.45 by three major systems. So the first system which comes into action the moment the pH drops within this range is going to be a physiological buffer system, followed by your renal as well as followed by your respiratory, then the renal regulation steps in. So what are the physiological? Because we know about the lung as well as the renal compartment, but we don't know much about the physiological buffer system. Physiological buffer system is nothing but the bicarbonate and carbonic acid buffer system, which gets activated seconds or minutes within the drop in the pH or the increase in the pH, and it tries to maintain the pH within the normal range of 7.35 to 4.5. And it is complemented by the other buffers, which are predominantly the intracellular blood buffers, which includes the hemoglobin and the other intracellular proteins, as well as bone, which is a major buffer carrying a significant amount of phosphate as well as bicarbonate in it. So these are all the buffers. These buffers get activated within seconds to minutes, and followed by in minutes to hours, the pulmonary regulation steps in, and the renal regulation takes hours to days. That's why you have, when you have a compensation for the respiratory acidosis and respiratory alkalosis, you have acute and chronic compensation, because kidney takes its own sweet time to compensate, and once it starts compensating, majority of the time it overcompensates, right? So there are four terminologies which you have to understand, which is acidemia, alkalemia. Acidemia and alkalemia, you say a terminology as acidemia and alkalemia when the pH drops less than 7.35 and when the pH drops more than 7.45 respectively. The process which leads to this is called as acidosis and alkalosis. Patient may have metabolic acidosis but not necessarily always have acidemia. In other words, patient can have a bicarbonate of 15, but it will be compensated by PCO2 of 25, so that the patient will be actually in a normal non-acidemic pH, but actually there is a metabolic acidosis ongoing there. So once the pH drops, it becomes acidemia. The process is called acidosis. Yeah, it's important to define that. Yeah. So when we define as acid-base balance, there are three major mechanisms by which the acid-base balance can be interpreted or it can be studied upon. So the most common one which we are all aware is the bicarbonate approach, the otherwise called as the Boston approach, in which it assumes that the only acid and the base in the system are the bicarbonate and the CO2. CO2 is responsible for H plus and the bicarbonate is responsible for the alkali, and it is based on the Henderson-Hasselbalch equation. So the next approach which came into picture is the Copenhagen approach, which is based on the base deficit or the base excess approach. How much amount of bicarbonate, alkali or acid is required to be added to the serum to make it a normal, to bring it to the normal pH. So which is not commonly used. The most commonly used is the Boston approach, followed by the most complicated and the most foolproof one is the Stewart approach. The Stewart approach is exactly the stark opposite of your Boston approach, wherein the bicarbonate is a derived variable and it is inconsequential. It doesn't take bicarbonate as a major ion. It considers the strong ions as the major ions determining the acid-base status of the patient. So it includes sodium, potassium, your chlorides, magnesium, calcium as the major ions. Along with that, partial pressure of carbon dioxide is one of the indicator for maintaining the acid-base status, followed by the non-volatile acid total ATOT, which is the total concentration of non-volatile acids, which includes your other acids in the system, right? So what we will be discussing about is based on only the Boston approach. For complicated acid-base disturbances, Stewart approach holds better than the Boston approach, but it is very complicated, so we won't be discussing about that. Yeah. So bicarbonate approach, as I said earlier, it is based on PCO2 and bicarbonate. Based on the Henderson-Hasselbalch equation, it equates PCO2 is equal to H2CO3. So H plus ions are based on PCO2, and bicarbonate is the base which both the interaction between the both maintains your pH. So which is given by the formula, pH is equal to pKa. pKa is nothing but 6.1, which is the dissociation constant for carbonic acid, logarithm of H plus HCO3 bicarbonate by PCO2. So it is dependent on only two variables. One is CO2, another is bicarbonate, right? So when you look at the algorithm for the pH and the H plus ion concentration, so it is a inversely related logarithmic relationship between the H plus and pH and the H plus ion concentration. In other words, when you have increasing H plus ion concentration, you have acidosis or the pH drops. And it is not a linear equation, it is a logarithmically inverse relation. So thereby, if you see the curve, it is a curved one. But the thing which you have to note here is when you have a pH of 7.1 to 7.5, it is near linear. In other words, when the pH is between 7.1 to 7.5, you can extrapolate this pH to H plus ion concentration. This is the basis upon which we are going to interpret our ABGs in the later step. So this is to keep in mind. So this is what you have. So if you look at it, at 7.4 pH, your H plus ion concentration is 40 nano equivalent per liter. Yeah. So sequentially, you add it by 0.8, you will get at 7.5 the H plus ion. If you multiply it by 0.8, 40 into 0.8 is 32. 32 into 0.8 is 25. So you can derive the H plus ion concentration indirectly based on the pH alone from a pH of 7.1 to 7.5. So with this basis, we will proceed with the interpretation of ABG. So for calculation purpose, what we will take it as is, even though the range is like that, we will have a pH of 7.4 as the normal pH, and any pH less than 7.4 is acidosis, and anything more than 7.4 is alkalosis. A normal PCO2 of 40, and the bicarbonate we are going to take it as 24. This is for calculation purpose. So there is a 6-step algorithm which we generally follow for interpreting or delineating a patient who has metabolic acidosis. So the first thing which you have to do is you have to check the validity of the ABG. Whenever you have a ABG, you have to check the validity for it. How do you check the validity? It is the extrapolation of the previous slides which you have told. So you have to first calculate the H plus ion concentration. How do you calculate the H plus ion concentration? It is given by the formula H plus is equal to 24 into PCO2 divided by bicarbonate. Okay, so you will get a value. So that value has to be subtracted from 80. When you subtract it from 80, you will get a 2-digit number. That 2-digit number should be the pH value of that patient. So you will understand it better with this slide. So this is a ABG, you have seen there. Okay, so you have a patient who has a pH of 7.32. The patient's PCO2 is 20, you can take it as. The bicarbonate is 10. So how do you calculate it? You have a value of 48, right? 24 into 20 is the PCO2 divided by 10 is the bicarbonate. You get a value of 48. You subtract 48 from 80 to 80 from, 48 from 80. What number you get? 32. So what is the pH of the patient? 7.32, right? So if this is accurate, then your ABG is valid. Either your if it is not there, then it can be two. Either your sampling is inappropriate or your ABG machine requires calibration. So before doing this, proceeding to an interpretation is going to be of no use. Yeah. So once your ABG is valid, then you have to look at the pH. If you have a pH of 7.4 less than 4, it is going to be acidemia. If it is more than 7.4, it is going to be alkalemia. Right? So you first define whether the patient is acidotic or alkalotic. So validity of the ABG, then acidotic or alkalotic, then you look at what is the primary disorder which is caused. So if the patient is having acidosis, so yeah, patient is acidotic. What is causing the acidosis? So you have to pinpoint whether it is a respiratory pathology or a metabolic pathology. So when you have a respiratory pathology, the pH as well as the PCO2 will move in the opposite direction. In other words, when the PCO2 increases, your pH decreases. No need to memorize this, you can usually delineate from it. When you have a respiratory acidosis, your PCO2 is going to be high. So the PCO2s and the pH travel in the opposite direction. Say if this patient pH is 7.3, your bicarbonate is less. So it is metabolic acidosis. It is with mixed acid-base disorders where you are going to face a difficulty. So this acidosis, bicarbonate is low, you are having a metabolic acidosis, right? So validate the ABG, check whether the patient is acidotic or not, then check which is the primary disorder, whether it is the respiratory disorder or a metabolic disorder. So then what is the fourth step you have to do? You have to look at the compensation. So invariably a compensation will set in, but never the compensation will bring the pH to normal. If the pH is normal by a compensation, there is a coexisting pathology associated. If you have a metabolic acidosis with a normal pH, probably there is a respiratory alkalosis coexisting with it. Or if you have a respiratory acidosis with a normal pH, probably there is a metabolic alkalosis coexisting with it. So you have to check for the adequacy of the compensation, so which is given by the formula. So this is the formula which you can remember But the easier one I would say is whenever you have a metabolic acidosis or a metabolic alkalosis, for each milliequivalent drop in bicarbonate. For example, if your bicarbonate is 14, what is the normal bicarbonate? 24. So your bicarbonate has dropped by 10 milliequivalents. That is the same mmHg of PCO2 it has to drop. Right? For easy calculation, not for exam purposes. If you are given an APG and if you have to do these formulas, it is going to be reflect. If you are having a metabolic acidosis or metabolic alkalosis, for each milliequivalent drop in bicarbonate or increase in bicarbonate, the same mmHg of PCO2 has to either increase or decrease as a compensation. But if you want to calculate, this is the formula, PCO2. The subsequent slides, I will show the previous ABG, the calculation would have done. You can look at it, right? So when you have a respiratory compound, respiratory pathology, you will have acute and chronic. Because usually the renal correction, as I said, will take hours and the complete compensation will happen by days. So when you have a respiratory acidosis or a respiratory alkalosis, the compensation for acute respiratory acidosis is going to be, you can remember it by the mnemonic 1425. For every 10 mmHg increase in PCO2, in acute respiratory acidosis, 1 milliequivalent of bicarbonate will increase. If it is a chronic compensation, 4 will increase for respiratory acidosis. If it is going to be respiratory alkalosis, in respiratory alkalosis, you are going to have a drop in PCO2. So for every 10 millimeter Hg drop in PCO2, in acute setting, you are going to have a 2 milliequivalent change in bicarbonate, whereas in chronic one, you are going to have 5 milliequivalent change in bicarbonate. So 1425, right? This is for respiratory acidosis and respiratory alkalosis. So you calculate your compensation so that you can label them as a single acid-base disorder or a mixed acid-base disorder. So just look at the, going back to the slide, look at this ABG. You have a PCO2 of 20 and you have a bicarbonate of 10. Okay. So we are going to calculate the compensation for this patient. Yeah. So you have bicarbonate of 10, 1.5 into 10 plus 8 is equal to 23. What was the PCO2 of the patient? PCO2 of the patient was 20. So plus or minus 2, even if you take it, there is definitely some amount of respiratory alkalosis associated with that. So probably patient may be running a fever, patient may be anxious, so he is washing out CO2 more than what is required, right? So there is a mixed acid-base disorder too. So as soon as you correct the compensation, if you have a metabolic alkalosis as the primary pathology, the next thing which you have to look at is the anion gap. So the anion gap actually is a misnomer because the majority of the ions which are measured are cations. In other words, it's a discrepancy between the measured cations and measured anions, whereby you get a difference which is called as the unmeasured anions, which is reported as the anion gap. As per electrical neutrality, the cations will always be equal to the anions. So it is the discrepancy of the measured anions which we calculate as anion gap. So it is given by the formula sodium plus potassium minus chloride by bicarbonate. You can either take potassium in it, or as a classic measurement of anion gap, you can leave out potassium also. Then it is going to be 10 plus or minus 2. If you include potassium, it is going to be 12 plus or minus 2, right? So you have to calculate the anion gap so that you can differentiate it between high anion gap metabolic acidosis and normal anion gap metabolic acidosis, right? So when you have a high anion gap metabolic acidosis or when you have a normal anion gap metabolic acidosis, if you have a metabolic acidosis, what you have to do is the majority of the unmeasured anion is your albumin. Especially in a critical care setting, I will have majority of my patients with a hypoalbuminemia. So you have to calculate the anion gap corrected for the albumin. So that is the corrected anion gap, wherein you add a correction factor of 2.5 for every 1 gram drop in albumin from the normal value. So if you look at this patient's calculation, if you look at this patient's anion gap without albumin correction, it is 18.5. Still it is high anion gap. If you add an albumin correction also, it becomes 21. Which is a high anion gap metabolic acidosis. If you have reached till this stage, you can come to a diagnosis of either of these things. Your patient is going to have either of these things, which is given right? So when you have a high anion gap acidosis, which is not fully explained by your exogenous ions, like your ketones. In this patient, it is very clear. If you look at the ABG, this is very clear that you have a lactate of 10 there. So you need not worry much about it. This patient has a high anion gap metabolic acidosis secondary to lactate, but there is a catch to it. I will discuss in the next slide, right? So that is a lactic acidosis. So if you are not able to pinpoint to the reason for the high anion gap, then you have to look at something called as osmolar gap, right? So why is this osmolar gap important is, if you have a suspicion of intoxication or acute presentation, these exogenous ions may be exogenous osmoles which are added into the circulation. So you have to calculate the osmolarity. And the normal difference between the calculated and the measured osmolarity should always be less than 10. If it is more than 10, there are exogenous osmoles included in the system. So you have to rule out these toxins, ethylene glycol, ethanol, methanol, all these things you have to rule out. So this is osmolar gap. And if you have a mixed acid-base disorder, you have to complete this analysis by looking at the delta gap or delta ratio. There are two things which you can look at to rule out a coexisting normal anion gap metabolic acidosis or metabolic alkalosis in case of a high anion gap metabolic acidosis. What I have chosen is the delta ratio. Delta ratio is the ratio of delta anion gap by delta bicarbonate. See, this is simple. This is for remembrance purpose. If you can show it, if the exogenous ions which you have added have neutralized equal amount of bicarbonate, what will happen? The ratio will become 1. So if the ratio is 1, there is only pure high anion gap metabolic acidosis. If the bicarbonate is reduced more than what it has to be, so then there is another ion which is decreasing the bicarbonate. So whereby what will become is, your denominator will become more, because the difference of the HCO3 will become more. So the denominator will become more, so the ratio will drop. So there is a nagma along with the hagma. If the denominator becomes small because of exogenous bicarb added to the measured bicarbonate, your ratio is going to become 2. So there is a coexisting metabolic alkalosis associated. So this patient has a ratio of 0.64. So probably this patient has a high anion gap as well as normal anion gap metabolic acidosis. The reason this patient has a normal anion gap acidosis is he is also having an AK. He is having a creatinine of 5 and he is not making any urine, and we dialyze this patient. So that is the reason why he has a normal anion gap acidosis also. So this is how we interpret a metabolic acidosis, and these are all the most common causes of normal anion gap. This is given by the formula Hardups. But the most common one which you see for the normal anion gap acidosis is going to be your loose stools, or is going to be your renal tubular acidosis, followed by your acetazolamide use in selected population, or in case of gastroureterostomy surgeries. Yeah, right? So evaluation of nagma, when you have a pure nagma, you have to differentiate whether the loss is from the gut or the urine. Okay, so how do you differentiate it? Is by looking at the urinary anion gap. If your kidneys are functioning fine, what did the kidneys do is, your kidney will excrete the excess acid through the urine. So how it will excrete it? It will excrete it as ammonium chloride. So NH3, NH4 plus Cl it will eliminate as. What is the formula for urine anion gap? You cannot calculate the ammonium, so you can calculate the sodium and potassium minus chloride. So NH3Cl will be the elimination. So your chloride will become more. So if your urine anion gap is negative, it indicates that your kidney is functioning well. In other words, it is the GI loss which is the reason for the normal anion gap acidosis. If your urine anion gap is positive, then your kidneys are not functioning well. So probably the reason for the normal anion gap acidosis is going to be your kidneys. So you have to work up based on that. This is in a nutshell. You can go through it, right? Fine. So the catch of the first case is, just a minute, I'll finish it in 2 minutes. Yeah. So this is the case 1. This is the case which I discussed. This is the ABG of the real patient which we saw 10 days back. This is the ABG which I saw on admission in the left corner. And the second one is the ABG which I displayed there. The third one is the ABG. Right? If you keep looking at it, this guy's history is a 65-year-old male diabetic who presented with loose stools with AKI to our ICU with the tachypnea. But he was hemodynamically stable, but he was acidotic and tachypnic. Numbers wise, infective workup was negative. We did the imaging was negative. But he was running very high, severe high anion gap acidosis, right? So then we looked at the ABG, it was serially worsening. He was fluid depleted, we volume resuscitated him, he was not making urine. So the idea was to dialyze him. At a pH of 10.5, I start him on dialysis. After 2 hours, after 6 hours, I repeat ABG, the acidosis worsens. So we were perplexed actually what is happening there. We were thinking about starting him on CRRT. That is what we were thinking about. At that time, the patient attender told he used to carry his sugar tablets in his packet. That is what the history told by the attender. Then we looked at the history and looked at what are all the medications he was taking. He was taking Gemmer as well as Glinase MF. And he was taking 3 tablets of it each. So he was taking nearly 2 grams of metformin each TDS, 2 grams of metformin TDS, which did not manifest any lactic acidosis as long as his kidney was functioning well. The moment he started having dehydration with loose stool, what happened was his kidney shut down, his metformin caused lactic acidosis. So what we did was he started him on normal, not hemodialysis, we give him a sled for 8 to 10 hours. And then that was the ABG in the last, which was 4.4. So ABG can also be diagnostic. It is not only for monitoring the patient. So the series of ABGs gave us the diagnosis of probably a MALA, metformin associated lactic acidosis. So metabolic alkalosis I will not touch upon. So the major thing in metabolic alkalosis which you have to rule out is whether it is chloride responsive or chloride unresponsive. Chloride responsive, you are going to fluid resuscitate them. Chloride unresponsive, you have to look for the syndromes, right? Respiratory acidosis, I will not go into the detail. Invariably, it will be because of either neuromuscular disease or by central nervous system dysfunction, or in elderly patient, it is going to be your dead space or your restrictive lung disease. Respiratory alkalosis invariably is secondary to any systemic illness, either because of fever, anxiety, or any respiratory stimulant drugs. Or in pregnancy and liver disease, invariably when you look at respiratory alkalosis, CLD patients always have respiratory alkalosis. Right? Case 2, just in a, this is again an interesting case where a case of 40-year-old ITP patient was presented to our hospital with mild breathlessness, which has been progressing for 2 weeks. So what we did was we looked at the saturation was 85 in room air. We put her on 5 liters of O2, it was 85. We put her on NRM with 10 liters of O2, it was 85. And when we put her on 15 liters of O2 also, it was 87. We were not sure, there was no RV dilatation, there was no tachycardia. She was breathless, but the lactates were normal, right? So this is not the real ABG of the patient. I somehow missed that ABG. So this is where what I told as co-oximeter comes into picture. She was a known case of ITP. She is a refractory ITP for which I think old age practice of dapsone was prescribed to her and she was on dapsone. So dapsone is a drug which is more prone to, it's an oxidizing agent which can cause significant incidence of methemoglobinemia. So what she was suffering from was methemoglobinemia. Because when we took out the Y, how did we suspect it is, when we took out the ABG for that patient, the saturation in the ABG was 99%. Right? It is for the PGs to go and look at what is the R ratio and why her oxygen level was, saturation level in the pulse oximeter was fixed at 87. So this is something called as saturation gap. So the pulse oximeter saturation is something called as functional saturation, whereas the co-oximeter looks at fractional saturation. So this is called as the saturation gap. So the functional saturation is 87, but the fractional saturation is 99. So when you look at the co-oximeter, it gives you the methemoglobin is 31%. So if they are asymptomatic, withdrawal of the drug will be sufficient, and if they are symptomatic, giving methylene blue after looking at G6PD levels will cure the condition. If you have, especially in this part of the world, if you have a lot of incidents of pain thinner poisoning, pain thinners are prone to have toluene and nitrobenzene. These are also oxidizing agents. You will have high incidence of methemoglobinemia in these patients, right? So the case 3, with this I will finish. So this is not commonly seen in Indian context, but if you are appearing for European exams, it is important. So there is something called as, this is a young guy who is a AC mechanic who presents to the emergency with acidosis, altered sensorium, and in a very toxic stage with hemodynamic instability. And when you look at his lactate is very high. The thing to notice here is his osmolality is also very high, right? So the lactate is not the pure lactate, but there is some exogenous osmol added to it. So which gives us to the another gap. Everyone would have been aware of the osmolar gap. There is something called as lactate gap. What is lactate gap is ABG machines measure lactate by a method called as lactate oxidase method, which can falsely interpret glycolic acid, which is a metabolite of ethylene glycol. Ethylene glycol is a common antifreeze which is used in the AC industry. So the consumption of which will create high anion gap metabolic acidosis with false lactic acidosis manifesting as lactate gap with the high osmolar gap. Right? So if you look at these patients, lab value of lactate, which is done by lactate dehydrogenase method, their lactate will be normal. So why is it important is it is again diagnostic, and if you subject them to dialysis, they will improve. Right? So in summary, ABG is by far the most valuable point of care investigation for an intensivist, and never treat a patient by the ABG, treat the patient with the clinical context, otherwise you will never reach any endpoint. And a systemic approach, how you do for an ECG is mandated for doing an ABG also. And if you do it in the proper way, ABG is even more fascinating than ECG. Thank you.
Thank you so much for your elaborate discussion. Any questions from the moderators?
Thank you, sir. The ABG interpretation is well explained with the case series within 20 minutes. So I think the PGs get benefited by your presentation. Actually, our respiratory medicine textbook says respiratory failure is not a clinical diagnosis. It's a laboratory diagnosis based on ABG. Thank you for the very well presentation. Thank you, sir. Any doubts from the audience side?
Thank you, Dr. Ayyappan, for your excellent presentation. I'm having two questions. One is, how often you repeat this ABG in critical care patients in ICU? What are the limitations for this ABG?
It has its own limitations. That's, as I said, it should be linked with the clinical context. A single ABG without a patient profile doesn't make any sense. Regarding the frequency of ABGs, it depends on for what indication I do. If I'm doing it for a patient who is a ARDS patient on ventilator, I do it 8 hourly. If the patient is similarly not responding to the treatment, if this patient after initial dialysis, if the lactates have improved and if the patient was recovering, I may not have repeated an ABG at all. But since it was deteriorating, I need to get on top of why he is deteriorating. So the ABG, the frequency of ABG is determine the patient and the response to treatment. My motto whenever I do a ABG as well as I do an intervention is to come to a clinical diagnosis and a label for the patient. The moment I get a label for the patient and I have initiated them on appropriate treatment, I will do only one ABG post that to know that, yeah, my diagnosis is right. The moment my diagnosis is right, his ABG will show improvement. The moment his ABG shows improvement, then I'll be a bit more calm that he doesn't require further close attention. So my frequency of ABG comes down. If I am in the wrong path, then probably I will repeat it, but never more than 6 hours a day. Only time when we do it very commonly is when the patient is on ECMO, VA ECMO and VV ECMO, then we have to do it 4th hourly to know our sweep gas flows and to know how much flows we have to keep. That is an indication where we do it 4th hourly. Or when a patient is on CRRT with a citrate, where we have to know the ionized calcium, we do it 6th hourly. Other than that, in general ICU patients, probably daily or 2 times a day is one. The flip side to it is it has the more the variables which are being displayed, the more costlier it has become. When I started my critical care practice, ABG was 1,200 rupees. Now it is 3,500 rupees with the additional variables. So that is one thing.
Thank you. I thank Aruna Cardiac Care for arranging this wonderful session, Summit. Thank you.
So we are continuing to the last and the final session of today. So the topic is on continuous glucose monitoring from specialist to primary care. So I call upon Dr. Suresh Kumar sir, Dr. Ayappan sir, Dr. Rajwell Murugan sir, Dr. Meenakshi Sundaram sir, Dr. Sivasailam sir, Dr. Sangamitra ma'am, Dr. Shankar sir to the stage for felicitation. And I kindly call upon Dr. Arunachalam sir, Dr. Natarajan sir, Dr. Ayappan sir, and Dr. Alan Bini sir to stage to hand over the momentum. So I kindly request Dr. Arunachalam sir to felicitate Dr. Suresh Kumar sir for his extraordinary speech. I request Dr. Natarajan sir to felicitate Dr. Rajwell Murugan sir. I next request Dr. Alan Bini sir to hand over the memento to Dr. Meenakshi Sundaram ma'am. I next call Dr. Arunachalam sir to hand over the memento to Dr. Ayappan sir. And I call Dr. Rajwell Murugan sir to felicitate Sangamitra ma'am. I call upon Dr. Suresh sir to felicitate Dr. Sivasailam sir. I request Dr. Sangamitra ma'am to hand over the memento to Dr. Shankar sir. I thank all the distinguished speakers and moderators, chairpersons. So we're going to the final and session of today, which is CGM, Continuous Glucose Monitoring from Specialist to Primary Care by Dr. Natarajan sir. I call upon Dr. Alan Bini sir, and Dr. Ramesh Babu sir to chair the session. And I also call upon Dr. Balamurugan sir and Dr. Anand sir to moderate the session. And I would like to introduce a speaker, a distinguished speaker, Dr. Natarajan sir. He served as a former professor and head of the Department of General Medicine at Madurai Medical College and Government Rajaji Hospital, Madurai, where he played an extraordinary role in teaching, mentoring, and guiding countless undergraduate and postgraduate medical students. Over several decades of medical practice, he has earned deep respect for his outstanding clinical judgment and bedside teaching excellence and commitment toward academic medicine. His contribution to physician training and internal medicine practice has made him one of the most respected senior academicians in Tamil Nadu medical circles. Over to you, sir. Thank you. Sir, I request Dr. Rajesh Babu sir to chair the session.
President, good afternoon, all of you. Till the slides are getting ready. In this, I think most of you are postgraduates. How many of you are conversant with using this continuous glucose monitoring? Because science is very much evolving and medicine is much more evolving faster. If you don't get yourself updated, particularly with the use of devices, it is very difficult for you to practice, to stand in the ocean of practice. So, because the patients are very much aware of these devices. Is it ready? Okay, with greetings and blessings from Lord Meenakshi Temple City, and thanks to the organizers for giving me this wonderful opportunity. I am going to present this short presentation on continuous glucose monitoring for physicians. So this is what I was asking. So are you a routine user or an occasional user or interpreter only or rarely use CGM? So I think most of us will come under occasional user or interpreter, most of us. But in the future, probably in another 2 to 3 years, I think all of us will become a routine user, because without knowing CGM, it is very difficult to practice diabetology, particularly type 1 DM. Type 2 DM also, there are some indications. So you should be well versed, because it's very simple. It is not as complicated as ABG. It's quite complicated ABG. It's very difficult for us to follow unless you are super brilliant like I am. But this is very simple. So when HbA1c is very much available, what is the need for CGM? This is a classical example. So both patients have got a HbA1c of around 7.2. But this first patient is a flat curve. There is no spikes, troughs, or valleys. But this other patient who has also got the same HbA1c 7.2, he has got troughs and the peaks and troughs. But that is called as glycemic variability. And your HbA1c doesn't pick up this glycemic variability. And that glycemic variability is going to do endothelial damage that is responsible for most of your vascular complications, macrovascular, microvascular complications. So the same HbA1c for both patients, that patient will fare badly when compared to this patient. So HbA1c just gives an average for the last 3 months, particularly for the last 6 weeks. It doesn't go into the intrinsic thing of the so-called glucose metrics. So this is not done by HbA1c. So HbA1c is still there, but all is not well, even though the HbA1c is near normal. So HbA1c cannot be displaced, but it should always be supplemented with CGM. So that is the main crux of today's presentation. So what is this CGM? It doesn't measure the capillary blood sugar. It measures the interstitial fluid sugar. So there's some lag of time between these two fluids, around 10 to 15 minutes. That is one caveat, but even then it doesn't matter. Second is the equilibrium is fastly achieved in most of us, but when there's a rapid change in the blood sugar value, as in post-breakfast, particularly in pregnancy, sometimes the equilibrium is not reached, so it will take some time, so you can have an erratic value. So these are some 2 or 3 caveats. So the warm-up period, so once you wear this CGM, the warm-up period is anywhere between 1 to 3 hours. At that time also it is not that much accurate. So, but for some few caveats, CGM has got its own plus, and it has got auto alerts. The real-time CGM, auto alerts. Whenever the patient goes in for hypoglycemia, it will give an alert. Whenever it goes for hyperglycemia, it give an alert. And not only that, the trend, even before, because even before reaching the hypoglycemia, it will give an alert that the patient is probably going to develop hypoglycemia. So that is the time we have to interfere. Because after developing hypoglycemia, there's no point in, because they can go for neuroglycemic symptoms. So these are the advantage of this CGM. And for the beginners, there are 2 types of CGM available. One is called real-time CGM, another is called flash or intermittent CGM. So both of them have got their own advantage and disadvantage. The display is always continuous. It is always on, 24 hours, 24 into 7. That is only on demand. That is The patient will be wearing it. If at all you want to read, you have to go and place that reader and then find out the value. So to understand simply, all the CGM will have a sensor. That sensor is placed in the abdominal or in the arm. That will sense the interstitial fluid sugar. Then that is transmitted. There's a transmitter from it, and there is a receiver or reader. So there are three components for CGM: a sensor, a transmitter, and a reader. And it is 24 hours functioning in real time. And it is only on demand. It will be functioning, but you cannot read all the time in flash. You have to place a reader and then find out. That is the difference between these two. And the alerts are integrated with real time, and it's not integrated with flash. And it is best for hypoglycemia. Real time, hypoglycemic risk people, it's better to wear this real time. And the flash, it as an outpatient because it is not much of burden to the patient. So it will not give much alert. It will not compromise his day-to-day routine. So that is good for OP patient. And patient burden and data control, this is not of least importance. So what is the usual time? How many days you monitor? The conventional time is 7 to 14 days. All these monitors can be placed by the patient himself, self-placement. But there are good monitors called EverSense monitors that can be placed for 365 days. But that has to be placed by a healthcare provider. So that will be better. That is not very much available in India, but abroad they use that. 365 days it will be there monitoring. Real time will monitor every 5 minutes your blood sugar. And flash will monitor every 15 minutes your blood sugar. So these are the basic differences. The duration of application is usual conventional 7 to 14 days. Very rarely we go for so-called type 1 DM or during pregnancy, 365 days that can be kept. That should be placed only by a healthcare provider, not by a patient himself. And who are the ideal candidates who deserve a CGM? Number one will be all type 1. So if you have got a type 1, today make it a point, better go for a CGM. That is number one, because you know hypos are quite common in type 1. Hypers are quite common. It's very difficult to control their milk, very difficult to time the insulin. So once you put them on CGM, the outcomes are really good, and the HbA1c control is good. And so-called the glycemic variability comes down once you monitor them with CGM. And they are aware that someone is monitoring. And all insulin-treated type 2 DM should have a CGM at least once or twice in their lifetime. And the third is recurrent hypoglycemia. So most of you from government colleges, you must be aware that at least every admission we get 2 or 3 hypoglycemia patients. With sugar around 30, 35, they go for what's called the medullary stage of hypoglycemia. They don't recover from it at all because of the hypoglycemic unawareness. So that's a condition called HAF, hypoglycemia associated autonomic failure. So recurrent hypoglycemia blunts the autonomic nervous system. So normally once you develop hypoglycemia, first you'll have the sympathetic overactivity, tachycardia, tremor, hunger, sweating. Then if you don't address at that period with some intake, then the patient develops what is called as the neuroglycopenic symptoms, unconsciousness, drowsiness, seizures. In HAF, they bypass the sympathetic stage and directly end up with neuroglycopenic stage. So in that individual, this is very ideal because this acts as that alert, sympathetic alert. So they will not have sympathetic symptoms, but once the blood sugar drops down to 70, it will give an alert. So the patient can have something. And pregnancy with DM. So all of us do know the strict control of diabetes. This was most of our questions by our examiners. 2 situations were strict control, very strict control. One is pregnancy, another is renal transplant. So pregnancy, these people should be put on. There is some caveat, as I told you, because the post-breakfast pregnancy diabetic, they will have a large excursion. So that can be misinterpreted by a CGM at that point of time. But even then, CGM is a must in pregnancy if the fetal outcome is good. To have a good fetal outcome, CGM is a must. And these 5 are the absolute indications. So moderate, high glycemic variability. Even in type 2 DM who's only on OAD, not on insulin, if you have got high glycemic variability, put on CGM and find out what is the cause for the high glycemic variability, and you can cut short the complications. And the basal insulin titration to pick up what is called as the dance phenomenon, Someyagi. For all of us do know. One you have to up titrate the dose, one you have to down titrate. Unless you do put a CGM or to take a blood sugar by 2 a.m., 3 a.m., 5 a.m., it's very difficult. So CGM will be helpful. and that is again its lifestyle. So, like your BP regarding 120/80, what are the numbers you should remember in CGM? Number one is time and range. So, at least 70% of the reading, the patient should have the time and range sugar. What is the time and range? Anywhere between 70 to 80. So, he is permitted to have a blood sugar of 70 to 80, and it should be at least 70 readings, 70% of the readings should be in this. Second is time below range. That is anything less than 70 is time below range. So only 4% of the reading or less than that should be time below the range, because this is more dangerous. So if it is more than that 4%, you have to change your prescription. And time above range. Time below range, there are two types. One is time below is less, 56 to 70 is stage 1 or level 1, and 56 and less is stage 2 or level 2 hypoglycemia. Time above range, more than 180. 180 to 250 is stage 1 time above range. 250 and above is stage 2 above range. So so at least 25% of the recording or less than that can be time above range. But with more than 25, again you have to change the prescription. And that is the last is very important. Percentage of coefficient variability. So it should be less than 36. Less than 36. Because that is the thing that is going to damage the endothelium and produce all complications. So that these peaks and troughs, they are picked up by this coefficient variant. But this is for a non-pregnant, healthy, young diabetic. But we have to change the system or change the numbers for pregnancy. And any postgraduate can say the answer. What should be the time and range for a pregnant female? So it is 63 to 140. Because it should be much more strictly controlled, because there are different metrics for a pregnant. And if a frail elderly, you go on the other side. You can go by around even 100 to 200. So you can change the system according to, change the tune according to the patient. This is a conventional, but pregnancy it is entirely different. So it is 63 to 140 for a pregnant, that should be time and range. And anything below 63 is hypoglycemia, and more than 140 is hyperglycemia for a pregnant female. And once haven't seen the recording, so because we'll not have much time to go through all the things in the record. So what priority you should give? First priority is to how much time the patient had hypoglycemia, because that is more dangerous. So in this patient A, it is time below range was that less than 70, 18% here, which is too high. So here the second patient is B, target is B. So first priority, once you go through the reading like ECG, you just find out whether the patient had hypoglycemic episode or not, and if that be the case, how much percentage, has it exceeded that 4%. Second priority is time in range. So whether at 70% time he was in range or not. Only the last priority is for hyperglycemia, because hyperglycemia is not going to produce acute damage, it's going to produce chronic damage. That is also important. But prioritization is like this. And so first check your data adequacy, whether it has been done for 14 days. 1 day, 2 days will not be of much help. And second is hypoglycemia, how many times he had hypoglycemia, and timings of highs and match patterns. So whenever the patient had hypoglycemia, was it because of less meal or more insulin? Similarly, for hyperglycemia, more meal or less insulin, and the timing of insulin, because that matters a lot. Even timing of tablet also matters a lot. And action should be always one or not. So don't drastically change the prescription based on CGM. Do only final tuning once. Then probably with the second CGM, we can do the further tunings. So this is called the ambulatory glucose profile, wherein this gives you a 10 for over 24 hours. So whether the patient is in time and range for 70% of the time, or when he had hypoglycemia, when he had, this is the usual thing we get in ambulatory glucose profile. So how are you going to translate the CGM values into your treatment protocol? So whenever there's a nocturnal low, it is because of excess basal insulin. So you have to reduce the evening or basal dose. Nocturnal low, it is picked up only by CGM, unless the patient is an inpatient and the staff nurse does that. We can do it by your blood glucose monitoring. But otherwise, if the patient is at home, this is the thing. And if it is an afternoon rise, either it should be a missed bolus. We know what is bolus basal regimen. So missed bolus can produce afternoon rise or a insufficient bolus or a lunch pattern, a different lunch pattern. If it's going to be a persistent afternoon spike, probably his lunch pattern is different. He's having a probably heavy carbohydrate diet in the lunch. So you have to titrate according to that. And if it is a breakfast spike, because this is the thing, most of, if you want to diagnose a diabetic for the first time, if you can afford only for one test, that should be a post-breakfast. Because at that time only the counter-regulatory hormones, cortisol, adrenaline, everything will be high and insulin will be low. So you can pick up them quite early. That took specifically 90 minutes after breakfast is the time where all of us will have the highest blood sugar value in our body. So post-breakfast, again, it's either whether it's because of the increased carbohydrate load or because of the bolus mismatch. And the last is weight swings. So again, we have to find out whether because of his lifestyle, whether he does more exercise at particular point of time, take excess food. So type 1, it has transformed the treatment of type 1 CGM. So the benefits you achieve is it reduces the unexplained hypoglycemia, and it supports precise insulin timing, useful for both, not only for pumps, for multi-dose insulin therapy. It detects the dawn phenomenon. Dawn phenomenon, Somyagi, again, you not repeat. So this is a very important thing as far as type 1 is concerned, no doubt about type 1. It's not only for type 1, also for type 2, because again, so how much lunch is, how much carbohydrate is taking in the afternoon, and what is the blood sugar value. So for basal insulin titration, for intensification decisions, for lifestyle coaching, for unexplained symptoms, again, this is the important thing. So the last thing, get it good HbA1c with fatigue. Anyone who has got an excellent HbA1c, but again is fatigue. Probably it is because of frequent lows and highs. So once you go to a CGM, you can find out the cause for his fatigue, and you can modulate the dose. So again, to emphasize, it is a useful tool in pregnancy, during fasting or Ramadan, or during exercise, and for care transitions. So one or two cases I will finish up. A good HbA1c patient, nocturnal hypoglycemia. So HbA1c will say the patient has got a good average control. It doesn't pick up the nocturnal hypos and all. Two hypos and two hyper will neutralize, and the patient will have normal HbA1c. So this is a 54-year-old male, type 2 DM, basal bolus, 7.2, well controlled, morning fatigue, headache, occasional night sweats. So if you do a CGM, you'll have that so-called nocturnal hypo. So this is over basalization, recurrent nocturnal lows. So again, in the morning, you'll have rebound hyperglycemia. This is classical Somyagi, so you have to reduce the basal insulin. So Somyagi can be diagnosed only by this CGM. And so case 2 is 38-year-old female, type 1, 15 years, basal bolus regimen, A1C 6.9, post-meal fatigue. This declines after meals, then overshoots. So you can find out, this is before correction, he had a spike. Then downstroke. Then after correction, identify with CGM, and if you just find large phosphate excursion with rapid early drop, bolus timing mismatch. He was taking the insulin some 5 minutes before. So some insulin like your analogs or Fiasp can be taken 5 to 10 minutes or during breakfast or after breakfast. But your conventional insulin should be taken at least 20 to 30 minutes. So there's a mismatch between the insulin initiation and so in the reality, set the indication, explain the expectation, teach alarm, schedule early review and document changes. And the pitfalls, as I told you, the interstitial readings, the lag began by 10 to 15 minutes. And when the patient, in the night when he sleeps, when he compresses, when he sleeps in the prone position, he may compress and he can have falsely erratic value, inadequate wear. We should wear at least 70% of the time. And don't jump into a conclusion with a single value. The single value can be erratic. Always you check with your blood sugar value at that point of time, and alert fatigues. So sometimes the patient may be very much disturbed by these alerts. So you can down tune the alerts for that particular patient. So CGM is a pattern tool, not a number tool, and start with hypoglycemia. So whenever you read, first to find out whether patient has hypoglycemic episode or not, and it act on trends. So easily you can find out before the patient develops hypoglycemia, act on trends. So this is a simple quiz I made it. So which metric best reflects glycemic variability? It is a, so if you're told, if you read coefficient variability is the best metric to find out. And first thing to grade this hypoglycemia. And what pattern suggests over-basalization is recurrent nocturnal lows. When the patient has got recurrent nocturnal lows, he has got excess basal insulin. And which data is generally adequate. 14 days is only adequate. Less than 14 days, if you ignore that reading. And what's the most important step after reading CGM is document on 2 or 3 specific, not more than that changes. Don't change the whole prescription with CGM. I think that's the end of my presentation. Again, thanks for the wonderful opportunity. If there are any questions, I will be happy to answer.
Thank you so much for the excellent presentation, sir.
Thank you, sir. Nice presentation. See, this is what I want to tell you. When I asked sir this topic, sir was also suggesting one other topic, but I stick on sir to talk this topic because, see, without knowing diabetes, nobody can treat any patient. One. Number two, without knowing obesity, you cannot treat any patients. I tell you all the postgraduates. CGM, how this happens, one of my friend working in Qatar, he is an engineer, +2 classmate. He came and he talked to that he has put his mother on CGM and what is interpretation. Then I didn't know anything. So I cannot say that I'm cardiologist, you go to diabetologist like that and all in 3-tier city. So that is the awareness you must show. You know how it looked like? Like the small coin like that. So initially I thought something big like a halter like that, they will be around abdomen and all. So most of the time, inner side they put that and monitor. Sir, and one doubt. One endocrinologist was telling me that for type 1 is good and other things, pregnancy. If you put for type 2, or even the phone, they can find out, no? They scan that and they eat all nonsense things. They look at after 3 hours and they see that there is no sugar rise. So they're going on without the concept of other than sugar. Sugar கூடலன்னா they were eating all nonsense things. So that's why it needs a lot of, you have to talk to the patient before. Another doubt, sir, if a patient going hypoglycemia, will you ask the patient to note down his time of meal? Recommend?
That's once he comes for review, we will just find out what is the cause for hypoglycemia. Probably mismatch, most of them it's a mismatch between the insulin and meal.
நீங்க மாட்டி விடும்போது சார் நீங்க சொல்வீங்களா உங்களோட மீல் டைமிங்ஸ் எல்லாம் கீப் பண்ணனும்?
Definitely. That's a must. Okay. That's a must.
Thank you, sir.
Excuse me, sir. Sir, in particular in pregnant patients, there are studies to show that glycemic variability plays a major role in macrosomia. In spite of the patient being in time in range, glycemic variability will, the increase of more than 40 milligram per deciliter will definitely cause, there is more chance of macrosomia. Can this CGM identify this glycemic variability?
The indication.
And one more question, sir. Are there drugs that can particularly address this glycemic variability?
I'll answer the first question. I couldn't get your second question. First question, the diabetic, pregnant diabetes is the absolute indication. And once you put them on CGM, the glycemic variability can be easily picked up. As I rightly told, glycemic variability is going to end up in all fetal complications. Macrosomia, neonatal hypoglycemia, all these things. And you can very well pick it up when the patient is even on continuous subcutaneous insulin pump or your basal bolus. And if you can adjust, the outcomes are very good. So first CGM indication will be type 1 DM. Second will be pregnancy. These two are absolute indications for CGM because the outcomes are better. And most of the studies have been done only on these 2 occasions. As rightly pointed out, type 2 DM, the CGM studies are not that much done. So we are not coming with very much results. But we are doing it practically, but studies are not done mainly for type 2 DM. For pregnancy and type 1 DM, absolutely indicated. And macrosomia, everything has come down with the use of CGM in a pregnant female. That is the post-breakfast, that's the most important thing in a pregnant female. So now the concept is you can split the breakfast into 2. So if the patient is having 4 idlis, let they take 2 idlis at 8 o'clock and another 2 idlis at 10 o'clock. CGM has identified that. So if that be the case, it will be blunted. You will not have that glycemic variability. So what's the second question? I couldn't get it.
drugs that can address this glycemic variability. Medicines that can address this glycemic variability, sir, that can cut down.
Certain drugs can interfere with glycemic variability. I remember as PHC, paracetamol, hydroxyurea, vitamin C. When the patient consumes these drugs, they can interfere with their CGM. So better see to that. Acetaminophen is not paracetamol. When the patient is on paracetamol, don't interpret. Hydroxyurea, don't interpret. And vitamin C. They alter the values for CGM. So these three drugs you should have a checklist before.
Sir, what is the actual cost for the patient, sir?
CGM, I told you it's used for 7 to 14 days. It is anywhere between 5,000 to 8,000. And that's 365 days, I'm not aware, it is not available in India. That is implanted by a this healthcare provider. This is anywhere between this. And the patch costs around 4,000. So the patient can buy if at all, if you have got a medical shop, you can just stock that patch in the medical shop and you can sell it and the patient can wear it. It is very simple. Either wear it in the abdomen or in the arm. So the cost is not prohibitive as of now.
Is there any disadvantage in using CGM in patients who are too morbid obesity with respect to body surface area and thickness of the adipose tissue at the site of stick area?
No. The sensor is good enough to pick up the interstitial fluid.
Thin patient, heavy patient?
Not much, not of difference. Obesity is not a pitfall to use CGM. Obesity and lean, they are equally. Only that obesity, probably when they lie on the prone position, they will compress much. So you can ignore certain readings. So only I insisted, don't take an action based on one reading.
Yeah.
So certain readings may be erratic. But as by and large, the readings are reasonably good. Yes, very well. It's definitely they can take a bath, they can go anywhere, but not in Kutralam.
Will you advise routinely all chronic diabetics with target organ damages, CAD, CKD, CVA, etc.? Whether we have to advise? Definitely, because they had gone for the complications because of uncontrolled diabetic state.
So once the damage is done, now the problem is not to prevent the target organ, already it's done. Now the problem is hypoglycemia. That will worsen the damage. Particularly cardiac autonomic neuropathy, sir must be aware, SCAN. Cardiac autonomic neuropathy is one condition. They will have autonomic neuropathy and they will have cough, hypoglycemic autonomic failure. So they will not be aware of the hypoglycemia at all. So the purpose of CGM in this situation will be to reduce the incidence of hypoglycemia and to give hypoglycemia alert. So cardiac autonomic neuropathy is a known entity, and so only it's silent infarction happen in these people. These people will have autonomic failure also. So hypoglycemia will not be recognized. They'll bypass the sympathetic. Directly end up, because in GH we get, at least they take up in the vegetative state. They come with 30 milligram of blood sugar. We cannot recover them at all. 3 days, 4 days, they will be in ICU. We can increase the sugar to 200, 300. But once the damage is done, it's done. So they take the body home as a vegetative state. So hypoglycemia is more dangerous. So in particularly in CKD, I think it's a must because CKD are prone for hypoglycemia. So for recognition of hypoglycemia, the yearly established CAD, CKD, all these people, it's a must. Thank you, sir. Thank you, sir.
Thank you, sir. Thank you for your wonderful talk with regards to impact of CGM in type 1 diabetes, gestational diabetes, and glycemic variability. Thank you, sir. Thank you for the brainstorming session.
Thank you so much, sir. So now it's time for felicitation for the last session. I request Dr. Natarajan, sir, to stay on the stage. I request Dr. Arunachalam, sir. I request Dr. Rajesh Babu, sir, Dr. Alan Bini, sir, Dr. Balamurugan, sir, and Dr. Anand, sir, for felicitation. I also call upon Dr. Madhavan, sir, Dr. Sairam, sir, Dr. Suresh Kumar, sir, and Dr. Sangamitra ma'am to hand over the mementos. I request Dr. Madhavan sir to hand over the mementos to Dr. Rajesh Babu sir. Dr. Rajesh Babu sir. I call upon Dr. Sai Ram sir to hand over the mementos to Dr. Anand sir. I request Dr. Sangamitra ma'am to hand over the mementos to Dr. Alan Bini sir. I request Dr. Suresh sir to hand over the mementos to Dr. Balamurugan sir. Thank you so much, everyone. We have successfully completed all the scientific sessions for today. So we are going to conduct a quiz team. Quiz
So
competition.
now, next quiz. See, only 13 participants, Abdiya. Huh?
20.
20
questions, 20,000.
20 participants. Huh? 1-5. 15 participants, 3 prizes. So the chance is higher. So let us start.
The registrations are still open. 20 questions, 20,000. And following the quiz competition, we'll collect the feedback forms from the delegates. Delegates, I hope everyone has received the OMR sheet. If someone hasn't, please raise your hand. Is there anyone else who hasn't received the OMR sheet? Okay. Has everyone received the OMR sheets? I kindly request all the participants of the quiz to provide their information on the OMR sheet. I kindly request all the delegates to come to the front. So do not discuss, do not use chat GPTs, do not use mobile phones. And it'd be better like if we can spread out. And post quiz, like all the delegates will be having a participation certificate. Thank you. And you can collect it from the comparing desk. So we are now going to start with this competition, ACCeSS 2.0, 2026 quiz. The time starts now. Each and every question will have 90 seconds to answer. So question 1, on post-operative day 1, following a major enterectomy, a patient with type 2 diabetes was mistakenly instructed to continue her dapagliflozin till the morning of the surgery presents with progressive tachypnea, nausea, and severe fatigue. Her capillary fingerstick glucose reads a misleadingly mild 154 milligram per deciliter, and arterial blood gas confirms a profound metabolic acidosis, pH of 7.18, bicarbonate of 11, with an elevated serum anion gap of 22. Large ketones are detected in the urine. What's the immediate priority in the managing this patient's euglycemic diabetic ketoacidosis? So let's move to the next question. A patient with type 2 diabetes on metformin, glimepiride, vildagliptin, and empagliflozin is scheduled for major elective surgery. What's the recommended perioperative medication plan? Question. A 62-year-old male with septic shock has a blood pressure of 88 by 50 mmHg and a heart rate of 110 beats per minute. His calculated diastolic shock index is elevated 2.2. Heart rate by diastolic blood pressure. What does a highly elevated diastolic shock index clinically signify in early septic shock pathophysiology? Next question. A 68-year-old man with urosepsis complicated by septic shock is admitted to the intensive care unit. He has received 30 ml per kg of balanced crystalloid and is receiving a high-dose norepinephrine infusion, titrated to maintain a mean arterial pressure of 68 mmHg. Despite achieving the recommended perfusion pressure target of mean arterial pressure 68 mmHg, his clinical condition continues to deteriorate. An invasive hemodynamic assessment demonstrates map of 68 mmHg and a central venous pressure of 18 mmHg. Pulmonary capillary wedge pressure is 20 mmHg and mixed venous oxygen saturation is 52%. Serum lactate increased from 2.4 to 4.8 millimole per liter over the past 4 hours. And urine output is still low and it's less than 0.2 milliliter per kilogram per hour during the previous 4 hours. A bedside echocardiogram is being arranged, but immediate intervention is required. Which of the following is the most appropriate next step to improve the systemic oxygen delivery and tissue perfusion? Go to the next question. A 67-year-old male with chronic heart failure with reduced ejection fraction, HFrEF, is hospitalized for acute decompensated heart failure, ADHF. He is initiated an aggressive intravenous furosemide diuresis. Over 72 hours, his weight decreases by 4 kilograms. His signs of systemic congestion is clear, and his hematocrit raised from 38% to 42%. However, his routine laboratory panel reveals an increase in serum creatinine from a baseline of 1.1 milligram per deciliter to 1.5 milligram per deciliter. The patient is hemodynamically stable and completely asymptomatic. What is the most appropriate interpretation and management strategy for this worsening renal function? Evidenced by the rise in creatinine. Let's go to the next question. A 70-year-old female with history of heart failure with preserved ejection fraction, HFpEF, is admitted with anasarca and severe diuretic resistance despite receiving continuous infusion of high-dose intravenous furosemide. Her 24-hour urine output is less than 600 ml. The clinician suspects that an adaptive structural change within the nephron is driving this resistance. Adding which of the following agents to block the distal connective tubule represents the most appropriate pathophysiological step to re-establish diuresis? Next question. Which of the following formulas correctly describes the calculation of renal perfusion pressure, highlighting why an elevated CVP directly impacts the glomerular filtration rate in patients with severe cardiorenal syndrome? A 65-year-old male with an ischemic cardiomyopathy, LV ejection fraction is 30%, and a stable chronic kidney disease, baseline creatinine is 1.4 milligram per deciliter, is being managed for a mild heart failure exacerbation. He is currently taking sacubitril valsartan, metoprolol succinate, and spironolactone. During optimization of his intravenous loop diuretics, A laboratory check shows a serum creatinine of 1.7 milligram per deciliter and a serum potassium of 4.8 equivalents per liter. How should his GDMT be managed in this scenario? Let's move to the next question. A 72-year-old female with severe chronic corporal pneumonia secondary to advanced COPD presents with worsening anasaka, tins ascites, and profound jugular venous distension. On admission, her baseline serum creatinine is 1.2 milligram per deciliter. She is started on continuous intravenous furosemide. Over the next 3 days, her systemic condition minimally improves, but her serum creatinine rises sharply to 2.4 milligram per deciliter. A bedside point-of-care ultrasound assessment reveals a grade 3 Bixer score showing severe pulsatility in the portal vein and a completely reversed monophasic flow pattern in the hepatic veins. Which of the following strategies represents the most sound other physiological approach? The next question. A patient with NSTEMI has a heavily calcified balloon undilatable coronary lesion. Which statement best describes the excimer laser coronary angioplasty ELCA? Go to the next question. A patient with suspected HFpEF has a LV ejection fraction of 54%, borderline left atrial enlargement, E by E dash is 11, and a mildly elevated NT-proBNP. Resting tests are inconclusive. What's the next best step in diagnostic approach? To the next question. What's the role of beta blockers in patients with classic HFpEF who have no other indication, example recent MI or atrial fibrillation? Move to the next question. A patient with obesity, BMI of 42 kilogram per meter square, and HFpEF has low BNP and NT-proBNP, despite clear heart failure. What best explains the low natriuretic peptide levels? Go to the next question. A patient with symptomatic HFpEF, LV ejection fraction of 58%, CKD, EGFR shows 38 milliliter per minute to 1.73 meter squared, and elevated NT-proBNP level is treated with the loop diuretic. Which therapy should be added to reduce heart failure hospitalization and cardiovascular death? Go to the next question. A 64-year-old man presents with sudden onset right-sided weakness and aphasia. The exact time of symptom onset is unknown because he was found on waking. MRI brain shows a hyperintense lesion in the left MCI territory on diffusion weighted imaging, DWI, while the corresponding area is not hyperintense on FLAR imaging. What's the most appropriate interpretation of this DWI FLAR mismatch? So we'll move to the next question. A 72-year-old man with hypertension and type 2 diabetes presents to the emergency department with sudden onset of right-sided hemiplegia and global aphasia. His NIHS score is 16. Non-contrast CT brain shows no intracranial hemorrhage. Early ischemic changes were noted in the left insular cortex and left lentiform nucleus only, giving an aspect score of 8. CT angiography demonstrates an occlusion of the left proximal middle cerebral artery, M1 segment. What's the most appropriate next step in the management? Next question. A 68-year-old man presents with an extensive anterior ST elevation myocardial infarction complicated by cardiogenic shock. Despite successful primary PCI and high-dose vasopressors, he remains hypotensive. Echocardiography shows a LV ejection fraction of 15%, but the right ventricle is normal in size and function. TAPC is 20 mm. The shock team decides to implant an impeller CP device. Over the next few hours, his cardiac output and blood pressure improve significantly. Which of the following is the most important prerequisite for optimal hemodynamic benefit from impulse support? Go to the next question. A 70-year-old man with acute anti-ash elevation, myocardial infarction undergoes successful primary PCI. He remains in cardiogenic shock and is started on norepinephrine, titrated to maintain a MAP of 70 mmHg. His blood pressure is 98/62 mmHg. His heart rate is 128 sinus tachycardia. Cardiac index is 1.8 liter per minute per meter squared. Serum lactate is 4.2 millimole per liter. And urine output is 15 milliliter per hour. Echocardiography shows a LV ejection fraction of 20% with no significant right ventricular dysfunction. The treating residents suggest adding dopamine because the patient remains in shock. Which of the following is the most appropriate next step? Let's move to the next question. A 48-year-old woman with poorly controlled diabetes presents with persistent vomiting, abdominal pain, and dehydration for 2 days. She is tachycardic but normotensive. Arterial blood gas, ABG shows a pH of 7.4, PaCO2 of 40 mmHg, and bicarbonate of 24 milliequivalents per liter. Serum electrolyte sodium is 140 milliequivalents per liter. Chloride is 92 milliequivalents per liter. And bicarbonate is 24 milliequivalents per liter. Serum ketones positive. What's the most appropriate interpretation of the acid-base status? We'll move to the final question. A 62-year-old patient with type 2 diabetes on premixed insulin has a 14-day continuous glucose monitoring report showing time in range is 68%, time below range is 2%, and a coefficient of variance is 42%. What's the best interpretation and management? Thank you, sir. Thank you. I request the delegates to hand over the OMR sheet to the organizing committee members. Now I call upon volunteers from the delegates to deliver a feedback about the session. Any volunteers? Any volunteers for feedback?
Volunteers, please give your valuable feedback. It will be surely useful for us to improve our performance in the upcoming sessions. And also it will be a motivation for the organizing team and those who involved in this program. So please give your valuable feedback. Any 2 members, 2 or 3 members? Volunteers, please give your feedback.
செஷன்ஸ் எல்லாமே நல்லா இருந்தது. எல்லாருமே நல்லா டீச் பண்ணாங்க. டைம் மேனேஜ்மெண்ட் மட்டும் கம்மியாக இருந்த மாதிரி இருந்தது. நடராஜன் சார் வந்து கிளினிக்கல் கேஸ் டிஸ்கஷன் அந்த மாதிரி பண்ணினா நல்லா இருக்கும் ஃபீல் பண்ணேன். ஃபுட்டு நல்லா இருந்தது. செஷன்ஸ் எல்லாமே நல்லா இருந்தது. டைம் வந்து கொஞ்சம் கம்மியாக இருந்த மாதிரி இருந்தது எல்லா செஷன்ஸ்க்கும். வென்யூ நல்லா இருந்தது. டாபிக் செலெக்ஷன் நல்லா இருந்தது. கிளினிக்கல் பேஸ்டாக ஏதாவது ஒரு இது நடராஜன் சார் அவங்க படிச்சிருந்தாங்க. கிளினிக்கல் பேஸ்ட் டிஸ்கஷன், கேஸ் சினாரியோஸ், கேஸ் ப்ரெசன்டேஷன். வென்யூ நல்லா இருக்கு, ஃபுட்டும் நல்லா இருக்கு.
Just a minute. Excuse me. Hello, one just.
Watching your program on the online, sir. It was wonderful, sir. Almost you cover all the topics, not only cardiology, every topics, which is very much useful for our day-to-day problems, sir. Well arranged, sir. Good commitment. Continue, sir. Best wishes.
Thank you, sir. Thank you, sir. This is retired Professor HOD Rajan, sir, Thuthukudi Medical College. He was not able to come, personal reasons, so he watched online this program and gave this.
சிஜிஎம் பற்றி லாஸ்ட் செஷன் ரொம்ப இன்ஃபர்மேட்டிவாக இருந்துச்சு. லாஸ்ட் செஷன் ரொம்ப நியூவாக இருந்துச்சு, நிறையா அதை பற்றி கற்றுக்கிட்ட மாதிரி இருந்துச்சு. மெனு ஃபுட் எல்லாமே நல்லா இருந்துச்சு. கேஸ் பேஸ்டு டிஸ்கஷன் இருந்துச்சா இன்னும் நல்லா இருந்தது. இருந்துச்சு. கேஸ் பேஸ்டு டிஸ்கஷன் வித் மச் மோர் இன்டராக்டிவ் செஷனாக இருந்துச்சா நல்லா இருந்தது.
குவிஸ் வந்து ஃப்ரண்ட்ல ஸ்டேஜ்ல கூப்பிட்டு ஒரு டீமா வச்சிருந்தாங்க நல்லா இருக்கும்.
Hello. Yeah. So now it's time for the results. Third prize winner, and I call upon Dr. Suresh Kumar sir to provide the cash prize for the third prize winner. Is Dr. Oris Subiakshya. MD General Medicine, postgraduate, Thoothukudi Medical College. I also request Dr. Arunachalam sir to join us. So now I call upon Dr. Madhavan sir to hand over the cash prize to the second prize winner of the quiz competition. Is Dr. Reshma Priya. Thoothukudi Medical College. And now at last, finally, I call Dr. Suresh sir, Dr. Raman sir, and Dr. Madhavan sir to give the first prize. And the prize goes to Dr. Bhagyalakshmi, TVMC, Tirunelveli Medical College. And now I request Dr. Arunachalam Sakyapan sir to deliver the vote of thanks.
So, first of all, it's a great academic event. The two in Tuticorin, because initially they say that it's very difficult to pull crowd for the thing, but still the hall is 75% full. And really, I thank all the delegates for making this event a big success. And I thank all the speakers who come across from Bangalore, Chennai, Trichy, all those traveled all the way here, and especially chairpersons and moderators who spare their time in spite of Sunday. And also I should thank our team, this digital team by Shan, making it hassle-free. And I should thank the industry, pharma industry especially, who supported, without whom it cannot be happen. Say this Sun Pharma people were fully with us, entire making the from day one onwards, planning everything. So a big hand to Sun Pharma. And also the USB, Lupin, Alchem, and every people also contributed for this conference. And I should also thank my Aruna Cardiac team, who are all the, General Manager Manogar, HR Uma, and Anisha, all Malika, everybody, and my biomedical engineer, everybody who worked planned this as a very thing. Last but not least, I should thank Mr. Raman, who took all the efforts, choosing from the venue to the menu to everything. And without him, I should also thank my ACC marketing team, Dr. Murugan and his team, who could meet all the doctors and fill the Google forms and get all the things and here. So if at all, and I should thank Satya Resort people, especially the manager who was fully cooperative with us and who could do all the whatever the last minute, for example, to the lunch, we had some deficits, he could make it back. So I thank the management, the Satya Resorts, for giving this wonderful venue and making a good food and stay place. And if I would have left somebody, so I thank one and all and our photographer, all the people who are with us and made it a big thing. So and also thank API Tuticorin Pearl chapter, especially Dr. Rajavel and Dr. Meenakshi Sundaram, and who also collaborated with us, and Professor Ratna Kumar from Tirunelveli Medical College, allowing postgraduates to come here. So I thank everybody who made it this big event, and the mastermind behind all this event, the managing director, Dr. A. Swarnalada, Aruna Cardiac Care, who is the final main organizing mind behind this event. So she is not here. Anyhow, I convey thanks to everybody and who left also. Thank you all. Let us have such good meets in future also with the help of Almighty. Thank you. Thank you so much. Photos. Okay.
I request the participants to stand up for the national anthem. Thank you, everyone. The delegates can collect the certificates from the head of the departments. The certificates will be handed over to the head of the departments.